I miss my homeland, and I regret being ever apart. And oh, I miss the sunsets, they're all forever in my heart. Wind blowing through my hair, blowing leaves everywhere. Ocean so blue like the sky, filled with life like you and I. How could I forget the good times of living in paradise? And oh, I miss my homeland, and I regret being ever apart. And oh, I miss the sunsets, they're all forever in my heart. And oh, I miss my homeland, and I regret being ever apart. And oh, I miss the sunsets, they're all forever in my heart.
Looking back when I was a young boy, I thought I knew it all. But the moment I laid my eyes on you, I became a man. I would throw a coin in the jukebox. Johnny could sing my favorite song. Under the boardwalk, feel the air, we'd all be singing. Everybody singing. Happy days with you and the gang. Now I'm still dreaming. Back then we were ruling the world. No time for sleeping. Happy days will never run dry, just as long as you're with me. We can go on ruling the world. Happy days never end. Ooh, now that we made it together, our love is stronger now. Even though faces keep changing, we've got each other. Happy days with you and the gang. Now I'm still dreaming. Back then we were ruling the world. There's no time for sleeping. Happy days will never run dry, just as long as you're with me. We can go on ruling the world. Happy days never ending. And over it gets sweeter, loving you gets better all the time. Ooh, no, no, no. I'm so glad we're still together. Every time I think of you, I smile. Ooh. Happy days with you and the gang. Now I'm still dreaming. Back then we were ruling the world. There's no time for sleeping. Happy days will never run dry, just as long as you're with me. We can go on ruling the world. Happy days never ending. We can go on ruling the world. Happy days never ending. Ahalo. Oh my lover. Say my mama, hey, hey. My lover. Ahalo. Oh yeah. Champagne on ice. Cuban cigar with a spice. Suit in the chain, boots in the rain. Lean back, watch she tangling. Mustang on fleet. Bang bang your cheek. Bang. Putting in the cane, so I'ma get a tang. Lean back, watch she tangling. She acts like a movie star. Take me to Jupiter. Couldn't get my eyes off of you. When the bomb shake, oh no no. She act like a movie star. Take me to Jupiter. Couldn't get my eyes off of you. You got me sober under the cover. Oh my lover. Oh my lover. Oh my lover.
Come and give me that sweet papaya. Let me eat it like rice and tayo. Come and work that thing, mama yo. Drop that thing, mama yo. Oh.
Drop it down, work it slow, grind it on and on, till they done. Right na na na. Whoop, whoop, scoop.
She act like a movie
She
star.
act like a movie star.
Take me to Jupiter. Couldn't get my eyes off of you. When the bomb shake, oh no no. She act like a movie star. Take me to Jupiter. Couldn't get my eyes off of you. You got me sober under the cover. Oh my lover. Oh my lover. Oh my lover. You got me sober under the cover. Oh my lover. Oh my lover. Oh my lover. You got me sober under the cover. Oh my lover. Oh my lover. Oh my lover.
Música malie awe fefe mana ya sivae. Música malie awe fefe mana ya sivae. Usumana bese malie. My atata, my siva siva, my pata pati, my oso oso. Yeah, ni malunga ai awale pa o. Nesong ai miti falo no. Awala ete isai pale. It's a day that my Mexico.
Kia ora tātou, Nisa Bula Vinaka nā turanga ki nā marama. Whakalofalahi atua, ki mo tolu osi. Kia orana tātou kātou toa. Aloha mai kākou, Nisa Yandra Vinaka, and a warm Pacific greetings. Welcome to the Fale. Good morning, Professor. If you can please find your seats and we will commence our polo kalama. But warm Pacific greetings to you all up the wās. It is so great to see you all. My name is John Pulu, and I'd like to firstly acknowledge our Heavenly Father for this wonderful occasion, minus the weather. But in the Pacific, when it rains, we call it a blessing. But if I get pneumonia after this, it's a curse. I'd also like to say a big thank you to the team for inviting me. They could have got an AI to do the MC, but they got a PI. Thank you so much. I worked on that one by myself. That's Pacific Islander. That's an acronym for Pacific Islanders, not a private investigator. You alligator. Give me the calculator. Okay, we get it. You can do poetry. My name is John Pulu. I'm delighted to be here today, to be amongst this wonderful group of people, wealth of knowledge, and we will be sharing and hearing a lot about what you do with the many guests that are here today. But in our Pacific way, we start with a lotu, and I'm delighted to invite Reverend Inga Sitama Mokole to come forward. And I was worried because they said if he wasn't going to be here, I was going to do the prayer. And then soon you'll have thunderstorms. So thank goodness you're here. So Reverend Inga Mokole, Mālō apito for starting us off.
God is always good. He always provides. So I saw him walk past and I've just come down the steps and I said, I'm safe. I'm not late. Anyway. Monu mitaki tungi e whakalofa hea tua. Hohofi mai. E hawa anga ngatapu e tua. Whalataha mai mo mautoru ke he pongi. Greetings in the name of our Lord Jesus Christ. Let us pray. Fufonga mai ko ia tua ke he haa mautolo a whaia ngā hau nei. Ke ia mō tākinaki e haa mautolo a tau pulotu mo tau loto matala. Ke tufa ai ko ia tua. Lord God, we give you thanks and praise for this time and this place. An opportunity for us to gather together and to share wisdom and knowledge in your holy name, O Lord. The scriptures I have for you this morning, if I can get to my technology. Proverbs 18 verse 15, it says, the heart of the prudent acquires knowledge, and the ear of the wise seeks knowledge. In Niuain, ko loto he tangata pulotu, ko maua e ia e ilo. Ko tau selinga foki he tau tangata kua ilo. Ko kumi ia ke he ilo. So the little reflection for you for the day. A symposium is more than a gathering of speakers. It is a collaborative pursuit of truth and progress. This verse highlighted two essential postures for any successful academic or professional: exchange a willing heart and a listening ear. True innovation happens when we approach new ideas with humility. The prudent heart does not assume it already knows everything out remaining actively open to growth. Similarly, the wise ear doesn't just listen to reply, but listen to learn, absorbing insights from diversity perspective. As you engage in today's session, let the scripture challenge you to be active seekers of knowledge. May your discussion be shaped by your listening intentional, and the insight gained here lead to meaningful action in your field. Let us pray. Let us bless our gathering. Dear Lord, we thank you for the gift of this day and for gathering us together for this symposium. We are grateful for the diverse minds, talent, and experience present in this room. As we share ideas and learn from one another, we ask for your guidance, grant our speakers clarity of thought, and bless all who are listening with open mind and receptive hearts. May our discussion be rooted in respect, collaboration, and sheer desire for growth and innovation. Pena ha mautoro ata manako mo te ole ki mua hau ke hatua ke pongi. Kia tākele a mautoru mo koe mo mautoru ke he kamata ai nei a to hoko ke he tukurangi. Amen. God bless us all.
Whakawelahi, thank you very much to Reverend Mokole, who is the minister at the Holy Trinity Anglican Parish of the Promised Land, Otahuhu. So whakawelahi mahaki, thank you very much. I'll see you at church on Sunday. Maybe church choir. Ladies and gentlemen, Madame, Monsieur, before I continue, I'd also like to warm welcome to everyone that's tuning in online as well, online. So that's my mother and my neighbor who's watching in. How's it going? What's up? Yes, I will bring the milk and bread after work. But before we continue, aroha mai, I'm going to just quickly go through some of the house rules before we continue with our welcoming remarks. I'd like to go through, firstly, tulo watu, kere kere. If you need to use the lavatory, as we say in France, you may find them located on this side. Whamole kere kere, ka takipe. There will be no smoking, vaping inside or around the Fale. Also, there will be no breathing as well, if you can just do that quietly, please. No littering. Also, in case, in the unlikely event of an emergency, the team will evacuate everyone out of the Fale and the Fale crew, but just meet out here, and then I'll direct you to the nearest Valentine's or KFC. Safety measures, of course. But we are now going to hear from the remarkable Professor Sir Colin Tukuitonga. Professor Sir Colin Tukuitonga is the Director of Te Poutoko Akiwa and the Associate Dean Pacific of the Medical and Health Sciences here at the University of Auckland. Ho mai te paki paki for Sir Colin Tukuitonga.
Whalawhalahi atu nisam Bula Vinaka Talofa lava Mālō e lelei ki Orana. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Metua Bates from Rarotonga was the first person here this morning, early, while you guys were still negotiating with the weather, I think. The second thing I'd say would be I'm Niuean, and Niue is drought prone. Small island in the middle of nowhere. When it rains, it's a blessing. It doesn't matter what happens, how much of it is. When you get rain, you should be pleased. So, John, you're right. It's a blessing. Welcome, all of you. Very nice to see you all. And also to the folk online, nice to have you. This is our annual event. We haven't, I'm not sure that we've got the formula right yet. If you look at the program this afternoon, it looks a bit ambitious, would be how I would describe it. So I just appeal to the speakers to respect your fellow speakers and keep it brief, keep it tight, keep it clear. 2-3 messages that you want people to take. It is an ambitious afternoon. The problem we have is, of course, there's lots of interest. And when you invite people to send in abstracts, you have an obligation to give people an opportunity to share their story. And so you end up with lots of people, and then we don't really want to exclude some people. So they're in a challenge for the afternoon. I reckon it'll keep you awake. So 4 concurrent sessions. Concurrent sessions enable us to have more people speak. But of course, you have to make a choice, and you're going to miss one or the other. So that's the afternoon. But this morning, of course, some fantastic presentations and discussions. We have, for the first time, real opportunity to eliminate cervical cancer. And for those who are unaware, cervical cancer is one of the 2 most common malignancies for women in the region. And so the prospect that we can eliminate cervical cancer is exciting, I think. We've just got to kind of come together and align our hopes and work and so on. And so you'll hear more from the experts on that probability, prospect. There are countries, of course, who are already showing positive signs of progress. So I'd like to think that this is something we can do and should do with our relatives and colleagues in the islands, and you'll hear more about that. You'll also hear from colleagues about the development in promoting excellence in science and the work of the Science Academy. Rowan is here from Apia. Again, that's an exciting development. I think we've been relying on other people generating the knowledge and interpreting the data for us. I think increasingly, clearly, we want to do that ourselves with other people, no question. So some very interesting sessions for you. And again, I want to thank you all for coming today. And if you have a chance, say thank you to Lois and the team at the back who bring it all together. If you have any complaints, I'm the person to talk to. So have a fun day, learn lots. We've got a terrible political environment in Aotearoa, absolutely dreadful. And one of the things we have to do as a community of practice is to stick together, use the science, and share the knowledge. That's the only thing we have. Because you will have seen some terrible decisions made in recent times, not based on evidence or data or common sense even, but based on what appeals to the sponsors of our political leaders. So that's all the political statement for today. Have a fun day, everyone. Thank you very much.
Whakawelahi maha ki Mālō Pito, Professor Sir Colin Tukuitonga. Thank you very much for that. And as you heard, he said, keep it tight, a bit like my shirt, a bit like my budget. So welcome once again, distinguished guests, ladies and gentlemen, and everyone tuning in online. We're now going to hear from our keynote speaker, Dr. Ai-Ling Tan. She is a senior gynecological oncologist and senior academic at the University of Sydney, Australia, working with the Elimination Partnership in the Indo-Pacific for Cervical Cancer, EPICC program to strengthen women's cancer care across the region. Hope mai te paki katak mo. Paspasi mai, Dr. Ai-Ling Tan. Mālō.
Thank you. Just bear with me. I've got technology. I've only got 2 hands, and I'm trying my very hardest. So just bear with me for 2 minutes. Oh, I can use this microphone. Okay, thank you. Well, Bula, Talofa, Mālō, lelei, kia ora. And I'm going to put my part in it, which is selamat pagi, which is good morning. And obviously, EPIC also has involvement in Indonesia, Malaysia, and Timor. And I'm really grateful to be here. I'm a bit intimidated by all the leaders and the researchers. I'm a clinician. I work in the field. So it's an honor to be with you today. Last week, I was in the Western Highlands, and I was wondering whether any of our friends here from Papua New Guinea. And earlier in the month, I was in Timor-Leste. And in recent months, I've been obviously traveling the Pacific along and working along colleagues in Samoa, Tonga, Vanuatu, and Solomon Islands. The geography is different. The culture is different. The health systems are different. But the conversations are remarkably the same. And it's about how we access timely diagnosis and treatment for our women. We're talking about gynecological cancers here. How do we build local capacity, local expertise for women so that their care can be closer to home? We need clinically safe environments, we need sustainability, and how can we do it equitably? Over the few decades, I've learned that actually it's not about a single operation, a single procedure, or a single group. It's about all of us coming together, and that's why I've decided today I'm going to tell a story about people, partnerships, and pathways. So I'm going to start off with this. Okay, obviously, didn't get the technology right. I'm going to start off with this slide. It means a lot to me, this slide, and I'm going to share the story with you. One of the women's from Fiji, the other one's from Papua New Guinea. They live in different countries, but different stories, but they remind us why what we do matters. Cervical cancer is one of the cancers that is both preventable, treatable, curable, when it's detected early. So let me ask you a question. Why is it that a woman who lives an hour from Cairns in Papua New Guinea or 3 hours from New Zealand in Fiji not have access to care? Why should geography determine survival? More than any other cancer, cervical cancer is a cancer of inequity. And in my 20-odd years in the Pacific, and I met Sarawia in Fiji, and her story has stayed with me ever since. And also, it is a pledge that we have made together. She says, Dr. Arling, you tell my story, and you make sure that nobody else in the future goes through what I've had to go through. And today, changes have progressed, but our challenge still remains the same. Geography should not affect survival. So, in terms of why is this happening, I think in the Pacific, there are some Pacific realities we have to accept. That of geography. If you're in the highlands of Papua New Guinea, in the Western Highlands, I've just visited it for the first time, you actually can't get to Port Moresby unless you go on the plane. So how are patients going to get transferred? We know of our workforce shortages. And we know that the burden of disease is going to be increased by 50 to 100% by 2040. So the challenge, there's commitment around the region. The challenge is not commitment, it's access to care. And I think that it is also, when we have extraordinary need, we also have extraordinary opportunities. My disclaimer is the people on this slide, the people that I know. There are lots of people doing really good work that I don't know of or I've never been in contact with. So please, if you are, don't complain about me. I know and appreciate everybody's work, okay? My journey began in the Pacific about 20 years ago, and it's not about programs. My journey began with people. I've got friends, colleagues, clinicians, and people who are committed to improving care for women. And every photograph represents for me a relationship that I've learned from and how it's changed how I think about women's cancer care in the Pacific. From Fiji to Niue to Samoa. This relationship shaped how I came to understand what the realities are in women's cancer. And what I'd like to applaud these people on this is the fact that they're clinicians, they're educators, but they had the vision to locally train their specialists in the University of Papua and the Fiji National University. And by doing that, we have been able to retain the specialist workforce, and we know that 85% to 90% have stayed in the region. So good on them. And some of them are my personal friends. I mean, when I started off as a junior registrar, I did know nothing, and my colleagues and friends from the Pacific were the ones I rang up to ask for help, even though they were my residents. So I am deeply grateful, and for me, that's always a connection for me. So in terms of partnerships, I think this is really important because you can't do the work in isolation. We all work together, whether you're ministry, professional bodies, regional universities, as well as global partners. We all have a role, and we're working towards a common goal. So some might provide funding, some might provide surgical capacity like we're doing, some might do screening, some might strengthen systems, and some obviously look after the governance. So for us, everybody is in it together, and the disclaimer, once again, if I forget to put anybody, it's not because you haven't done any work. So the next, it's about the Pacific capability, what we've learned in the years that we have been trying to teach and train. Traditional models, which I really, really do not like, rely on visiting experts. People come in, they fly in, they come with their team, they do their work, they feel really good about themselves, and then they leave. And we have also short workshops. I mean, short workshops basically just provide observers. They don't actually, that's not sufficient. So I think what really works is you're investing for the long-term longitudinal mentorship, I think is really important, and competency-based training and regional support. And that's what we're trying to do with the Gynae Oncology training program with IGCS. We have virtual teaching. They're trained in-country as a hybrid program. We have hands-on surgical training during the time that we will go 3 or 4 times a year. We've got multidisciplinary meeting, as well as we provide ongoing support. Our relationship is lifelong, essentially. And we have a great community of practice that's starting to happen. Of course, once again, we come to people. You can't do that without people. You know, what the great things about women's health is that the clinicians and their willingness to teach, to mentor, and support colleagues from across the borders. And I'm just showing that. We also need local supervisors, the likes of Dr. James Wong in Fiji and Dr. Arthur Elijah in Papua New Guinea. So it's really important that we do have a combination of local and international mentors, and that's how we work. That's the model that we would use. So I'm just going to briefly talk about IGCS, which is the International Gynecological Cancer Society. And we run 2 programs. One is for the Global Fellowship for Gynecological Cancer, and the other one is the pre-invasive, obviously talking about cervical cancer. You need to be able to treat who you screen. There's no point to screen if you can't treat them, right? So that's what we've developed. And the principles are the same. It's about local capability, it's about ongoing mentorship, and quality assurance for us is really important, and sustainable service. So it has to be locally led and in the country, clinically safe. And the difference in the 2 programs is where the woman enters the pathway. If the woman comes in as invasive disease, and the invasive program is not just about cervical cancer, we're treating all gynecological cancer. So we're using whatever funding we have to do the training that actually affects more than just cervical cancer patients. And so this program basically has transformed our thinking from episodic teaching to longitudinal mentorship and involvement. Next, I'm going to, just discuss with you, this is our fellowship program. It's a busy slide, but I'd just like to share with you a story, because I like to tell stories. So the guy up at the top is Professor Michael Quinn. He's a very famous gynecological oncologist. He was my professor, and I used to moan to him a lot, because I used to spend a lot of time telling him about the Pacific. and the challenges faced by the women, because they didn't have access to care, and you were the president, so can you not do something about this? So I think he got a bit, so I nagged him in. And the thing is, I was thinking of the Pacific. I was very narrow in my level of view. I was thinking about my region, and he was actually thinking bigger globally. And the result was the IGCS Global Gynae Oncology Fellowship Program for low middle income countries. So what began as a vision to support countries with very limited access to specialist training became a global program that was based on longitudinal mentorship, local ownership, and training specialists where they live and work. It's always good to introduce our team. I like to embarrass people, so I made all of them put their little pictures up. So this is the current fellows we have. We've got Dr. Nanisi Sakiti from Fiji, who's graduated, and now we've got Una Tabiosi from Fiji. Robert Jones, who's the president of the ONG Society in Papua, and he's the first fellow from Papua. And Dr. Ben Coati from Solomons. It has been a challenge. Dr. Nanisi Sakiti, who's not here, we had to go through Parliament to get approval to train. Papua New Guinea had a few challenges. It took us 2 or 3 years to get Robert, but we're going to onboard another person in Papua New Guinea and maybe in Solomons. And the joke amongst everybody is that I'm a marketing manager, because every time I train someone, I say, can we do someone else in the year? But it seems to work, so we are going to proliferate, and that's really great. So we also do recognize the need that countries have who do not have the population, the infrastructure to support gynae oncology training. So we're looking at the next level of surgical upskilling, but we like to do that in a very structured way rather than ad hoc way. So countries like Samoa, Vanuatu, Tonga, who we are supporting to some degree, and that's through the New Zealand Medical Specialist Service abroad. So when we talk about surgical visits, look, I'm a surgeon. We love being in theatre. That's our happy place, all right? But unfortunately, visits are not just about happy places. It's about building systems, and it's about also talking to the local team about implementation, about cancer management pathways and referrals. But it's really always the same. It's always about basically empowering local teams to develop their capability, confidence, and systems. The idea is that they deliver care independently, because sustainable cancer care is not just about one procedure. It's actually about skills, services, and knowledge by everyone, and we develop that together. So that's our visits, and you can see Dr. Michael Burling visiting PNG, and I was in Samoa with Silipa, and so those are some of the visits. We also have workshops. This is for the pre-invasive part, where normally what happens is after online training, they do have to go to a workshop, and traditionally it's run by IGCS in far-flung places of the world that it's so expensive to get to. So what we've done is that with the Malaysian team, brought it to the Pacific. So now our training, we're doing it at the PSRH. We've done it in 2024. We're going to do it in Tonga again this year, and just to bring it in. So we're now accredited, and they actually recognize that we can actually provide the training. So that's really excellent for us. And also we have a bit of fun. When we went out to dinner, the team said that their stomachs were expendable, Eileen. So they were expendable. But we also had multidisciplinary meetings. We have two pathways for that, and that's where we have our medical oncologists and all our radiation oncologists, everybody in there to help with the IGCS fellowship training. We also have developed one for PSRH for all the Pacific population and countries that do not have access to gynae oncology care. So we do that once a month, and it's really great because we have every specialty, and we managed to get that on a monthly basis, and it's worked really well. Countries can present cases that they have issues with. And Susan, who you see there, she has the most difficult job as the program manager. She hurts everybody, like people like us who forget to sign our logbooks for the fellows, or fellows who don't put their entries in. You know, the usual. People who do this work know that they're really, really important. Now, my next slide, I'm going to show a film, and I think they're going to show it from the back. I think that rather than hearing from me, you should hear from someone who represents the future of women's cancer in the Pacific. We're very lucky to be picked, Fiji, to be picked by BBC in their series called Rewriting Cancer. And I thought, the voice should be Nanisi Sakiti from Fiji. Can we do the that, please.
What motivates me in what I do? What motivates me in what I do is that, oh goodness. What motivates me to do what I do is seeing women, or Fijian women, that are dying of diseases that can be treated. And it makes me want to do more for them. I'm getting emotional. Yeah. Fiji is a small island nation in the South Pacific. We say Bula, which means hello, which means welcome, and also it means life. I'm a single mom. I live with my daughter. She's 6 years old and she goes to school close by to the hospital. I also live with my grandnephew. I'm the first International Gynecology Cancer Society trained gyne-oncologist in Fiji and also in the Pacific Island as well. It's a Tuesday morning, so what I usually do on a Tuesday morning is grand ward rounds. This ward is not only cancer patients, but also other patients that are admitted under gynecology. We still have a large number of women that's been diagnosed with cervical cancer that are dying at the treatable stages of the disease. This lady has endometrial cancer that we are planning to operate on tomorrow. When I do my master's, I started looking after gynecology, and then I realized that when I worked in New Zealand, they have a gyne-oncology unit. Here in Fiji, we don't. One of the big hindrances that we have is that we do not have the standard treatment, which is radiation treatment. We need more people to be trained. We need resources to be able to put forward for these people to work with. I heard about the International Gynecology Cancer Society Fellowship Program. I was the first one to lift my hands up that I was interested in getting trained. And that's how I met my mentor, Dr. Eileen Ten. Just have to consider having a hysterectomy so that we can control her bleeding and continue. I think I've said it to so many people. I've even said it to friends that she's the person I would like to be when I grow up.
She's gonna cry. She's gonna cry. Salipa and you are the worst.
I know.
You always make me cry the two.
We must be Fijians.
There are 5 different women's cancers. So it's really important that you train someone that is able to provide comprehensive cancer care. The principles and standards of this fellowship is exactly the same as what we would do in Australia and New Zealand. What is different is that it's hybrid in nature, and the fellow stays within their own country with visits from international mentors and also trained by the local supervisor, and that the training is adapted to the resources and infrastructure and equipment available to them.
And welcome to another Pacific Society of Reproductive Health multidisciplinary meeting. Today we've got 2 cases. One will be presented. I completed my fellowship program in 2022. And yes, definitely I still contact my mentors. I contact them, I think, every month when we do virtual tumor boards. The training doesn't only teach you about the pathology, it teaches you about passion, being compassionate towards your patient as well.
You see the evolution of the person in terms of their clinical judgment, their authority, their confidence, and the major thing for her, I think, is also the ability to advocate for patients. You want to train leaders for the community.
We are planning to do a hysterectomy, bilateral something. So I think we are good to start from my side. After I graduated from the IGCS, I've been part of the team that is trying to make a difference in terms of accessing standard care for cervical cancer.
The left one is going to be the most immune one. So that's the one that you need to.
I have been part of the team that actually had launched the HPV screen and treat program for Fiji. I also has been part of the team that has been in the discussion with regards to radiation therapy services. The main role of this IGCH fellowship is actually to build the gynae oncology unit from the ground up. Now I'm a mentor, and I'm mentoring Dr. Unaisi Tambua, who's a consultant at the Colonial War Memorial Hospital.
It's easy to just talk to her and she'll just either work-wise, clinical, whether it's personal, whether it's psychological, it can be very stressful. She's like overall the best mentor there is.
I think the program has been hugely successful and can definitely be replicated globally. They have 23 institutions utilizing the curriculum with 46 international mentors and 60 fellows that have graduated from the program. It is an ongoing, lifelong relationship, and I think that that's the beautiful thing about this program.
I've walked with women till their last days. When we lost the women, it impacts their family. I've seen sadness, I've seen frustration. We rely a lot on our mentorship program to being able to manage our patients. But I'm hoping that one day we will have a group of our very own that can do this.
What you've seen is actually an outcome of more than a decade of partnership, mentorship, and commitment. And more importantly, it is actually showing Pacific leadership is not a future aspiration. It is already happening. Nanisi's story is inspiring, but it's not unique. It demonstrates what can happen when countries invest in their own people. This is the next slide is to actually show you that a story we know. In the Pacific, the incidence and the deaths from cervical cancer is high. Let me just illustrate it with two stories. Gloria is a nurse from Papua New Guinea. She spent 3 months in Tasmania in a palliative care unit. She did not see one patient dying from cervical cancer, and she came back and said, "Is that possible?" Jane, who some of you might know, was the CEO at the Western Highlands. When she went and talked to women in Papua New Guinea about cervical cancer and asked for who has been affected by cervical cancer, women put 2 hands up. So that is the stark reality. Why is this the case? And WHO obviously is trying to do something about it. The strategy that WHO has about 90 vaccination, 70 screening, and 90 treatment targets can be said to be based on some assumptions. I think it's based on the model where you get continuity of care. It's actually based on available specialists, same-day diagnostics, women that can come back. That doesn't always happen in episodic care systems, And so we need to think how the pathway is designed. In our system, it's designed to optimize diagnostic certainty. We're really always we're very concerned about overtreatment. But in a Pacific setting, we have the same pathway, but it behaves very differently. The women do not return. We know that 80% of women do not come back after screening. Travel is difficult. And every step along the pathway means that the woman does not get treatment and treatment does not happen. So the pathway needs to change, which is why we're talking about same-day treatment where feasible with thermal ablation. This is about cervical cancer we're talking about. Follow-up is for specialists for complexity, and referral is a safety net. So we really need to minimize delay. We need to stop every multiple step for the woman to be treated, and so that we do not lose women to follow up. So that is our challenge that we've noticed in the Pacific, and obviously that is something we need to work with. What's exciting about this? This is just some clinics, the pre-invasive clinics in Samoa, Timor, and it's interesting to see the training to the services. In the last 12 months, clinics are emerging with local realities, local leadership, and local ownership. And it's happening in Samoa and Timor, and I'll show you the next 2 slides relating to Papua New Guinea. But clinics are not enough. Once again, I must stress, the completion of pathway to care is really important. I had the privilege of being to PNG for the first time and doing a Let's training for the week there. Capacity building in PNG is challenging, but the clinicians are amazing. They've traveled from New Ireland to Western Highlands, New Ireland being up at the tip, I think somewhere at the tip, and also Aotearoa to the Western Highlands for the training. And not only did they come, they brought whatever equipment we might need to use. And we're talking about colposcopes and LETS machines, which are not exactly sort of light things. And some of them traveled for hours. And also, you know, it was not the infrastructure that they had, it was their commitment. And it was the commitment to build services for their communities. Once again, the challenge is not commitment, it is access. And it was just great. And we had, I'm going to show you what the local team, so this is the first team that started the Screen and Treat program. Can you imagine, in the middle of Western Highlands, the most inhospitable place to start the program? But they did it. And I think if we don't focus on what's missing. You know, when I was in Samoa, I thought, oh, the clinic's a bit small. I went to Timor, oh, the clinic's a bit smaller still. I went to Papua New Guinea, it was like, you know, we were in a container. But it's not what they lacked, it's what they've achieved that is impressive. You know, faced with the geography, with workforce shortages, and any limited infrastructure, they adapted, they innovated. They were just amazing. They found the space, and the space was a container. The women waited in the bure next to the container, and they developed workflows. They had people with on data, they had a nursing team. The nursing team were excellent. They created a service. You know, training is important, but what ultimately training needs to do is to translate into care for women. Which brings us to the next most important question. What does a woman's journey through care look like? So when we talk about cervical cancer, people always focus on that a little bit, you know, screening, vaccination, treatment, but for the woman, it's actually the entire pathway, and the woman needs to go from one to the other. And the journey depends on workforce being available, equipment, governance, financing. If anything fails, the whole thing fails. So any break in a pathway actually represents to the woman might not get care. So I think that that's a really important thing to remember. And the challenge for us is not just to build programs, it's to build connected pathways so that the actual pathway enables the woman to easily complete that whole journey. Next, this is my little slide. Which I haven't shared. Sorry about that. We talked. So that was about the journey of the woman. And the next one is this slide, which I think is a really important slide, which is that when we measure programs, it's not like you've done 100,000 screening. Great, good. But what happens to the women with high risk? How many of those women completed care? That is, to me, is the most important. So elimination is not achieved when you have the policy being written, when a program is launched. It's only achieved when the woman actually receives treatment, the high-risk woman. Sorry, my slides are a bit... So how do we do that how do we ensure a woman living in Papua New Guinea does get the same standard of care? It's not centralizing service. We actually, if you standardize the care, but decentralize care, centralizing the standards. Women should be able to receive their care closer to home, but the quality of the care should not be any worse. It should be consistent. And we know people can provide those procedures independently and safely. We know that when specialists are scarce, governance is really important, quality indicators are important, and no one should work alone. So if you think of a clinician in the middle of an outreach clinic, but they're connected into their centralized standards. So no clinician is working in isolation. And we must measure outcomes. We should not measure activity. The team would like to apologize if this upsets anybody, but they're really keen that you get a look at our warped sense of humor. So at the Time magazine, that's when they were all training. So we have Dr. Talipa, who's in Auckland, Michael, who's from Tonga, but he's currently in Sydney, and the two guys, they're really good. They've been doing regular visits, and Dr. Nanisi, who we met. And for many years, women's cancer care relied heavily on external support. But the exciting thing for us is that we've got a new generation of leaders, of gynae oncologists, and they're trained within the region, and they're increasingly training others. And that's really exciting. They understand the communities, they understand the health systems, they understand the challenges far better than I would ever will. So I see my role is to support, to mentor, and to create opportunities. The future is very much Pacific-led. And last but not least, I think that for many years, people like to think that models of care from high-income countries to low-income countries works, but it doesn't. The Pacific does not need imported models of care. You need models that are actually designed around realities of the Pacific women and the Pacific communities. You need to understand the geography. You need to understand the culture. You need to understand the family, the workforce constraints, and the realities of daily life that they have. And programs must be built for the real patient journey, not around assumptions, not around institutions, not around funding cycles. And I think that in my recent trip to Mount Hagen, the team presented me with a bilum. I've never seen it, I didn't know it, and you apparently hang it in the front. And that is woven thread by thread, and reminded me of sustainable cancer care, exactly built the same way, not by a person, not by many people, but by a group of people with their skills, knowledge, and commitment. The Pacific already has people. We have partnerships, and pathways are starting to grow. So I think that today we can build Pacific models of care, clinically safe, locally led, sustainable, with people, partnerships, and pathways. Thank you.
Io. Please join me again in a round of applause for our keynote speaker, Dr. Ai Ling Tan. Thank you so much, Dr. Ai Ling Tan. Before you go, my dear, I have a little present here, just to show our sincere gratitude. It's the latest iPad that I stole from Kmart. Enjoy. Thank you so much. Another round of applause. Wonderful to hear the amazing work and see all our beautiful people doing incredible work in the region. So thank you very much for your advocacy and highlighting them in your presentation. All right, wonderful people. We're now going to move on to our first plenary session. And may I please invite Professor Robin Whittaker, who is a public health physician and adjunct professor with the Transform Research Centre in the School of Population Health at the University of Auckland. She is the Clinical Director HealthX at Health NZ and Chair of the National AI and Algorithm Expert Advisory Group. Ko iau mo paspasi mai, ho mai te pakpaki, pats mai for Dr. Robin Whittaker. Nice to see
you. Kia ora koutou, Talofa lava, Mālō lelei, kia Orana, Bula Vinaka. I can't put that anywhere. Greetings, and thank you all very much for this wonderful honour of being with you with the Centre's annual symposium today and being part of this kōrero. I was asked to talk a little bit around the potential for AI across the Pacific, which just seemed like an enormous topic for one pālangi in less than 30 minutes. So I'm going to slightly reframe that. So the perspective that I'm talking from, obviously, is that I'm a public health physician here in Tamaki Makaurau. I'm the chair of our National AI and Algorithm Expert Advisory Group within Health New Zealand and part of the WHO group on ethics and governance of AI in healthcare. And so what I thought I would do today, which I hope will be useful, is I'm going to talk a little bit about some of the examples of what we're doing with AI in Health New Zealand here across the country, what we've learnt about some of the pitfalls as well as some of the potential and the promise. I'll give you a little bit of a provocation about where this might be heading, and then talk about what we're doing to try and shepherd some of this AI in safely and securely and equitably, and how this might be useful, hopefully, across the Pacific. And I hope that you'll see that this, just as a start of the many conversations that we will all need to be part of to try and do this well for everyone. So that's my plan. So I hope that's okay. So, oops, I'll just go back there. So when we're thinking about the AI tools that we're using in Health New Zealand and in general, they kind of fall into three main buckets. So we have, the first one is around the kind of risk scores, the predictive analytics. The second one around machine vision, so this is like the radiology tools. And then the third around generative AI, which is really very different. So I'm going to give you some examples of each of these. So the first bucket is around the risk scores. So this is what you might call your really old-fashioned algorithms and analytics, AI analytics, that's been around for a very long time. We've used it in lots of different ways. The example I like to give here is what we did during COVID. So there, when we saw that the Omicron wave was coming towards us and we knew that we weren't going to be able to keep up with the number of people with positive COVID tests, we developed a predictive algorithm based on all the data that we hold within Health New Zealand. This was in the northern region. So there was a community hub, a Pacific community hub that was contacting all the Pacific whānau where someone was had a positive COVID swab. And so what we gave to that Pacific community swab was a dashboard, and then every positive swab hit the laboratory systems. It immediately scanned the data that we had available around that person and came up with a risk of hospitalisation. So this is a risk of this person becoming really severely unwell. And that information was then able to be presented directly on the dashboard for the community hub, so it helped them to prioritise who they needed to call first, where were the families most at risk, that they could get in contact first and offer them some help. And as well as just giving them the risk score, I realise you won't really be able to see that, it gave them little flags as to why this person was at high risk, maybe because they had respiratory disease already. So it was a very practical solution. It was delivered directly to the people who were doing the mahi on the ground and in the community, and it also was explainable because it told them why. So this was really well used at the time, and is a really good example, I think, of like how we could use predictive AI analytics in practice. But these things are not infallible either, even though this is the type of technology that's been around for a long time. There's still risks with this, right? This actually requires us to have data. It requires us to have big data sets that we can derive these tools from and test these tools on, and then it requires us to have the digital systems that gave us that lab test result immediately and where we could look for all the other data. And so that is based on having those kind of infrastructure things in place that we could make the most of. And it's very context specific, right? As you've heard from the previous speaker, these things need to be developed locally for the local context. These are not things that could be developed elsewhere and then shipped here. They need to be developed locally and used locally and be useful locally as well. And so, so this is an area with huge promise, but lots of requirements still in order to do it well. So that's kind of the first example there. The second one, moving on to the computer vision. So these are the type of tools that we're seeing in radiology now, tools that are reading X-rays and MRI images and picking up early signs and patterns of things going wrong, things being slightly abnormal. So, and these tools, it makes sense that these tools are actually getting really good. They're really highly accurate because a computer can look at an image down to the level of a pixel. It's actually kind of better than the naked eye. And it can pick up patterns that we can't see very well. And so these tools are just starting to become more and more ubiquitous and available. And they're being built into our system. So we now have mobile chest X-ray machines have got AI built into them that will give you an answer immediately about whether this is a normal chest X-ray or something that needs to be investigated. We're starting to do things like fracture detection in an emergency department so that you can immediately discharge someone rather than having to wait around for a radiologist to read the report. But the example I wanted to give here is about diabetic retinal screening. So this is a project that's actually led by the Pacific Health team in Health New Zealand, and we have Mālō, one of the team, in the audience today. So the benefit, one of the main benefits I think about being able to use AI is that it can provoke us to do things differently, do things in different ways than we currently do them. And that's what the Pacific team have been trying to do here, is to take diabetic retinal screening out of specialist clinics and hospitals and take it out into the community and onto marae and into community outreach events with mobile cameras, because the AI allows us to train kaiwhina to use these highly specialised mobile cameras, and the AI will give them immediate feedback around whether they've captured the image properly or not, and can give immediate feedback about whether this seems to be a normal a normal retina, or early signs of something abnormal that needs to be further investigated. So it should allow us to really change the whole model of care about how and where we deliver services, because we can use these tools to help us to do so. But again, it's not that easy. So we've had lots of issues with this particular project that should just exemplify some of the issues in general. So we have really old systems that prevent us from sharing the images to the AI and to the ophthalmologists. That's taken us a really long time to get around. We have our traditional ways of working and our traditional services, which are resistant to being cut out of how we provide the service. And we have our population, which are, wary of AI and wary of things being done in different ways as well. And we're not very good at communicating around what does it mean to add an AI into this kind of model of care. So there's loads of reasons why these types of things are still really difficult to implement. And one of the others is around how we do it. Yeah. So just as a different example, so you may have heard lately we're looking at putting an AI tool into the breast screening program. Now, but you put that AI in the whole workflow of screening actually makes a big difference. So you don't need to see all the detail here, but basically you could put AI at the front as just a triage. It just tells you the priority of all the screens. You could put AI as the only reader. You could put AI as a second reader, so you have one human, one AI, and then see if they agree. You could put AI as the first reader and then give that result to the radiologist. You could have the radiologist read it first and then see if it's confirmed by the AI. You could do it in loads and loads of different ways, but the thing is that wherever you put it, it changes the workflow, but it also changes the outcomes, and it changes the cost effectiveness of that whole workflow. So these things have to be really kind of carefully thought through. And there's still bias in the system, right? Because there still has to be trained on hundreds of thousands of images in order to get these systems to be really, really good. And generally when it comes to the computer vision, the radiology's tools, these things are trained on hundreds of thousands of people in the US or in Europe. And it's very, very unlikely that they have been tested in Māori and Pacific populations, for example. So there's still a whole lot of testing and tweaking that we need to do locally to make sure that they're going to be good for our people and they're going to work for our people. So the performance is much more than just the accuracy, which we know is now getting pretty good. And that's just a list of some of those other issues that I've already talked about. And then we come to the third big bucket, which is generative AI, which is the big buzzword now, of course, you all have heard about, ChatGPT, and really, really changed the game hugely. So this is something that works completely differently. So we're no longer talking about something that's been trained on hundreds of thousands of images and what the doctors said was the right answer. These things are, the real Wild West. So they were basically trained with way less transparency. They were just basically shown the internet and said, go for it and teach yourself. And we know what the Wild West of the internet looks like. So that is what they are trained on. And these things do not work on accuracy. They're not trained to come up with a right answer or be incredibly accurate. They are trained in a probabilistic way. So they're basically trying to come up with what is the next most likely phrase or sentence or answer. So they're not trained to give you the right answer, they're trained to give you the answer that you probably want. So for that purpose, they are inherently inaccurate. But the main example of what we're doing here in Aotearoa in terms of using Gen AI in the health system is the ambient AI scribes. So these are tools that will listen to a consultation between a health professional and a family. They record that, transcribe that consultation, and then summarise that into a template that you give it and say, I want a structured note like this or a letter like this. It will summarise what happened and put it into that template, which saves enormous amounts of time in terms of documentation by our health professionals. So they love it, generally. We can train it to write the response in any way that we want. So we can provide really good patient information out of this as well, because you can ask it to then summarise this for the particular person that's sitting in front of you in terms of their language, their literacy levels, their needs in terms of information needs. And these tools can do this really well, actually, and they can also, and lots of studies been shown to be more empathetic than the information that we might otherwise give them as health professionals. So the potential, again, for these type of tools is huge, but the pitfalls are also absolutely huge. So as I've said, these things can be inherently inaccurate. They have to be checked. Everything that they produce has to be checked. They were trained on the internet, so there are inherent biases in how they've been trained that come from the historic collection of information that is out there. We're really worried about our control over our information, particularly the information of Indigenous populations. And how do we continue to control that information when it's out there in these massive multinational models? Things like intellectual property, but also potentially the loss of clinical skills. If we are relying on our AI to do these things, we inherently become just a little bit lazier because we become reliant upon them. And all these things have been proven. But the big thing there is scope creep, which to me is what is happening with our implementation of scribes across the country, is that these tools are just trying to do more and more and more for us now. They're not being restricted to just summarising what happened. They're saying, oh, and have you thought of this? And maybe you want to add this into your management plan. And they're just adding things as they go. And so the scope of what we allow our AI to do is just massively expanding. So those are the kind of three main buckets and three big examples of AI tools that we're implementing in the health system in New Zealand at the moment. Really good potential, but still really limited by all of the issues, by all of the pitfalls. But here's the provocation about where this might be heading. And I know you won't understand what's on there yet, but there's been two big advances in this space in the last little while that I think are just going to make the next big difference in terms of how useful these AI tools are. So the first one is the one on the left, is that, as I explained around how the generative AI works, it's not designed to have a normal thought process like we do. And so they're not very accurate and they're not very good at the medical reasoning that goes behind coming up with a diagnosis, for example. Until just recently. So on the left there, this is Google's new AI. It's called AMIE, A-M-I-E. And this has just been published last week, and there was another one published as well, very similarly by a different group. That can suddenly do, I don't know why it's gone like that, can suddenly do medical reasoning, right? So these are chatbots, if you like, where you can put your information in, it'll ask you questions, you can answer it, and it will actually go through a reasoning process that we can be transparent and we can see how it's thinking, if you like. And as you can see in that spider diagram, the AI is the pink underneath, which shows that on all of those areas of things like medication reasoning, treatment preciseness, management plan appropriateness, the AI was better than the medical professionals for the first time ever. This is not ready for prime time use, but this is just an indication that how much the AI is advancing and will potentially be able to actually do medical reasoning. And then the second advance is the bit on the left about agentic AI. So agents now, the new development in AI is that agents can do things. So they're not just a passive answering questions, they can actually also make things happen. So for example, they can answer phone calls and have a discussion, and as a result of that could book you an appointment, could order a lab test, could order a radiology, could receive the results and then put that into a referral and send a referral to a gynecologist, for example. And it is the putting together of all of these things in the future where now, instead of just one big AI that's not really very good and is very opaque, you could now have layers of different, very specialised, highly specialised AIs with very good guardrails around them that do very specialist things, put all of these together in a multi-agent sort of platform, and you've suddenly got something that could be incredibly useful. So that seems to be where the future of AI is potentially heading. And it suddenly makes it way more useful for your average person than it has been to date. We're not there yet, but this is looking like what the future might be. But considering the Wild West that we currently already have, introducing this kind of AI is obviously just going to have way more risks and issues that we are going to have to be in control of. We all know about all of these things that have been out there in the past about data breaches, privacy breaches, really bad results of bias in systems, inaccuracies, and things not working very well in practice compared to in the research type of environment. So how are we going to manage this? How are we going to govern this as we try to bring these things in a way that is safe and ethical and useful and equitable? So what we have been doing for a few years now here in Aotearoa is around AI governance, because currently in New Zealand we have no specific legislation or regulation around AI or software as a medical device or any of this. And there was a review done across the Pacific a couple of years ago in 24 that basically found it's the same in most countries across the Pacific. There's no legislation, there's no regulation, there's no strategy from governments about how they're going to use AI, how they're going to introduce it safely and ethically. So we're all in that kind of same boat. And in the absence of regulation, we do have these other kinds of levels of guidance, which are the same, for everyone really. But what all these guidance documents basically say is that each agency that introduces AI is responsible for doing the assessment, the evaluation, for monitoring and evaluating and making sure these AIs are safe. So they're putting that back onto all of us as the people who try to introduce it. So we have set up a national AI and algorithm expert advisory group within Health NZ, which is currently reviewing all of the applications to use AI tools in our healthcare services across the country. And this is built on several years of research now that we have been doing this, and we have lots of lessons learned that we really need to start sharing widely and working together on. So our group is a very multidisciplinary group of internal and external experts in a whole lot of different areas. We represent all of the perspectives on the far left there, including Pacific as well. And everyone brings their own lens, their own area of expertise to the discussions and the review of new tools for use within health services. And we provide endorsement or otherwise recommendations around how to mitigate risk with the introduction of each tool by reviewing it from all these specific lenses. I'm not going to go into all of these ones now, so I'll skip through a few slides. But basically, we really do think very carefully around how does this impact the clinical workflow and the patient and clinician interaction. We've got a body of research now that we're still doing around what are our consumer perspectives around how we use AI and what do consumers want to know in terms of transparency and consent around the use of AI, and how do we try and ensure that we maintain the trust. So we're building on a body of research there. And obviously we are testing everything for equity and fairness, and we have a small lab where we can test tools with impact on, particularly on Māori and Pacific populations, because most of these have not been to date. And we can look for bias, and then we can mitigate bias in the way that we implement them. So there are ways that we can try and help do this more equitably. We have a group who've been working on adapting Māori Hudson's work around asking the right questions around Māori perspectives and Māori data sovereignty. And we have some pretty good standards around ethics which are the same internationally, and build on the work with that WHO group that I'm a part of. There's always data considerations, and every tool has to go through a privacy impact analysis, where we go through all the principles of our privacy code in New Zealand. And as I've said, most of these tools are based in 14 countries out of the whole world, so generally only in English. Performance is one of probably the easiest things to test for, and we have ways to test for accuracy and reliability now. But we've also learned a lot on the legal side of things, and what do we require from third-party companies who are generally the ones who are doing this, who are not health companies, they're not even digital companies, these are new companies generally who do not understand the health context. So what we've ended up with is this new pre-implementation evaluation framework, which has been led by the research by Dr. Rosie Dobson. And we're just trying to get this published at the moment. So this is just new, we're just starting to use it, but we really want to share it, and we really want other countries to adapt it for their own contexts. So basically, it is based on the Ministry of Health principles for the use of AI and precision medicine in Aotearoa, that's the outer ring, is the AI principles from the Ministry of Health. The next ring is those different perspectives that I just showed you that we bring from our advisory expert group. And then the inner bit are the 3 areas where we're asking specific questions about each tool around how does it enhance the health and experience of our patients and communities, how does it improve the healthcare workers delivering care, and how does it add value to the health system. So those 3 areas, and we ask the questions that are in the middle, and what we end up with is a bit of a heat map like this that shows how ready that AI tool is to go, or what are the areas where we need to put some mitigations into place to address some of the issues. So this is what we really want to kind of offer and start talking to people about how to apply this and how to adapt it for different countries' contexts. And we're aware, so the WIPRO region, World Health Organization, is currently planning to pull together cross-WIPRO, cross-Pacific nations meeting around how do we collaboratively govern the introduction of AI across Pacific nations. Instead of expecting each country to have to do all of this work themselves, how do we come together and collaborate and do this together, but also being able to adapt that for everyone's context. So we're really looking forward to those kinds of discussions, hopefully coming up towards the end of this year. So that was what I wanted to say. I hope that is useful. In summary, I think that there is huge potential, but there are also huge pitfalls. And we really need to work together on how to try and do this safely, securely, ethically, and equitably for all. So, kia ora. Thank you.
A round of applause for Dr. Robin Whittaker. We'd like to say a big thank you, my dear. So on behalf of our team, this is a box. There's actually nothing inside. It's just, it's AI. It's AI. It's AI. So enjoy. She will be with us for the day as well, so she'll be here for plenty of Q&A. But we've indulged in information. Now we're going to fill our pukus. We're going to break for morning tea, but may I invite you all to please close your eyes. We're going to do a quick little lotu, tātou te talo. Tui o taimi mo I tāni, tu mau kau whakatahe whainga Māori e koe ni, ke tua whawhitai ke a Fiona. Maulota tu eki ka mua mo ki mautole a honi, ko hui koe ngahi a talanoa mahau inga koe ni, ke mea I he taim tatau ke kei langlang I e pe a Fiona. Maulota tu koe mea to koni koe ni, ke mauha mauinas, ke whakakato e ngahi whatongia o e a honi. Mau kore ngai mea ni hoa whasisu Christ ko koe ko mawha moi, e meni. All right, beautiful people, we're going to break. Morning tea is here, and then we'll come back in about half an hour. And for you at home, just stay there. Don't go anywhere, you beautiful creature. All right, we'll see you very soon. Out the way.
Some good love. I want to give you some 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 love.
Shawty, I'ma only tell you this once, you the illest. And 311, I'ma die hard like Bruce Willis. You got spark, you got funk, you got something all the girls want. You like a candy store, and I'm a toddler. You got me wanting more and more. Your love, yeah, your love, yeah, your love, yeah,
Whanongo he tue whakalavetala he ai manu launo e hoku toli he kakala to ahono mausa pe ate ki he sola o taka no no fope i he hoa o tamata ko whanau no he tue moe whakalavetala he ai manu launo e hoku toli he kakala to ahono mausa pe ate ki he sola o taka Fisai, kuo movete, whakamau o e
the club, eh? EMP girl, we coming. The on the left, on the right, then watch way. As we slow mo up, prating the bar. Yeah, we gonna bring her up tonight. Oh, yeah, we came here to party. The bar, yeah, we gonna bring her up tonight. Sat down, what's them crazy ladies? What's them crazy ladies getting? Nothing at the club all night long. DJ put a beat and replay. We gonna take it till the early morning. Hey, bartender, bring another jar. Getting drunk in the club all night long. Oh, bartender, another shot tequila. Them right, you know I need one more susu bottle. Let's go.
Group on the dance floor. Let's go. Group on the dance floor. Wind up on the beat.
Oh, hey, bartender, bring another jar. Them right, we came here to party. Oh, bartender, another shot tequila.
Group on the dance floor. Wind up on the beat. Group on the dance floor. Wind up on the beat. She bought me a bottle wine and a whiskey cola. Asked me for a dance, okay? Go gala, go gala, go gala.
Hey, bartender, bring another jar.
Now what you're doing, now it's time for drinking.
Oh, bartender, another shot tequila.
La 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 la. Come girl, come give me now. Come girl, come give me like a loving. Come give me like a kissing and hugging. In a me heart, in a me mind. Tonight you be my darling.
Hey, bartender, bring another jar. Oh, yeah, we came here to party. Oh, bartender, another shot tequila. Another shot tequila. Yeah.
Group on the dance floor, wind up on the beat. Group on the dance floor, wind up on the beat.
Oh, hey, bartender, bring another jar. Them right, we came here to party. Oh, bartender, another shot tequila.
Group on the dance floor, wind up on the beat. Group on the dance floor, wind up on the beat.
Pass me another round, no, me can't go down. This in a spill up me head, everybody face starting looking funny, nah. Hey, bartender, bring another jar. Come we collide it, say. Oh, bartender, another shot tequila. Group on the dance floor, skip up on the dance floor. Come collide me, say we breaking it, jiggle it, now go mistaking it. Time and now heaven will be taking it, say. Hey, bartender, bring another jar. Not go waste it, drink it up all night long. Oh, bartender, another shot tequila.
La 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 la. Come girl, come give me now. Group on the dance floor. Let's go. Group on the dance floor, wind up on the beat.
Oh, hey, bartender, bring another jar. We came here to party. Oh, bartender, another shot tequila.
Group on the dance floor, wind up on the beat.
Here we go, all night long, you and me till the early morning.
Group on the dance floor, wind up on the beat.
Wind up on the beat.
Group on the dance floor, wind up on the beat.
Oh, hey, bartender, bring another jar. Oh, bartender, another shot tequila.
Group on the dance floor, wind up on the beat.
Wind up on the beat.
Group on the dance floor, wind up on the beat.
Every time she passed by my window, I wonder what she's going through. Try to find the courage to say hello and ask her if she feels the same way too. But I never promised you a rose garden or that big house on the block for you to live in. Yeah. But my eyes and heart have loved only you, girl. Faithfully yours for all time. I know she has high expectations.
faithfully yours for all time. What you got is a loyal man. I never promised you a rose garden or that big house on the block for you to live. Not everything is about money, but my eyes and heart have loved only you, girl. You for faithfully yours for all time. I love you for you, baby. I never promised you a rose garden or that big house on the block for you to live. But more than anything in the world, but my eyes and heart have loved only you, girl. Faithfully yours for all time. Every time I ask you, the big brown eyes show you side, I hope every hair my girl, I really love you for your pretty face and your kata is really Fakatalofa. I'm very special, and I love there's none other like you. Pretty mama, please smile for me. Pretty mama, come dance with me. Pretty mama, please smile for me. Pretty mama, you're the one for me. Yeah. You're the one for me. Yeah. Baby, every time I ask you, baby, your big brown eyes show you side, I hope every hair my I'm so crazy about you, Yahweh. Just tell me when I ask you, baby, that you will always be my baby. I'm very special, and for Ilole too. There's none other like you. Pretty mama, please smile for me. Pretty mama, come dance with me. Pretty mama, please smile for me. Pretty mama, you're the one for me. Yeah. You're the one for me. Yeah.
Excusez, Madame, Monsieur, ladies and gentlemen, may I please steal your attention for uno momento, por favore. Can I please invite you all to make your way back to your seats? We're going to begin our next session, paging all passengers boarding their flight for the Symposium at the University of Auckland. Please enter your gate and find your seats. Paging all passengers. We're about to begin very, very soon.
That's why I wanna hold you tight, tight, tight. Just be what you fight, 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 fight.
All right, hello Olketa, nemblong me John, Mālō e tau mau e ahone, Mālō e lelei, nisam Bula Vinaka nā turanga ki nā marama I Orana, to my friend from Tahiti Nui, Maururu, and mahalo nui loa for joining us today. And for everyone that's tuning in online, welcome back. All right, we're going to move on to our next session. It's a panel that will be facilitated by the most wonderful Dr. Audrey Aumua. Dr. Audrey Aumua is the CEO of the Fred Hollows Foundation. So please join me in welcoming Dr. Aumua to the front. And she's got a lovely panel here to talk about women's health, eliminating cervical cancer in the Pacific region. Now, first up, we're going to invite Professor Bev Lawton, founder director of Te Tātai Hauora o Hine, National Centre for Women's Health Research of Aotearoa, Victoria University of Wellington, Pōneke. Please come forward, as well as Dr. Eileen Tan, who we heard from earlier. And as well as that, we're going to also have Moa Nanu, Dr. Kara Okesene Ngafa, who is currently the head of Pacific Health Department, co-director of Te Poutoko Ora Akiwa at the University of Auckland. She's an obstetrician and a gynecologist. And finally, our final guest is Professor Judith McCool, who is the head of School of Population Health, co-director of Te Poutoko Ora Akiwa here at the University of Auckland. A round of applause for Dr. Audrey and her panel. We'll see you soon.
Good morning, everyone. Warm greetings to all of you. Our host, Cervical, good morning to you. Distinguished guests, esteemed panelists, colleagues, students and friends, welcome to our Taloha on accelerating the elimination of cervical cancer across the Pacific. We're really privileged to be joined by an exceptional panel of leaders, clinicians, researchers and advocates whose work spans prevention, screening, treatment, health system strengthening and research, and together they bring decades of experience working alongside Pacific communities and of course communities in Aotearoa to improve women's health outcomes. And earlier this morning, Dr. Eileen set the scene, I think, really beautifully for us by reminding us both of the urgency of the challenge, but also the extraordinary opportunity that is before us. You know, cervical cancer, as she said, is one of the few cancers that we have the tools to eliminate. Yet too many women across our region continue to face barriers to prevention and early diagnosis. And so today's discussion will explore what it takes to accelerate progress through collaboration and innovation, and of course workforce development that we heard about this morning, and locally led solutions. If we get time, we'll examine the full pathway. It's possibly that we may not, and I really encourage all of you to listen well. And before I start, I want to recognise Metua Bates, who Colin mentioned earlier this morning. Metua is one of the first national cervical screening leaders in this country, and so good to see you. And thank you for swimming across the ocean from the Cook Islands to be with us. You know, we have a huge amount of expertise on this panel, and they will talk about their own experience and what they have learnt and what contributions, particularly the work that they have been doing, they've made. And so they're not going to need a facilitator to ask them direct questions. So I'm going to open this up immediately, given the shortness of time we always have with these sorts of things. But I'd like to really just talk, turn to you, Professor Bev. And I know many of you will know our New Zealander of the Year. But Bev, of course, has been absolutely instrumental in advancing HPV screening and prevention. Your incredible leadership work in Tairawhiti with Māori women, and of course your reputation precedes you everywhere in this country. So we're really keen to learn a little bit about your work. And, despite cancer being preventable, and particularly in this instance, many women, of course, continue to be diagnosed at later stages of diseases. So we're keen to learn a little bit about what you do, and in particular, what are the lessons learned that you are experiencing that could really be even transferable for some of our learnings in the Pacific?
Kia ora, is that on? Can you hear me? Tēnā koutou katoa ko Pivile Orana hau. Ko te atanga hoiti te iwi. My dad's from the East Coast, my mum's from Wellington. I've got 2 children. I'm not allowed, my team says, I'm not allowed to say I haven't got any moko anymore, but I haven't got any moko, so it's no good. Okay, well, it is. See if you have sympathy for me. Thank you for the kind introduction, the AI-generated reputation. I think this is a very important topic. I just like to give you where we're at in Aotearoa at the moment. We're not doing as well as we should be, which is disappointing when you're holding a hand out for us to be an example. I think we can learn from some of the things for other areas, and we can learn maybe to do things better. I don't know if most of you are aware that cervical cancer is caused by a virus. When I went to medical school, I didn't know that. And now we know it's a virus. We now know we can vaccinate for it. We now know we can screen for it, which is why I've been holding a swab up for the last 8 or 9 years. We finally have self-testing. And I think it's really important to realise that's not the whole spectrum we've been talking about today. And for us, I think the success of screening was it was community-led, the research projects we were involved with were community-informed, and we got a program that, for once, the community was behind it. And I think that's a lesson we've learnt today. We've got HPV self-testing. We introduced it with the tuapapa Māori model, so the community spoke to the ministry. We did our studies right up to the 2 days before the program started, and we ended up with HPV self-testing, so ladies could actually do their own swab looking for the virus, because we know that will prevent 15% more cancer than what we did in the old version. So we've done well with that. So if you're going to give us some credit for this nasty bug, we've done well with screening. That we believe there are more than 3 pillars to get rid of this nasty cancer. We want to get rid of the bug, but we want to get rid of cancer. And there are the ones that we talk about with WHO are vaccination. We're a fail in this country for vaccination. Our rates are rubbish. There are at least 30,000 women, young girls every year who will miss out on this tonga of this wonderful vaccine. And I think this is when you have to, maybe you can help me. The conversation is now not just cervical cancer. This vaccine will prevent anal cancer, throat cancer, penile, vaginal, and cervical cancer. And head and neck, this head and neck is big. So there's approximately 400, I've got it written down here, 400,000 deaths globally from this virus. That's the deaths. That's not all the other cancers that they may have been able to treat. So this is a very significant bug. So why are we telling our whānau that they can have that information to give to their children to prevent these cancers? So we're failing on vaccine in this country. Screening, we're doing all right, but as Aileen said, if you screen, you've got a responsibility to diagnose. And diagnostic is not part of our pillars, because that's a WHO classification. We need to have diagnosis as one of our pillars. So we're saying, where are we going, what are we doing, and what's the transparency? And I assure you, we're doing very badly. Just under 50% of our women who are type 16 and 18 are not making the target of being seen within 30 days for a diagnostic colposcopy. What does that mean? You think, what does that mean? And that makes me emotional, because I have spent time recently with a young woman who was delayed for 7 months with a clinically significant delay of her cancer. So we are not making our targets for HPV 16 or HPV other with high grade. And that means there's people sitting out in Aotearoa with a screening test who are going to have cancer or a high grade, they are going to shift grade. And that is a disgrace. So it wasn't going to be all good news about Aotearoa. Sorry about that. For our treatment, we're doing so-so. And you know why I'm saying so-so? It's not transparent. Do you know what your district, it's not a DHB anymore, what your district, your DHB treatment rates are and your colposcopy rates are? You don't know. You can't look it up on the web to see if you're behind. Where I'm at the moment, no, Auckland. I think further south, counties behind. So you can guess where we're behind. And so we've got 5 pillars. Just before I finish, and the 5th one we can't forget is innovation. And I think we've always got to consider innovation. Innovation gave us looking for the virus. Innovation gave us the vaccine. So what's innovation going to give us next? And that's, I think, with any illness, anything, we must be surveying, and AI might be part of that. Don't know. What have I else got? We need to do it. There's no transparent. Oh, there's one last thing. We've joined with the Cancer Society Te Tātou Hora Ehene, and we have decided, we formed a task force of lots of like people, and we think if the government's not going to eliminate this, we don't have a strategy, we will have to do it, as everyone in New Zealand has to do this and get on the waka. So we've termed Eliminate 38, because they told me it looks good with the 38, Eliminate 38. So Eliminate 2038 is our goal, and we hope you're going to join us, because there's lots of work to be done. So thank you.
Thank you. And so holding up the swab, this is the self-testing swab?
It is.
It is. And so...
It's not been used. It's fresh.
Thank
But
you.
it can be used.
But with this kind of innovation, and she's so cheeky, isn't she? With this kind of innovation, and you're talking about we're not getting to the women and girls who need to have access to this. Why?
We're screening beautifully. I may say, I need a big clap. Pacific peoples, and I know that's not, a diverse group, are doing absolutely fantastically. I don't know why, but I think we should put it in the water, because they've gone, I'm top of my head, from 60% coverage to about almost 79, and we want 80. Overall, we've gone to 82%. Since switching to this, guess what? 82% of women are choosing to have this instead of a speculum. Ladies, what do you think of that? Oh, does that surprise you? We had to do a study to do that, to say, well, people would like to do this. Sorry, excuse me. But this is not the problem. It's what happens afterwards.
Right.
If we find the virus is a screen. Lots of people have the virus. And that doesn't mean that there's a problem on the cervix. 1 in 10 will be positive for the virus. But what's the percentage? Very small percentage of that, again, will have to have a problem. Maybe 3 out of 10 will have to, but they all have to be looked after. But it means 90 out of 100 people can go off and don't do it again for 5 years. Except, don't forget, you can do this for sexually transmitted diseases as well, just a public health comment. Yep.
Thank you very much. And it's a really stimulating opening statement there. And just turning to you, Dr. Eiling, and thank you really very much for your presentation this morning. And you really introduced to us this incredible model of capacity strengthening, surgical capacity strengthening in the Pacific. And thank you. This is such incredible work in the region. And I wanted to ask you a little bit about, we understand, and you described for us very nicely today about the investments and the partnerships and the people involved in these sorts of things. But I wanted to ask you to help us understand more about when you're building oncology and surgical services in the region and really sort of low resource settings. What do you think some of the big challenges are? What do you think some of the big indicators of success might be when you think about those limited and low resource settings for surgical capacity development?
Okay. I think that from our perspective, we always work within the resources. And we obviously are pragmatic people. And we realize that if we are going to train within a particular resource, our curriculum is actually flexible. So we would train according to what resources they have available, what technology they have available. But, people, wherever they are easily trained. And the commitment and the talent that we have is amazing. So I'm not sure whether I've answered the question, but it's actually about the people. We work with what resources we have. We do not do dangerous operations that we do not have follow-up for or the ability to support the woman. We've done radical hysterectomies in the Solomons, and there's a big paper that's shown that radical surgery can be done in low-resource countries safely. Most of the radical hysterectomies, and we're talking about cervical cancer here, do not need anything more than, the skill sets, the theatre staff, and the fact that we don't really need blood or anything mostly for these operations.
So many Pacific health systems then are really set and poised to deliver a full set of services.
For the cervical cancer, for surgery, yes. But what can I go totally different from what you've asked me, and can I just have my 2
Yes,
minutes
please,
of my bed bug that I need to share? Most women in the Pacific present with advanced disease. What we don't have in the Pacific is radiation. And that, to me, is a real problem because it's all very good. We're doing what we can. As a surgeon, that's all I can do. But from the perspective of looking after a woman now, we have not been able to treat locally. In terms of transferring care and being referred overseas, it's all very good on paper, the government supports, but the government does not support what I call the navigation package. And what that means is the transport, the visa, the carers package. Most women do not go overseas because they cannot afford it. Let's be realistic. Can we not do something about it? I can't because I'm a clinician. This is my recurring broken record. Sorry about this. But what can people do? Is there anybody in this room who can help us in terms of if governments are sending people overseas? Can they not cover the whole package? In Australia and New Zealand, we're supposed to be looking after our Pacific family, but they can't come here for radiation because obviously our public sector is also stretched. So because radiation involves external beam and internal radiation. So for me, at this moment in time, this is my major upset because I know in Samoa in 2024, there were 8 women, none of whom got treated. And I just think that is not acceptable. Yeah. I don't know how to fix it, though. Some of the things I have been trying to fix, but I can't fix that.
I suppose when you, and the model you presented this morning about, the efforts in training the workforce, I mean, they go a long way to building this capacity in a country and in a system. Is that the major investment, though, where our efforts and resources should go? Does this give a country capability to then start to design its service and its competencies?
I think so. I think you've got to start from the people, you've got to start from the ground, and certainly what we're doing at this moment is, beside the advanced case and the cancer cases, what we're trying to do here is to make sure that women who are screened actually complete the pathway and get treated. And so what we're trying to do at the moment is building up pre-invasive clinics to treat the women who are positive and to be able to prevent those women to have cancer and to have those advanced disease. So I think things will get better. I think this will make a difference. But in the meantime, I quite like to advocate for the women who, in most certain circumstances, as the advanced cancer, still have a reasonable chance of cure. But in terms of the pre-invasive disease, definitely we can build the clinics, we can build the service, we can train the specialists and the health clinicians and the nurses to do the work.
Great, thank you. Good. Dr. Kara, huge champion of women's health in New Zealand and of course the region. You know, your reflections on what you're hearing from both this morning but also from our previous speakers and you know, maybe take an opportunity to talk a little bit about your work and what you're learning about.
Thank you, Audrey. Fakatalofa te Talofa lava and warm Pacific greetings, everybody here today. I think I'm just going to tell the story of why I went into women's health. I was a fourth-year medical student, but I knew growing up that our women are very sensitive to sensitive examinations around the taboo from the waist down. And also in the Samoan culture, a lot of our cultures, the va between you and your parents, the va between male and female, the va between brothers and sisters. And so it was just yesterday, I was just reflecting on that relationship, how I was told by one of the managers in MAPAS, a lot of our Pasifika students through medical school do really poorly in the obstetrics and gynecology. And the reason being is it's so internalized with us that sensitive examinations and the taboo around anything from the waist down, that sensitivity. I know there's research being done about it. And you know, and how can we educate our communities around that? Great with self-wellbeing, Bev, that you asked me before, why have we increased the rate? It's because of that, because we could do it ourselves. We don't want to go to a clinic where anybody would, I mean, I remember as a junior SMO specialist, there was a Samoan woman that came through and she was horrified that I would do a speculum examination when she hasn't had a shower that morning. It's so hugely culturally important for us, those simple things. But it's those simple cultural beliefs that is so ingrained in us that makes it as a huge barrier to us accessing. I know there's probably women here who are, you know, campaigning for us in the community, and that's, and you know, I take my hat off to you. I mean, I'm just sort of at the other end. But those, you know, critical things. Just last week at the college, for the first time ever, the College of Royal Australian New Zealand College asked us, including Silipa, to come and talk about, you know, what is it that we should be training our non-Pacific clinicians, specialists, especially in the college, how they handle Pacific women, and what is it that is so important to us culturally, that is important to us when we see us in clinic, when we have an examination about self-swabbing, about what is about cervical cancer. And one of the, you know, PhD Pacific has approached me, said, you know, how could we, I think that's why Natalie and these guys did really well during the COVID, because they took the science and they did it in such a culturally appropriate way, such that our people could understand the vaccine. They went out to the community, had it all in different languages, had the videos, and that's the kind of thing that we need. You know, that kind of education for our women. I think that's just some of the reflections I'm sort of rambling on here. Talking about colposcopy, Bev, I know. You know, we screen them, HPV positive, high risk, cannot access colposcopy clinic. South Auckland especially. Why? Because the system is not set up to have, you know, to cater for the amount of that's coming through. There's only, so the pathway to that, to be a colposcopist, you have to be a specialist, right? But you can train nurses, specialist nurses, to be colposcopists just as well. And probably that's probably where AI should come in, where they could use that as well and match it to reading the colposcopy by a specialist. But yeah, just some sort of, and with Aileen, so two of those gynae oncologists actually came through Middlemore Hospital as part of our trainees. Something that we're really working with the college now is to increase Pacific and Māori specialists coming through. In the college, there's He Hona Wahine, extremely powerful group for Māori group in the space. We would like to set the same for Pasifika within the Royal Australian New Zealand College of ONG, who are influential for our women, the services, as well as also for the ministry. But yeah, I think that's enough from me now. Thank you.
Excellent, thank you. I mean, I think the issue that you raised about the cultural sensitivities and this concept of taboo and the training of non-Pacific clinicians who are working with Pasifika communities, I mean, what's the message that you give them when you're talking with them about this issue? And are you seeing this issue of taboo being an issue of resistance around participation and access and so forth?
It's interesting you asked that, because our head of department for ONG, who is not an ONG specialist at the University of Auckland, for the first time when I started giving women's health lectures in ONG, he said he had no idea, a very senior person, no idea that this was such an issue for Pasifika women. He had not a clue on earth. And he said, how did I come through the training University of Auckland and had no clue that there's such an important issue for Pasifika women? And so, it's just trying to, and I'm so grateful that now we have 3 ONG specialists Pasifika who are now working with us. One is a gynae oncologist, one based in Tauranga, Cook Island, and another one who's Fijian, now want to get into fertility. So we have to train them to get into these places and spaces to be strategically, because we know there's so much racism around access into fertility treatment because of our high BMI. But then our women with high BMI do get pregnant. Do you know what I mean? So what is it why is it making such a huge barrier? Because we haven't done the research around women with a BMI of over 32 in our Pasifika women who can actually get pregnant if we have IVF. None of that's been done. So, I mean, all the research around IVF and access to it is all from European countries, and we use that here. So we haven't developed something that's locally for our own local people. Anyway, thank you.
That's good. I mean, Professor Bev, I see you nodding a bit in response to Kara. Are you seeing the same challenges in your community?
I don't do any clinics, not anymore. No, I think it's the same thing, and that's what we were hearing when we did our qualitative work, particularly in Te Tātokoro and rural areas, that is again tapu, and heart-rending stories and people having speculum exams and just how incredibly hard that was. But the one thing that came out of a qualitative was the HPV self-testing was the young ones, their nannies and aunties would say, you have to go and do this, have this smear. You have to go and do it. It's, it's uncomfortable, it'll hurt, but it's really, you have to do it, meaning a speculum. And of course, they were quite bright, they didn't do it. And so when the HPV self-testing came along, it flipped the narrative. These young women will go and do their HPV self-test, over 25, that's what I think is still quite young. They do their own self-test. They put it on social media. They take their aunties and their nannies and they take them in for a test because it was their test. And no, we're calling it a swab, but we called it HPV self-test because all our qualitative work in our community said they wanted it to be their test. And taking control of that is part of what we're talking about, community control of doing something. We've got one part right, but we have to do more. I may say the attitude about not having colposcopists, I'll say this only for the 95th time, and won't say it again, is in 2017 when we said we were going to HPV self-testing, we said we must train more colposcopists. We must train more nurse colposcopists. Every year we said that. Did it happen? No. Sorry, had to say that.
Interesting. Well, to you, Professor Jude, how are you going to help these clinicians and practitioners through research? What is the role that you all might play here?
Can you hear me okay? First of all, kia ora koutou and warm Pacific greetings. And I want to, first of all, acknowledge also my colleagues I'm on the panel here with, because I feel as Aileen mentioned this morning, you felt intimidated. I feel similarly because really we are amongst women who've really broken new ground alongside their colleagues in this area. And I'm fully aware of my relative new sort of introduction to this field of cervical cancer. And about a year ago, I had been working broadly with my colleagues at Te Poutoko Aotearoa in the area of broadly NCDs, and then beginning to do some work looking at where the gaps were in the Pacific alongside our colleagues around cancer control, from prevention through to palliative care. Women's cancers came to the top of the priority list. And amongst those cancers, obviously breast cancer, cervical and endometrial cancer was particularly concerning for the region. Alongside our colleagues in Niue and the Cook Islands, we started to put together a proposal to get some support, some funding, because the concept of elimination to people outside of this room is quite audacious and compelling. And we were fortunate enough to secure some funding to contribute towards the goal of elimination of cervical cancer in the Pacific, particularly working with our colleagues in Cooks and Niue. So your question is, what can an academic university research centre do in this world of highly specialised, complex, integrated systems where there are gaps and there are successes and there is an enormous drive to make things work. So where can we play a role? And I sort of listened to the words of the Reverend this morning during the lotu, where he mentioned about the importance of listening, not to react, but listening to understand. And understand where the university, our centre, alongside our colleagues, can make a difference. Where is it that we can help plug some gaps? What is it that we do that is distinctive? We're not in the clinics, we're not in the theatre. But my sense is, and working alongside our colleagues, again, it's not my personal view, but I think we have to really understand what is already in place. There is considerable efforts underway. I think we still don't have answers to a lot of questions, and these have been raised on the platform this morning. We don't have sufficient workforce in some areas. We don't always have the best of cooperation, so while there is considerable resourcing in some areas, the real challenge is to make that integrated and cooperative, transparent and responsive to what the needs are in each country and each community. So I guess to finish, we're really early days with our funding, our piece of work that we'll contribute, working really closely with the EPIC team and Kirby and Polynesia Health Corridors. It was wonderful to meet Bev. I reached out to Bev early on when we received this funding to understand what's happening here in Aotearoa from the woman who's really probably at the forefront of the innovations in this space. So, Audrey, it's really our role as a university to understand where we can contribute both in research, workforce development, and respectfully contribute. And so early days for us. Kia ora.
Thank you. No, thank you, Professor Jude. And I was just going to ask Dr. Island to jump back into this conversation for a minute. And when you hear Professor Jude talk about the approach they want to take in building knowledge, what is the advice you might give them around research priorities for the Pacific?
You're asking a clinician to give research advice?
Yes, please.
I guess it's actually looking at the effectiveness and outcomes of what we've done. I think that's one important thing. It's about looking at the problem we have at the moment is, I think, when the screening data, when a woman's screened, is absolutely fine. So that's all captured. What the gap is between screening and accessing care, and looking at how many women who are high risk actually do get care, and that is a big black hole, because once they get to the specialists in the hospitals, that information is gone. And we've not been able to look at that, and it's something that we really need to look at. I guess the other thing that would be really good is to look at the integration of breast and cervical cancer, sort of breast for early detection and cervical cancer screening and the pathway, because I do believe that they're the two major cancers for women in the Pacific, and it'd be great to be able to work together with our colleagues and to make it integrated rather than siloed.
Thank you. Did you also like to respond to that?
I just wondered about whether you support the researchers to do the research in their own country. It's growing people as well, isn't it? That's really important. It's very easy to go somewhere and be saying you're coming in to do something, but as long as it's co-designed and they own it, they've got to own the data.
Can I respond to that,
please.
Audrey? Yeah, look, I agree, Bev and Ailing, that's a really good suggestion. So absolutely. I mean, part of, when we think about capability, uplift, whatever it is absolutely, like the skills and the knowledge, the expertise is already in country. And again, reflecting back, what is it that we can bring that can support the building of that. So, and I know, I guess I refer back to your session this morning, Ailing, around fly in, fly out workshop sessions. One-offs are transactional. They do not necessarily, and we've done decades of this to understand that that actually doesn't leave a lot behind. So again, what role can the university or a centre or and the partners we work with contribute to mentoring that development of skills to undertake and lead the research, particularly evaluation work is really particularly important, data management, understanding the role of AI and other technology advances. So it's not about coming and doing, it's absolutely sitting back and working alongside, and this is where Mitua and I and the colleagues in TMO are very connecting around where is it that those skills are needed. How do we support that development that isn't based on the old model of extracting people coming here and doing workshops, leaving behind work that's necessary? We can do a range of different ways to support that skill development. Where it's right and where we actually do have those skills, and I think one of the things we have to be really careful of is we stick to areas that we actually do have expertise in and work closely alongside those expertise in areas. So I'll come back to that key point, I think, is around really good cooperation. We're all bringing something as long as it's transparent, it's clearly communicated, and it's led by the countries around where they want to take the direction of their elimination program. I think we'll make progress.
And I've been remiss actually in sharing with the audience that we are going to take a couple of questions at the end of the session. So if any of you have got burning questions, I'm sure the panellists would be very happy to answer. But I wanted just to pick up on the partnership and the cooperation principle, which Dr. Aileen talked a little bit about today. And we know when working in the region, particularly in areas such as this, that collaboration and coordination is so key. In fact, it has the capacity, when we don't do it well, it has the capacity to really unravel good practice and good investments. And you put up a slide this morning that listed literally all the partners that are working in the Pacific. And I wanted to know a little bit about, how are you going to convene this? Some fairly significant resources available now to advance this area of work. I'm wondering what your thinking was, Dr. Aileen, with that.
Well, I probably have very limited experience, but I'm going to have a go at this. Obviously, as a gynae oncologist, I started with the EPIC consortium last year, and I guess what really interested me in that consortium is the multiple partners. So EPIC is very much a University of Sydney based, they're very much into modelling and policy, and then Kirby, which is more the implementation team, just is very generalised, and from the University of New South Wales do a lot of the implementation work, and the Australian Cancer Prevention Cervical ACPC Centre Marion Seville provides the pathology backup. And then we have the lovely Dr. Eka from the Pacific Community SPC who goes to do. So I think that, as Jude says, it's about working together, using your skills and working as a team. And so far, I think that it's gone pretty well in terms of doing that. And recently, the team have had a big regional palliative care conference in Fiji. And the thing for this group that are working together at the moment, and hopefully with the University of Auckland as part of our whānau, we will do more things. We actually co-design. All the data is locally owned and everything is locally led. So that for us is the major thing. We just provide what they need from us, but in a structured pathway, because I think that I'm going to have to go back to my completion of pathway for the women, because I feel very strongly about that, because that's one of the things that I see we haven't actually done and focused and invested on.
Sorry, Audrey. I just want to add into that. That's great at that level, but we must always remember it always starts from this level down here. You know, training through medical school, training through nursing school is so critically important. You can't get the people to work at this level if you're not going to have them down here at this level. And that's where I think for us as a university, that's where we can work really well together as well. And get much more support. What I had to do was one of the surgeons couldn't believe it when almost 60% of the graduates in that year as house officers all started to have interest in ONG. He said, how on earth did you do that? I said, it's called advocacy. You know, you have to do that. You have to do that level, train them. And really, you know, once you get to a certain level, I was so grateful last week at the Randskog, 3 of the specialists that we trained through gynecologists, interested in fertility, and one the generalist in Tauranga, they came and they ran that workshop for me. I did nothing. They just came, they wrote up the cases. The case was a real case, 23 Pacific woman, and they ran the whole thing from the time she was diagnosed with endometrial cancer to the time that she in and out with abnormal uterine bleeding, didn't get diagnosed for ages, managed to come into for treatment, etc., etc. And the issue around fertility. Do you freeze her eggs at the age of 24 with cancer? And is she eligible for care? Those are the difficult questions, really important for our community. So these kind of things, you know, it's great ailing step that, you know, then they subspecialize into gynecologists where this level is happening, but you still have to start, you know, down from the ground level, from MAPAs, from right through to nursing, you know, Bachelor of Health Science, etc., really train them and really get them interested. And that's where also with and one of the key things, partnership around that level is colleges. You get your colleges involved, and that's why Pacific Society for Reproductive Health is very successful at the moment, because it's part of the global health of the Royal Australian New Zealand College of Obstetricians and Gynecologists. You get all that partnership, and you all work together. You drive from the bottom down, and then one day reach this level, at this leadership level, they can, you know, really run and do amazing things. Just a little bit more. Sorry about that. Thank you.
Oh, that's great. It's really important commentary. I'm going to, we've covered a number of topics here along the pathway of treatment, care and prevention, and held up a swab and so forth. So I would like to now invite the audience. We've had a very stimulating morning with Dr. Eilen's presentation this morning, and a number of really critical emerging issues that have been talked about in this panel. I would like to invite any questions from the panel before we take opportunity to make some final comments from. Thank you very much. Can we have a microphone, please? Oh, thank you.
Thank you.
Please introduce yourself.
Apologies. Bula Vinaka. Hello, I'm Lucy Castles. This afternoon, grateful to be inducted as an honorary fellow here at our centre. I'm blown away by the talent and the knowledge and the wisdom, the empathy and the care of the talented women on the panel. So thank you for the panel and facilitating, Audrey. I had a great talk with Ailing at the break. I was so blown away by her presentation on some of what I would see as scalable models for how to do health workforce capacity building right in the region. By context, I'm working with the Global Fund on HIV, TB and malaria at the moment across our region, and some of the learnings I've had from discussions with countries are that Pacific countries want to do self-capacity building within the region, being taught by the region. And I think some of the things that Ailing has raised in her presentation this morning, and Jude, you've talked about the role of the university, and Dr. Kara as well, you know, really important. And if the university can have a role in amplifying and facilitating self-capacity building, and by that I mean the fellowship schemes by mentors within the region to mentees within the region. We have had in the HIV-TB space, we've had a lot of interest and success with mentor to mentee capacity building between health systems using virtual means. I thought everyone was sick of virtual training, but actually between health systems in our Pacific region, it's a really vital lifeline because people can't afford to get on the plane to travel to Suva for a workshop. And likewise, we don't just want to fly in international experts all the time. It can be pointless. So I just wanted to pick that up and ask if you have any reflections on the panel on sort of embedding that self-capacity building by the region, for the region, picking up on the ethos of Colin and Cara and Jude's centre that is for the Pacific, by the Pacific. Thanks.
Anyone, I think, because it's a really broad question. Jude, did you want to comment?
Actually, during the break, Audrey and I had a bit of a catch-up and we talked about, I've worked with, is that coming through?
No, you need another microphone.
Okay, get to the point. Fred Hollow's Foundation New Zealand are an exemplary model of mentorship training led in country, and sometimes we keep within our own field, we look at what's happening in the cancer or even more specifically cervical cancer space, looking beyond that and actually understanding how did Fred Hollow's as a program of work, as a regional program of work, what is its kind of secrets of success? What are the things that have enabled this model to proliferate and be so profoundly successful? So again, looking around other areas and learning from that is one thing I would perhaps recommend.
She's asking me a question, but I'll answer it over a coffee because we've had huge success, as you know, training ophthalmologists and eye surgeons. Yes, sir. Please, a question from the audience for any of the panellists.
Mālō lelei. Not a question, but a comment, what I've heard so far. I think we, researchers, consultants, clinicians, have to understand that we have been telling people what to do for a long, long time. And today's presentation, what I heard is no change at all. There's something wrong somewhere. When we look at the process that we follow, it's very clinical, top-down approach that we have been using in public health and also. What I'm happy about is the term that you use, co-design. Because to me, that's the word of the day. Co-design is the way forward. Where, look at, we are trying to eliminate cervical cancer in the Pacific. We are still looking down from the top to the women. We haven't actually engaged with the women and asked them, how are we going to eliminate this issue here? This can be done through co-design, co-create, co-implement, and co-evaluation, which to me is the language that we are starting to use at the School of Population Health, Pasifika today. So I personally believe that is the way to go. Thank you.
Thank you. Naka. Well, thank you very much. And Sir Colin is doing this to me, so I know what that means. But before we wrap up, I'd like to just invite the panellists to make one comment. And this is the question I'd really like to ask. If there was one action that a government, a health system, or a partner, or a community could take in the next 12 months to accelerate cervical cancer elimination, what would it be?
It's easy. For New Zealand, Aotearoa is to fund an equitable elimination strategy.
Thank you. Thank you. Dr. Eileen, you're in the Pacific a lot. I'd be keen to hear your thoughts on that.
I've only got one response, and that's to invest in the people. And as the gentleman at the back said about co-design, that's what we've been doing, and that's been hugely successful. It's all been driven by the women.
Thank you.
Thank you, and exactly the same. I mean, it's just working with your colleagues, in that partnership. But in the partnership, for me, partnership at all levels, and building from the ground up.
Same again, and geography should not be a barrier. So I think enabling resources to get to where they need to be, breaking down the bureaucratic barriers that prohibit innovation and acceleration of the value of those resources. So whether that's a government contribution or a collective contribution, definitely resourcing to where it needs to be and fast. Thank you.
Thank you. Well, allow me then to thank all of you for a very stimulating conversation this morning on behalf of our colleagues in the audience. A big vinaka whakalevu, and thank you really for bringing your expertise and your knowledge and your hearts and your service to the work of our communities. Mālō. Thank you.
Sorry, Dave. Yes, it's a framed photo of me that you can leave in your garage. I'll sign it later for $1. I beg your indulgence, ladies and gentlemen. We're now going to move on to our next part of the program. This is Pacific Academy of Sciences, Enhancing Excellence in Science in the Region. And facilitating this next session is Li'a Manaya, Dr. Roeni Ngashu, who is the Executive Director, Pacific Academy. Oh, I'm doing a bit of rapping. Pacific Academy of Sciences and co-director at Te Poutoko Ora Akiwa here at the University of Auckland. With Roeni is Measina Meredith, Program Coordinator, Pacific Academy of Sciences. A round of applause for our next speakers. Whakamole. Me taki atu paka.
Mālō lava soi manuia, ma langi mā, kia ora koutou. It's really great to be back here with my te Poutoko ainga at Waipapa, Taumataro and Tamaki Makaurau. As mentioned, I'm currently the Executive Director of the Pacific Academy of Sciences, based in Samoa. There was a point where Colin said, Roeni, we need someone to be doing this work. So I thought about it, I was like, you know what, it's a hard job being based in Samoa, but fine, I'll do it. And so for us, I think this academy is actually pretty important, not just for the region, but I think for the world. So, we've spoken a lot about the vulnerabilities, the challenges, things that are wrong in the Pacific and all the historical inequities that we face. But at the same time, there's so much Indigenous innovation that is in our region. We've heard about the solutions that are currently in our region that are with us. And so how do we rectify these issues and these imbalances by sharing what is really good, what is working well in our region with the rest of the world, because they can benefit so much more from what is sitting within us. And so our Pacific Academy of Sciences, is I guess this transformative step in which we can address these types of gaps. So historically we know that most of the science and the research that has come from the region are by non-Pacific researchers. And this raises really clear ethical issues, such as those that we've heard about in AI today, around how information is gathered, how information is stored, and how it is shared. And so this also marginalises our Pacific researchers in our communities, and this marginalisation is also further exacerbated by historical structural inequities. And so what do we do about this? How do we, I guess, fix this problem and make sure that we can elevate science in the region by Pacific scientists? And so in October 2023, under the International Science Council and the leadership of Sir Peter Gluckman, President of ISA at the time, and Sir Colin Tukuitonga, we convened about 60 researchers in Samoa to discuss whether this is something that the region wanted. It's no point in trying to do something if we don't want it. At the conclusion of the workshop, there was a resounding yes. We want a Pacific Academy of Science. This led to the establishment committee in November 2023, and I guess the outcome of that was that we don't just want a Pacific Academy of Science, we want a Pacific Academy of Sciences. So natural sciences, applied sciences, and social sciences. And what is really important is that underpinning all of this work is Indigenous knowledge, the preservation of our culture, our language, and our history. So this establishment committee came together. They did a really great job, and we had an opportunity to launch officially the Academy during the Commonwealth Heads of Government meeting in Apia in 2024. And so it's at this point that, I said to Colin, yeah, sure, why not, I'll do it. And so last year, I went back home to Samoa, and we've now set up our permanent secretariat at NUS. And in February, we had our launch party. For those of you who missed it, there'll be another one in 2 years' time, somewhere to be determined. But we now have a secretariat team of 2.5 people, which always makes me laugh a little bit about the 0.5s. Anyway, our purpose is clear. Right. Our academy harnesses and unites Pacific sciences, applied sciences, and our Indigenous knowledge. What we want to do is make sure that we elevate our Pacific scientists, our researchers, and this also includes our communities, to ensure that they also have a place and a space within these global spheres of excellence. Okay. To action our purpose, these are sort of the things that we do: supporting Pacific sciences, which includes Indigenous knowledge, elevating Pacific scholarship, so giving a platform and a voice for our scientists to engage in lots of different work across the world, and also building Pacific capacity, which I think has been quite a really strong theme from this morning, and advancing global impact. So if we kind of do all of this work together, then we can have the kind of impact that we hope to see for our region. Our people, our trustees, which includes Sir Colin as our chairperson, so yeah, he's my boss again. Our council is made up of our founding fellows, so the very first fellows that were inducted during our Chogan launch include these beautiful people, including our professor here, Jemima Tiatia Si'au. Last year, we inducted another 13 fellows, and this year we hope to induct another 10 to 15 fellows, and so this opens on the 1st of July. Would love to hear from more women. As Professor Malakai said, more women need to lead the world. But also would like to have regional representation. So I think one thing that we need to acknowledge and also remind ourselves sometimes here sitting in Aotearoa is the fact that our region is quite big and we need this diversity and including voices from the North Pacific as well. Secretariat, so together these 4 people make 2.5 of our FTE, and our impact. All right, so this is our impact and our intention, is that through the work that we do, we hope that we can support scholars through best practice, that we can bring together the robustness and the rigour of traditional sciences, to make sure that we do generate evidence-based solutions, but that it's grounded in our cultural realities, that it's grounded in our knowledge, that it's grounded in our inga, our families, our communities. Okay. I'm going to hand over now to my lovely colleague Mia Sena to talk about our flagship program, the Young Academy.
Talofa everyone. As Dr. Rowani mentioned, I am the program coordinator, primarily focused on the Young Academy because we're still in the establishment phase. We're very young at heart, so don't be scared about the young. Here in the Young Academy, we're going to change that word to make it more meaningful and apply quite broadly to all the young at heart here and around the Pacific. Okay, so what is the Young Academy? We were launched in February. We were launched in February during the annual inaugural Congress. And it started off with about 18 people who attended the Congress, about 200 and something attendees. But of 18 of those people who thought that they were relevant and come under the term young, we got around the table and we slowly started to have a chat about why we needed to start the Young Academy. We talked about the shared challenges as researchers based in the Pacific or in New Zealand doing research for and about the Pacific. We talked about challenges of lack of access to opportunities, lack of access to funding, so scholarships, needing more support, mentors, but not just any mentors. It's mentors of the likes of yourselves and our esteemed colleagues who have been presenting today with their expertise in different fields. We talked about having an impact as a Young Academy and providing that support at the early stage of a Pacific researcher's career and supporting them right through to get to eventually where Sir Colin is now, comfortably sitting in the front as a fellow of the PAS. So the objectives, obviously, of the Young Academy align with the PAS, but more so focusing on advancing science, policy, and education, solving those regional, and global problems from that Pacific sort of perspective, promoting excellence over seniority, and supporting emerging scientific communities, and as well as doing that all through collaboration and co-design, as our colleague in the audience sort of touched on earlier. So here are some pictures of our Young Academy attending the Congress. Diverse colleagues from around the Pacific. We're meeting about once a month, virtually for now. We've managed to bring together a small cohort, and that cohort is growing in interest. So like I said, from February, there were 18 interested people at the Congress, and now we have 90 plus researchers from throughout the Pacific engaging virtually for now through this network that we have of practitioners, of scholars, of industry experts from around the Pacific. We are growing leaders in terms of capacity building. We have brought together a small reference group. This is essentially the executive committee of the Young Academy, and I'm very honored to introduce and also highlight that we have the chair of our reference group here, sitting over there, our very own Dr. Betty. She'll be presenting later in a concurrent session. Providing that governance and oversight and coordination in terms of the kinds of activities that the Young Academy want to co-design and also implement to support young researchers. The Young Academy is also a leadership pathway, as I mentioned, to sort of to grow that sort of governance and that expertise in their respective areas, and also to contribute that in terms of governance to the wider network in the Pacific Academy. We have here the reference group I mentioned, and Dr. Betty is our chair, but also our colleagues from who I understand are also joining online. We have Emma Oliver from the PNG. We have Nick Moiono from Samoa, Selane Taidea from Cook Islands, and our very own Francis Sakato, also based in PNG, Port Moresby. So that's our young sort of reference group there, young at heart, young in spirit, but so eager to do more for the Pacific through their research areas. We have some upcoming events and opportunities. We have a monthly meeting, as I mentioned, and our next one is actually on Monday, the 29th, so this Monday coming up. Join us if you want to learn about the kinds of things that are inspiring young people, young researchers, and the kinds of talking about what they want to see the Young Academy roll out in terms of a program of support. And I mentioned one of the key things that they do want to see, a tangible mentorship program made up of mentors that are foremost our fellows, who are quite willing and able to give virtually their time, but also their expertise. We also have coming in the works, I mentioned that scary term young. We're going to change that, so we're rebranding, watch that space. And postgraduate qualitative research methods workshop being delivered by our very own partners, our Monash University colleagues. This will be delivered in Apia. Details to come, registration will open soon. So watch out for that opportunity. will also be coming back as a young academy and also led by our Dr. Betty chairperson to attend the He Pito Mata in Auckland in September. We're very eager to attend this particular event and also use it as a platform to launch some key things for the Young Academy, the strategic plan and our work plan, and also seek some investors to fund some of our activities, and also to launch our Young Academy mentoring program I mentioned. So there's still more to come. Feel free to contact me or have a chat later on outside in the corridors when you're available. One of the key sort of opportunities in terms of funding our early career researchers and our Young Academy researchers is our Tupaya research grants. This is kindly funded by the New Zealand government through the Ministry of Foreign Affairs. So our first round opened in February, and it's taken quite a process to get there. And today's an exciting day because Sir Colin will come up shortly to announce our round 1 awardees. So stick out for that. More to the research grants. It is a research funding facility empowering Pacific early career researchers and really targeting Pacific researchers based in the Pacific, but also those who are in New Zealand and Australia doing research about the Pacific and for the Pacific. So it is, the next round opens in September, so we'll launch that around about the time of He Pito Mata. It's about $50,000 worth of a grant. Stay engaged, stay in touch through our PASS website and our Facebook page and Insta or socials. And without further ado, kindly invite Sir Colin to come and announce our round 1 awardees.
So Chris, the Manake group, I spoke to them yesterday or the day before. One is you let the team do all the hard work and you take the glory. I also told them if you're a good leader, you take the hits and you share the bouquet. So I'm going to do complete opposite today. But see, I told Roanna, you do the work and I take the glory. This is how not to do leadership, Manaki. But fantastic to be able to share with you the folk through the process that Ms. Hina outlined to support young people. And so a pleasure to announce the round 1 awardees. I see Christina Newport in the audience, I think. Are you here, Tina? Yeah, so congratulations. Tina's based in the Cook Islands, obviously hosted by the University of Auckland. Her project is on Pacific knowledge, global conversations, publishing climate mobility, e-mobility research. Tina is a Cook Islands researcher and a policy specialist. So congratulations, Tina. The second awardee is Alexandre Burles. My French is terrible, so I apologize if I've butchered that pronunciation. Alexandre is from New Caledonia, the Institut Pasteur. Looking at antimicrobial resistance in meat and domestic animals. Alexander is a young scientist, joined the Pasteur Institute in New Cal in 2020. His research focuses on the study of AMR using One Health approach, combining culture-based methods and genomic and meta-genomic capabilities. The third recipient is Josefa Percival. Josefa is Samoa, Hawaii, and hosted at the National University in Samoa, looking at remote sensing, detection, and monitoring of the invasive vine. I'm not even going to try and pronounce that.
obviously an important problem in the region. Dr. Joseph Percival is a geospatial scientist and researcher specializing in GIS, Geographic Information Systems, remote sensing, and tropical forest dynamics. And the fourth recipient is our colleague and friend Emma Powell. Emma is the boss at Te Puna Vai Marama in the Rarotonga. Her project is Atu Nui Maruarua, an island and its houses. Emma is the director of Te Puna Vai Marama. There's something seriously wrong here. 2 Cook Islanders and no Fijians. I just encourage you from Papua New Guinea to tell everybody the next round in September. But Emma works in the Cooks, a scholar of Cook Islands and Pacific Knowledge Systems. Work focuses on Indigenous research methodologies, governance, genealogy, and policy development. So to all the recipients in this round, congratulations. To all the potential recipients, apply in September. Thank you very much.
Thank you, Sir Colin. And that concludes our presentation. Feel free to come and speak to either myself, Dr. Roani, or Dr. Betty, if you want to learn more about the Young Academy and Pacific Academy of Sciences. Thank you.
Another round of applause. And congratulations to our award recipients. I fit right in if there's a young academy, as you can see. Obviously fit the age group, so 6, 7. That's what us young people do. How very demure of you. All right, beautiful people, we're now going to break for some mea tokoni. But before that, if you're missing your phone, I have it right here. The last song you listened to was Celine Dion, The Power of Love. Oh no, sorry, that's my phone. Sorry. And speaking of the power of love, we have amazing medical experts here, but we now acknowledge the other doctor, God. So we're going to have a prayer, and I'm going to ask Dr. Ivy, who is a cousin of mine, who is going to growl me after this, because there's the element of surprise. If she can please bless our mea tokoni, then after that we'll break. God loves you, Ivy. Thank you. Smack me later.
Tau lotu, mau whawhtaia te ike whainga māli e koe ni, pak mau whamālo te ilo, mo e poto, o kua me he wani, i toko ni anke mau kakai māmane. Tā pāki mai a mea toko ni, whalahe pe mau moi lelei, wawhasi suka ko mau whamo oi. Amen.
All right, beautiful people, tangi o tumas. We're going to break lunches here, and then after that we'll be back at around 12:30, s'il vous plaît. And we're going to continue on with mental health across the Pacific, and then after that we'll break up for the concurrent session. So enjoy lunch, and we'll see you very soon. Me taki atawai.
toki me ane whakalele loto ko e te mai e fu te moro. E te mai o ka mai ua po ka kahelu wa o ne si oro. O ne maraki a ho kusino, e a didn't see me coming. Couldn't leave the game alone cause it's needing me. Flexing on the wicked with no Jesus peace. Took a couple L's, but I get up without fail. They see me doing really well and they don't want that. I might fall down, but I don't fall back. Leave a message, I don't call back. Have I seen her? Yeah, I saw that. A little disappointed cause it wasn't all that. She felt a mention, you and I saw bad, my bad. I'm paranoid, so now I watch my back. I gotta right my wrongs and right on fast. Right on. I gotta right my wrongs fast. Right on. I'm making all these dudes mad. Right on. They hoping I ain't coming live. Yeah. Right on. They suffocating the game, I can't let it breathe. In it the long way and keep it shine brief. All the haters like fake, deep down they do believe. Boy, it's never too late, you should get that degree. That ain't your whip, that's a leash. At least you can cut all your losses. Not everyone can be the boss, but send me a decent deposit. My pen just might make you a star. 100 on the dash, pedal to the floor, getting to the cash. Mama told me take it slow. I'ma get it how I can. Throw the money coming slow. I know I should be grateful that the money coming on. Heard them say that I done fell off track. I don't know what they say. Can't make everyone happy and it's sad. Can't get hung up 'cause life just moves too fast. Right on. I better right my wrongs fast. Right on. I'm making people out here mad. Right on. I know they hoping I won't lie. Right on. Yeah. Ah, la, la, la. We are the people of Kuki Arani, Tapiri Maiki Aura Ura Taua. No matter where you go, no matter where you are, we take our people in our heart. Ariki Baine, Ariki Tane, Kuki worldwide, Kuki Arani.
It's ladies by Wale, yeah. We're here to have a really lit party tonight. Let's round up all the ladies. So if you're single, tonight's the night for you. Tati tati apa? Kau tato kitilai te apo. Kau laula takavili tu kite muli. Liko mai tu nawa aka scary. Tuki left, tuki right, ula woleti.
We are the children of Mainetama. Kau laula takavili tatue. Ula ula tatue, ula ula. Kaula takumanea. We sing like Kaula takumanea. Kaula takumanea.
There's a rose that's growing in your heart. Can you see it? Oh, the way it blossoms like this time of season. I can tell by the way that you talk, there must be a reason. feel it. Oh, the way it blossomed like it's been for seasons. Ooh, oh, no. I can tell by the way that you talking, I must be the reason. 'Cause if it's loving that you need, then I can be the one that you can need. Be the one, babe. Be the one that you can run to. Be the one that you can run into. Be the one that you will call on when the world is crashing down. Be the one that you will turn to when no one else is around. Be the one that you need. Be the one, be the one. Be the one that you're depending on, yeah. That you depend on, be the one that you will lean on when you fall. Embrace all your flaws. Nothing left but all you need. Be the one, be the one. Be the one that you can run into, yeah. Run into, yeah. Be the one that you will call on when the world is crashing down. Be the one that you will turn to when no one else is around. Be the one that you need. Be the one for you, yeah. Be the one that you're depending on, yeah. Be the one that you will lean on when you fall. Embrace all your flaws. Nothing less but always more.
Noise, noise.
Hey mama, hey papa, do you mind if I dance around with your daughter? It gets a little bit closer. Hey ma, is it a pretty, pretty minor? Moving your body like a water, like a fish, I'ma catch you like a culture. I'm not gonna let you get away. Away, you know that I need ya. Searching the world just to see ya. Up and I see you go. Why you want to go? Oh, do you mind? Do you mind? Do you mind? Do you mind? If I put my hands around your waist, I'm not gonna let you go, let you go, let you go, babe. Hey mama, hey papa.
Testing 1, 2. Excusez, Madame, Monsieur. Can I please invite you all to make your way back to your seat? Excusez, Madame, Monsieur. Paging all passengers, flight Te Poutoko Kiwa Research Symposium. You are now boarding. If you can please find your seat and bag, or bag and seat. Please make your way over to your seat, and then we will continue with our next session. Welcome to you all once again. If you're joining us online, nau mai, haere mai, piki mai, kake mai. Welcome back to today's symposium here at the Fale Pasifika at the University of Auckland. So we're going to commence our next session in Lua le Miniti, or Lua le Minute, and then we'll continue on from there. So grazie mille. sir. Yeah, it's good. Everyone's moving. It's on time. Yeah. Whamore, can we put our hands together for the Sā Māori coffee who have been here with us? Ka kitera. I'll see you at the car park. Oh, see you soon. Yeah. All right, haka he tai lahi lele whakawhetai lasi e nā Mālō le soifua maua ma le lange mama hau eki pia mo e kāinga. Warm welcome to you all to the Te Poutoko Ora Akiwa Research Symposium. My name is John Pulu. If you're joining us online, where have you been all my life? It's wonderful to see you. We're going to firstly acknowledge the wonderful people that have been part of today's porokalame, or porokaramu. Can I please acknowledge the live stream team from Loopstream, Lenny and the team, thank you very much. Photography, we've got Yvonne and Ben, Mālō Apito, Fale Alili. The Sā Māori coffee. Flame Tree Catering. Fantastic food, eh? Yeah. While you all were eating the food, I was helping myself to the cutlery because we need some forks at home. Moving right along. Also, a big thank you to the IT team and the Fale Pasifika staff, Mālō Apito. Thank you very much. Mālō e ngā loe. And thank you for helping with our polokalame. Beautiful people, we're now going to move on to our next panel, and this one is on mental health across the Pacific. Now, this is going to be facilitated by Whanoia Professor Jemima Tiatia Siau, who is the current Pro-Vice Chancellor Pacific here at the University of Auckland. So please join me in welcoming Whanoia Professor Jemima Tiatia Siau. Joining her on the stage, we're going to have Associate Professor Sam Manuela, Associate Dean Pacific Faculty of Science here at the University of Auckland, Dr. Etuini Ma'u, Consultant Psychiatrist, Senior Lecturer at the University of Auckland, and Denzel Siakia, PhD Candidate, Project Manager for Pacific Health, Mental Health Survey Series. So please join me in welcoming all our wonderful guests for this next panel on mental health. Naka whakalefu.
Mālō. Mālō lava le soifua malangi e mama, whaftaitele lava mo le awangoa. Kia orana tātou katoa toa, mālō lelei, and whakalofa lahi atu. To our panelists, welcome. I'll get straight into it because I don't want to waste time, and I think the audience will want to hear more from you than me. So briefly, if each of you could talk about your project and introduce your project. Denzel, we'll start with you.
Test. Fakatalofa lahi atu, kia matolosi, kia ora koutou katoa. So as JP mentioned, I am the project manager for the Pacific Mental Health Survey Series. And the PIs for that project are Sir Colin Tukuitonga and Professor Judith McCool. Now, this project is actually funded through MFAT and it's commissioned by the Polynesian Health Corridors Program, which sits under the Ministry of Health, New Zealand Ministry of Health. And so originally this project is actually a prevalence study in the Pacific region, and I don't think it's news to any of us that mental health data, especially prevalence, population level mental health data is lacking in our Pacific region. And so this survey series is aiming to address that gap. So we were commissioned to do this study in the 6 Polynesian countries. So that's Tokelau, Niue, Cook Islands, Tonga, Samoa, and Tuvalu. And so to date, we have completed data collection for Samoa, Tonga, Niue, and Tokelau. And I believe Aotearoa has completed the data collection for Tuvalu. And so Cook Islands, there's been some studies already, and so Sam will speak to that, I believe. But that's a little background to the study.
Kaulahi, Dr. Manuela.
Kia rana tata katoa. So coincidentally, I applied for funding through Health Research Council around the same time as this project was beginning as well. And so this project is called Te Akarata Marama, which is talking about the dawn of new knowledge, because for the same reasons we had very, very limited mental health data at the population level. And so we have completed data collection for that in the first phase of that project. Unfortunately, difficulties arose because of COVID, and so we weren't able to get around to all of our pāinua. However, we did collect a substantial sample size through Rarotonga and Aitutaki, which eventually constituted about 10% of the adult population. So we're really happy with that. And so our second phase now is refining some of the measures that we used in that study. So we selected measures that were specifically used by Te Marae Ora and the mental health team in the Cook Islands. And we've just finished a translation on one of the measures, a translation and adaptation of those. Next phase will be to doing some field testing of the psychometric properties of that particular measure. Pairing that with a more qualitative oriented study focusing on mental health experiences and needs of Cook Island youth. And then again following up with another survey, because we identified prevalence in the first survey, and then following this we can identify incidents over the kind of 5 to 6 year gap between those two measurement points.
Dr. Ma'u.
What Denzel said. So I was involved in the background for most of the studies, and then on the ground for Tonga and Niue, just providing the clinical input and some of the research input as well, and happy to talk a bit more about that, but exactly the same projects as Denzel's described.
Okay, thank you very much all. Staying with you, Etu, for each of you, what have been some of the most meaningful outcomes and successes you've found from the project so far?
Yeah, thank you. Look, it's always going to be difficult studying mental health in the Pacific. There are a lot of issues that most of you are probably aware of. I think fundamentally the first question is, who do we want the data to represent? I'm really pleased that Pacific Health Corridors funded this project to get a true community prevalence study of common mental health disorders in the Pacific. I can speak from a Tongan perspective. We know there have been a few kind of hit and miss surveys carried out over the years, the most recent of which was a 2017 one run by I think the WHO out of France. But there's always issues with how you sample, there's always issues with how you deliver the screening tools, there's always issues with who delivers it. So there's always a lot of question marks around how representative the data actually is that you're collecting and how much you can actually believe the results that you're finding. Not going to lie, our project in the Pacific region has had its limitations as well, and happy to talk about those later. But fundamentally for me, I think the biggest learning was this is what a true community partnership looks like in the Pacific, in the 4 island nations. Denzel can talk a bit more about the different approaches we had to take, the compromises that we needed to make along the way, how data was collected. Yes, we all want to adhere to the scientific method as stringently as possible, but there are practicalities along the way that mean that if you're going to compromise, you have to compromise in the best possible way. Thank you.
Just to carry on from what Edu was sharing, I think one of the biggest unintentional maybe outcomes of this study was being able to take mental health specialists from here to support the local staff that are very overworked and under-resourced in the Pacific. And so Dr. Etu was able to join us for Niue and Tonga. We also had Dr. George Tuitama join us in Tokelau, and he also kind of ended up running the study in Samoa. And so we're very grateful for these clinicians that have that take time to come and support the local staff. And then I think also being able to upskill some of our local staff. We actually have one of our field workers, Ashley, who's here with us today from Niue, and so it's great to be able to give them some experience into research. So I think, yeah, some unintentional outcomes, but I think very important for our Pacific region.
Yeah, I think one of the most meaningful things that I've experienced when we were doing data collection, I didn't do it myself. I had a wonderful team of people who were going house to house collecting data, but we'll have debriefs every couple of days because it's really difficult information that we're collecting. We're asking some very personal questions. But a lot of the feedback that we were getting from the community was the recognition that there was a lot of stigma. But despite that stigma, they were very happy to take part in the research and give their data for this particular study. And so that for me kind of sparked some ideas of like, I guess there's a perception that stigma exists, but there's also the kind of reality of what that stigma means for people in their day-to-day life. And I was getting an idea that people understood that stigma existed, but they didn't necessarily always enact upon that stigma themselves. And so I saw that as an opportunity for some additional research, which I don't have funding for yet, if there's any funders in the crowd, to kind of look at the ways in which people engage with mental health and their own understanding, because acknowledging that the stigma is there, but still wanting to take part in something, showed a more collective efforts to addressing this at a more national level for me. And so I found that really, really meaningful as well. And one fun thing that happened was in Aitataki, just on my scooter, going to the next thing and getting waved down by one of the mamas who was like, I just want to talk to you about my son, and I think he's experiencing anxiety. And just being able to have those kinds of conversations and knowing that despite stigma might exist, that people do want to talk and they want to understand, and there's probably really good community-led solutions to addressing and preventing a lot of the issues that people experience. It's just a matter of finding ways to bring that to the surface and make it sustainable for communities as well.
Thank you, Sam, for that. In the audience, we know as Pasifika clinicians or researchers that relationships are key to how we operate on the daily in every situation. If each of you could share for our aspiring researchers and of course for our seasoned researchers, how you collaborated or built a strong relationship as a component of each of your research projects. One standout for you.
So I think for this particular research project. We're very fortunate that we had Sir Colin leading the team because he has established relationships with a lot of our Pacific partners, and so we're very grateful to be able to leverage off that. But then I think as part of that, as we went to each country, we, from inception up until dissemination, which is still happening now, we worked very closely with the local leaders to make sure that the way we not just conducted the study, but designed sampling and etc. was tailored to that specific country. And so I think the genuine partnership, being very transparent and open about the kind of resourcing that we can provide and what asking what they need, what they'd like to get out of this particular project as well. Not just meeting our deliverables, but being able to meet what they need. I think that was very important. And so, yeah, those are my...
Thank you.
Yeah, thanks, Denzel. Look, I think socialising any research to the public before it starts is important. We were very lucky in Tonga that we had the Honourable Siare Akawola, one of the pathologists who was the Minister of Health but had just stepped down. And he, went out to the public on radio, on TV, and actually socialised the idea of it. So it didn't come as a complete shock when people were door knocking. I think, as Denzel alluded to, picking who your front-facing people are is important. One of the reasons that I think the previous survey failed was they had student nurses going out talking to the public and collecting information. And I think particularly in a Tongan setting, having effectively young females asking very personal questions about disorders that are already stigmatised means that the answers that you get probably aren't representative. So we were very careful, both in Tonga and in Niue where I was involved, that the people that you trained up, the researchers that went out into the field to engage with people in screening were age appropriate, gender appropriate, and people that the community would actually trust and therefore want to share with. And even then, as Denzel can probably talk to, sometimes even that wasn't enough.
Excellent.
And I think some really good relationships I established was with Te Punawai Marama, the Cook Islands Research Centre, and USP Cook Islands as well. And also the amazing researchers that are living in the Cook Islands too. I see Dr. Tina Newport sitting in the audience over there. But so, those relationships really helped with the kind of the logistics and the infrastructure of the research, and the other connections with Te Marae Ora, and we had one of their clinical psychologists on our team as well, who facilitated connections with media outlets as well. And so, Ita was saying, we were advertising and communicating before the data collection had even begun, so we could socialise the idea that yes, we come into your house and we're going to be asking some very, 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 very personal questions. But there was awareness of that, and there was a familiar face delivering that message as well. In addition to people were just happy that there was a Cook Islander there from New Zealand coming back to the Cook Islands to work with our communities too. And so part of it was my own personal relationship with my family, and my sister was my little project manager for but everyone in the Cook Islands is connected somehow. But it was great to kind of have a fully Cook Island led thing, and Cook Island developed as well, and so we were able to kind of identify those relationships between different institutions and connect through our shared interests.
Mālō. So what innovative or unique thing do you think has come about via your project that perhaps someone could pick up and run with it with their own projects?
The timing of our data collection was a bit odd because COVID didn't come to the Cook Islands until 2022. And when we saw that community transmission was occurring, that was right in line when we were about to start data collection. as well. And so if you were in Kokainas at the time, if you had COVID, the Ministry of Health would come and put a yellow tape and red flag outside your house. And so that means when a household was selected and we saw the flag and we saw the tape, we're like, right, we can't do that anymore. So random selection kind of had to go out the window there. And so we had to do a bit of okay, we'll just go to every second house that is not quarantined. But I guess to introduce more randomness into the sampling, we would ask to speak to the person in the household who has the next birthday. And so we had to just kind of be creative in that instance, that our sampling frame was just not going to be possible due to what was happening at the time. But we could introduce more randomness to kind of maintain as much statistical rigor as we could by, kind of introducing more randomness into the selection of people within the household.
Look, I think fundamentally the most useful part of this piece of research is actually getting baseline mental health prevalence data on common mental health disorders, and in particular psychological distress and alcohol use, which, yes, are screening tests, so potentially aren't quite as robust diagnostically as a diagnostic test, but it gives us a really good baseline to build off. It's data that the respective countries can use to start making an argument for better mental health resourcing. It's data that then can be used as a baseline for future surveys down the line.
And I don't think it's innovative, but I think if I were to share something to be used for further research, it would be just reiterating the relationships and making sure that they're genuine partnerships with the people that you're working with, because we spent a little while building those relationships prior to conducting the studies in the countries, and having those relationships really helped when things during data collection, etc., when things would pop up, it just helped having those relationships and being able to go to specific people and kind of knowing that you can trust and count on those people to help move the work along.
Thank you all for those wonderful responses. Being in the mental health sector, or mental health and addiction sector, you normally absorb some of that heaviness, or see things or hear things that you won't conventionally hear on the daily, but things that could perhaps break you if a day were to go bad. How have each of you looked after your own mental health and well-being in conducting this type of research?
Look, not gonna lie, it was interesting. I think one of the things I really struggled with was you are working in under-resourced mental health settings in effectively low middle income countries. So the resourcing isn't there for mental health. So the tension that I always felt as a clinician was, what do we actually do if we identify a disorder? What do we do when we're screening for risk and we identify elevated risk? How do we treat them? Where do we send them to get treated? What does the longer term follow-up look like? And it becomes a really interesting tension, because on the one hand, I want to help, but on the other hand, I'm only there for 2 weeks. So it was about liaising with the local mental health units as much as possible, which does come with its own difficulties. I think after 20 years in the job, you do learn to compartmentalize and detach a bit more, but that was probably the hardest bit for me.
For me, because I'm the project manager for the study, I think my main priority was the health and well-being of our team. And so each day we'd have our daily debriefs, and I'd also just check in on each of them individually as well, just to make sure they were feeling comfortable. And some of our local field staff weren't actually clinicians. And so, as Sam mentioned, sometimes people would bring up concerns or queries, and so it was really good to have Etu and Dr. Anya, actually, she was a psychiatrist in Niue with us, because they were able to kind of answer those questions, and just to have that expertise with us in person rather than having to rely on a phone call or video call. And yeah, I think that's all.
Yeah, so our field team, I set up debriefs with them after every kind of major data collection aspect they were going through. And also we built into our training beforehand on how to manage sensitive disclosure of information as well. And so we had a trained clinical psychologist on our team who could provide that additional training to our field staff. And for me as well, kind of, looking at everything, hearing all the stories as well, and people would just come to talk to me as well. They would call me the mental doctor, and I'm like, I'm not actually a clinician, I'm a researcher. So, but part of it was, kind of compartmentalizing aspects, and I had good support around me as well. So I had fortunately I had my family there. I made new friends there as well, and I knew people who understood the kind of heaviness of what we're looking at as well. They understood the heaviness and the taxing aspects of research, and I could vent and complain, but also kind of find solidarity with those with that experience. I also had a working professional on the team as well, so if there ever were times that I needed some kind of support for myself, Dr. Evangeline was there as well. So we built those support mechanisms into the data collection process for ourselves.
Excellent. Wonderful. And you're still all breathing and sitting with us now, so we have time for perhaps 2 to 3 questions from the audience that you'd like to ask our wonderful... Yes, Eseta. Comment?
Anything to do with community consulting, you have to have the connection and you have to have the relationship. That's key, and it has to be. And don't knock the nurses, Edwini, because the nurses do a hell of a lot out there. And it's about sending the nurses of that area to those people. Yeah, they know. Thank you.
Thank you, Eseta. Tukalan.
Without disclosing the community, the island, or any of that, because there's obviously a process to be completed, what did you find that you didn't know before? What surprised you, given your 20 years in the business, so to speak?
I think, up until the surveys happened, a lot of our understanding of the prevalence of distress and mental health in the Pacific, we've extrapolated from New Zealand, particularly from Pacific people in the New Zealand Mental Health Survey, or Te Rauhine Ngaro, which is now probably 25 years old. So I went in with an expectation that we would find similar levels of distress, similar levels of diagnosed mental disorder. And by and large, what we found was a lot lower than Pacific people in New Zealand, both in terms of distress and in terms of diagnosed mental disorders, depression, anxiety, PTSD in particular. I do have some question marks around the prevalence of mental health disorders that we found. I think there's a lot of issues with the languaging in the tool that we used. I think context matters, the way it's translated matters. For example, there are many... If we think about a diagnostic label as a word that gives us a shared understanding between two people about what we're talking about, and there's no common word for something, then it's going to be very difficult to get that message across. So there's a few issues with the prevalence of mental disorders, which came in a lot lower than we'd expect based on New Zealand data. The psychological distress questions, I think, are a lot more general, but again, probably suffered from a little bit of translation. And levels of distress did appear to be lower than what I was expecting. But overall, look, I think it's a good starting point, and we can refine surveys, or we can refine what we do and repeat this and see what happens.
Mālō seifua. My name is Matala, or I work at Te Whatuora Health New Zealand, and I'm currently managing a kaupapa within Ora Health. We've got this great big KPI, which we love to set around trying to get those over 90 days on our oral health surgical wait lists to receive treatment by the 30th of June, which is next week. But what I've seen from over 90 days, there's about 41% of our Pacific patients who sit within the special needs dentistry category. So these are patients who have, in your sense, mental health disorders, complex behavioural needs, who their treatment keeps getting prolonged and prolonged because of this complexity, and they will not be able to be referred outside or outsourced because their referrals will be declined due to their complex needs. So I would be very interested to hear how can your research and evidence help be translated to that frontline healthcare delivery, just so that we can improve some of, in a sense, we don't even have clinical guidelines around treating Pacific patients with these special needs dentistry, within special needs dentistry. And there's a lot of intersectionality there, especially with patients who are also have disabilities. So there's a huge gap in that evidence. Maybe a future research project as well. But yeah, I'd be really keen to hear how we could better translate some of the evidence and bridge some of those gaps.
I haven't thought that far ahead yet. But I guess one thing that I was not going to answer your question directly, but one thing that we did in the Cook Islands survey was we asked questions that I hadn't seen asked before in this particular survey. So I have a background in social psychology, so I was interested in identity and well-being, but also interested in intersectionality as well. So I was asking questions around gender diversity and sexuality. And disabilities as well, looking at measures of disabilities too. And so from there we're able to identify we can identify more nuanced expressions or kind of prevalence across particular demographics. And so what I could imagine, which I don't have, but if we had a kind of a more comprehensive health survey that looked into kind of more specific health conditions that people have or are experiencing, and how these might be connected or related to the mental health status. That could be one way in which that could potentially start to translate into frontline services, and so you can see if there are, I guess, kind of any kind of particular patterns that we can identify that would be kind of informative for those frontline things. But in terms of a practical sense, I'm a bit limited in my abilities there. But I guess from a data perspective, as asking some of those more granular questions that we can start to see where those patterns exist.
Thank you. You may have a clinical response. No, they're shaking their heads. Okay, with that, I will end your pain, and we will shut down. We will shut down the session. Whawhataitele lava for your insights. It's been a pleasure.
Mahalo nui loa, thank you very much. Another excellent panel here with us this afternoon. We do have some gifts here for our speakers. It's just a box of hand sanitizers, luxurious ones, of course, brought to you by Palmolive and Dettol. Beautiful people, we're now going to move on to our next panel. Can I please invite back onto the stage Lia Manaya, Dr. Roeni Ngashu, who was a previous speaker earlier. We're now going to turn to climate crisis and its implications for well-being. And joining us on the stage for this next panel is Professor Yvonne Underhill-Sem, the Director of Business Development Pacific Studies here at the University. Dr. Angela Bancheri, Science Leader on Climate Health Impacts at PHF Science. Dr. Christina Newport, Principal Researcher at Aotearoa Consulting, as well as Apolisi Wangalevu, Lead Climate and Respiratory Health Program, Manaki Climate Resilience. So, whamole mole, kere kere, or as they say in Rotuma, whinga lelei, please come forward. We're going to do a language class while we're here. Not that anyone asked for it. Vinaka Wangalevu. I start to talk with a Fijian accent every time I start to meet my Fijians. You can guarantee that we will roll the R's. Naka. We'll see you very soon. Over to you, Dr. Ngashu. Vinaka, Vinaka.
Thank you very much, John. Always entertaining. Yeah, so very, very glad to be here to have an important conversation on climate change with some friends and colleagues. And, you know, as per usual, Colin's got me working very hard today. But I think, given our panel, I'm pretty pleased that we also have really good representation from the region. And so I think what I might do is just get everyone to introduce themselves a bit more, expand on like the work that you've been doing in the space, but also talk through like an important project that has used innovative, that word again today, research methods with communities. And I'll just start with Yvonne, if you can, I guess, give us a bit of an overview about what's happening in the region, given your expertise.
Kia ora, can you hear me? Could I just please ask for one thing first? I'm just going to get a picture. If you weren't here, we wouldn't be here. So, so kia ora ki a tātou katoa, whakalofa lahi atu, and warm greetings. And I'm Cook Island Niuean heritage with very close family ties to Papua New Guinea, and currently a professor here in Pacific Studies. And just very briefly, last week I was in Suva, without the accent, where we were talking about Pacific peace and security. And it pertains very much to what we're talking about today, so I'm delighted to be here. But more than that, was a co-lead, the particular project, and there were 3 of us who led a fabulous project, 7 Pacific countries, looking at climate mobility. So I want to acknowledge the co-leadership and also a very large group of other folk who are part of that. But thank you, Roani.
Kia ora, I'm Angela Bascheri. I'm currently at the PHF Science, so is a new PRO, is the New Zealand Institute of Public Health and Forensic Science, and I'm coordinating the climate and health work. I'm interested in looking at the translation of science to policy and how can you influence policy with science. I'm not so sure to what extent I have succeeded, but I'm working on it. And before joining PHF, I used to work at the United Nations Population Fund and trying to establish the work program on climate and health, and specifically climate and impact on women. So evidence is important, and PHF, the work that we are doing now is we are being renamed, we are working on the new strategy and trying to come up with a narrative of the value proposition of the organization on climate and health. We work on infectious disease, pandemic preparedness, and also trying to design solution for policymaker, urban planner to make decision on climate adaptation. So a lot of the work we're doing is on heat and health, so the impact of the heat on health, and digital twin tools, and we can talk about this later. We're also looking at climate-sensitive disease, such as looking at the impact on waterborne disease, AMR. We are kind of growing global evidence that AMR is also increasing with climate changes. And of course, the emergence of the vector-borne disease. So we're looking at all of those. And so in the discussion, I'll give you some my 2 cents of on insight on some of the work that we're doing. Thank you.
Kia ora, Nisam Bula Vinaka, and as I was introduced, I am no doctor, not a professor, just a young researcher from Fiji, and I'm honored and inspired sitting with respected climate health researchers here at the Fale and also the Pacific Valley. Thank you so much for the opportunity. I work with Kiwa Kids Fiji and on a project called Manaki Climate Resilient. So essentially we work on advancing solarization for climate vulnerable health facilities in Fiji, especially those that are located in remote locations. We also work on capacity building for community health workers and the general communities, improving their knowledge on climate change and also on respiratory health. We work with the team from the University of Auckland, the academic team from the University of Auckland, as well as technical expertise on solarization. And the last bit is also something which is new for Fiji, and I also something which is also new for the region is on laying the foundation for air quality research. So we are starting that also in Fiji, and we hope to progress that as well. And also before the Climate Manaki project, Kiwa Kids worked during COVID-19 and after COVID-19, essentially for the provision of oxygen concentrators. This is something that we work together with the Fiji oxygen program, as well as the Fiji biomedical and oxygen program, just to ensure that we have medical oxygen available for respiratory illnesses in Fiji. Thank you.
Is that working? Kia ora ana tātou katoa. Special thanks to everybody, to the Pacific Academy of Science, who have actually been really supportive of the work that I've done of recent. But I also want to just quickly acknowledge some people in the house. From the Cook Islands, we have Te Marae Ora representatives with Metua and Karen. I saw her earlier. She's our Health Intelligence Unit person. I also want to acknowledge Tracy Mawhelio, who was a part of our Climate Mobilities project that I was involved with Yvonne and Rowaney. Nice to see her back again. And of course, Sam Manuela, our colleague, who lives the life over here in Aotearoa while the rest of us struggle back there in the homeland. So thank you all. In terms of major projects, I can say that I've been involved and continue to be involved in a whole range of projects at different levels in terms of ethics around research governance, also implementation of research projects and implementation of climate change related projects here in the Cook Islands. But the major project that I'm involved in is about the wellbeing, prosperity and future of our Cook Islands people and our country as a whole, for our people that are here in Aotearoa and other parts of the region and also back at home. That's the project that's most passionate and that I'm most kind of focused on.
Thank you, and it's really great to have you here actually, Opalusi. Like, you are an example of what we've been trying to do in terms of capacity building. Overwhelmingly, lots of the research about climate change in the Pacific is actually based on data sets, quantitative data, and done by, again, non-Pacific researchers and I guess researchers from the global north. So with that, there I guess are a lot of limitations and also missing the important diversity in our Pacific region. So maybe, Yvonne, are you able to speak to that?
I'm very happy to speak to that, and acknowledging, of course, that I was trained by non-Pacific people. Wouldn't be here if that wasn't the case. But very clearly in the Pacific region, the majority of research has been done by non-Pacific people. So we were delighted when MFAT had a research call that asked specifically for Pacific-led researchers. And so this was not something that, it was really a gift for us to do that. I don't think they've done it again. And there were some problems with that. And one of the first problems was that we were committed from the beginning to two things. One of them, well, three. One of them was co-leadership. So the idea that there's just not one person who is leading the whole project. There were three of us, and we moved it around, we backed each other. And so that was a really important part of what we were offering. The second offer, and this is all quite different to the other kind of research we came across, the second offer was co-design. And that meant we couldn't tell them initially what we were going to do, because we didn't know where we were going to be necessarily, and we didn't know what the community would particularly want. So we had to push back a little bit and say, trust us, we know that we will have a co-designed approach which will work. And so that was quite an interesting thing. And of course we had an idea, but what we wanted was to ensure that people who worked in the communities were from those communities, had the language of those communities, and had an understanding of an intergenerational transfer of knowledge. And so that takes a little bit of work. And so with the team that we built, including ECRs and new and emerging researchers in 7 countries, Papua New Guinea, Solomon Islands, Kiribati, Tuvalu, the Cook Islands, Niue and Tokelau, we used our networks to find those kinds of people, to bring them into our project, to support them, to fund them. This was not a usual research project that MFAT was funding. So I think that was really important. We also have had a lot of others who wanted to be part of our project, and we were very polite in being able to say this is a project for and of the Pacific. The other thing that we were committed to was that the first beneficiaries of our research were the communities. And so we built that into our project. And so before we completed all of the peer review articles, which we still haven't completed, our first commitment was taking the research back to communities. And that was quite distinctive. And, you know, we worked really hard to develop very attractive, easy to read, policy kind of briefs. And you have no idea how welcome they were when we took them back to Kokopo in Rabaul, or we took them to Aoligo in middle of Guadalcanal. And so, you know, this is also, I think, a very distinctive feature of the kind of research, distinctive in relation to other kinds of research that we did. Sure, we haven't published all of those peer-reviewed articles, and we will do that in time. Thank you, Tina, for your for the work that she'll be doing shortly on that. But we feel very proud that we were able to do that. In addition, the intergenerational part that we found was that communities thought in terms of generations. So they thought about where they came from. And surprisingly, not everybody came from the place they currently live. We asked the question, how did you come to be here? And there were myriads of stories of mobility, much more diverse than we kind of think. But they thought in generations. And so that kind of intergenerational storying provides absolutely critical baseline data. No questions asked. And so we feel very comfortable that that is credible and defendable research insights from our community. Thank you.
Thanks. I might hand over now to Angela and go to the other side of the spectrum where we've got these intergenerational stories to some of the digital tools that you've been using, and maybe in Tonga.
Yeah, so I thought that maybe perhaps just reflection on the science to policy and the importance of research that is being thought from the community, for the community, is that if it is not impactful. So the International Food Panel for Climate Change, the last assessment report was very clear that a lot of the investment on adaptation in the Pacific wasn't actually effective because it was not designed with the community in mind. And I think at the global level on the process of IPCC, they are recognizing this. And I think in this assessment cycle, they're preparing a way in which they can include indigenous knowledge into the process of the assessment report. And I think it is finally a work in progress into that. In work that we are doing at PHS, we are trying to sort of apply digital tool and of course exploring AI. And I think one interesting piece of work that we have done is really reflecting how do you do it in a way that you can believe the output of the model. And so we're working on with Auckland City Council of developing a digital twin. And the first things that we have been thinking very hard is how do you set up an ethical framework? So how do I set up a process of analysis that you can have check-in points at different stages? And Auckland is very interested in the tools because there's a type of tool where you can test the what-if scenario. So what if I increase the canopy cover? What would happen? Do I increase do I decrease the exposure to heat impact? And interestingly, even through the process of doing that kind of pilot, you realize that actually there is a fundamental aspect that we need to consider when you do that, because residency is in itself have an inequality aspect. So there is only a limit to which you can, for example, increase canopy cover. And so you need to really think it through when you ask the question, which question I'm answering, how do I design the tool, and what I want, and how do you reduce inequality of your intended outcome, as opposed to maybe decrease the average, but increase overall inequality. So there is an interesting sort of insight that needs to be. So with all this fancy model, the first step is actually the ethical framework, and I think it's that important. Another interesting piece of work that we've done is reviewing model to make a case for investment in environment. And what we found, and so investment on environmental health that reduce the impact on health. And there are many tools out there, and we want to see the one that would give us a kind of, or the social or the economic also kind of framework. And we found that there are very few tools that integrate the multidimensional aspect of environmental health on the social and economic, and very few that actually have a indigenous or community type of dimension to it. So it's interesting that is how we actually need to push back on that economic narrative to a much more broader kind of framework. And how important those type of assessment are to make the case for funding and investment and research.
Thanks, Angela. I think maybe just picking up this point about the multi-dimensional aspect of climate health, and I think the Cure Kids project is amazing in terms of the respiratory oxygen project and the health co-benefits that it's had in terms of renewable energy. Maybe if you can speak up a little about that project and sort of the cultural ethics that went into building that project.
Thank you. Like Professor Yvonne has mentioned, that it needs to be led by the locals, and we need collaborations with them as well. So an example that I would give is our solar site selection methods that we had used. We had, the Cure Kids had partnered with the Ministry of Health, the Fiji National Oxygen Program, and working on a four-stage approach on how to choose the facilities for the solar system to be installed. And we looked at data that is already available, and these were the WHO data with a project called SHAPE, looking at the vulnerability assessment of healthcare facilities in Fiji, which had around 99 healthcare facilities out of 215 which are vulnerable to the effects of climate change. So that is a big number that we need to look at and narrow it down. So we look at the second stage, we looked at the facilities which are closer to the national grid system, and that would be eliminated from our set of numbers that we are working on. And then on the third stage, we looked at data which is already available too on the respiratory visits to these healthcare facilities. We narrowed it down to around 20 healthcare facilities, interlaying the data from the respiratory visit as well as the early warning alert system that we have in Fiji, looking at that. And the last bit, or the stage 4, was looking at working with local divisional health officers with what is their priorities within their divisions, and how could we assist them with the implementation of solarization in their facilities. So they came up with what are their priorities, and with that we worked with them with the implementation. And looking at the health co-benefits of this solarization, it's not only that the healthcare facility gets solarized or gets electricity 24/7, would be able to use oxygen concentrators and other medical equipments, and also reduce respiratory illnesses within their communities. It also works on the energy sector. Heavy reliance on fossil fuels, the climate crisis the fuel crisis that we are having at the moment. The facilities that we had solarized, we had just commissioned it in March of this year, and it was in time. When the fuel prices are high, they are enjoying 24 hours of electricity. They are not paying for fuel unless there's gloomy weather, then they would turn on the generator. Otherwise, they are very happy with that. So that is something that the health co-benefits of solarization, not only that the health facilities, we get to reduce our carbon footprints as well. And on the training that we are conducting to the community health workers, it translates right to the community members. Not only to the health workers that we are training, these learnings also translates into the community, helping them with the planning of whatever that they would want in the community, making sure that whatever that they're building, whatever that they're planning is also climate resilient. Thank you so much.
Thank you. I think coming to the Cook Islands now and looking at you, Tina, you're always a strong advocate for community, co-design, and we've heard a lot about the importance of co-design. How do you think our health systems, governments, researchers, practitioners and communities can work well together to effectively address climate crisis and the impact on health and well-being? It's just, a little question.
Just a little one. I think in our context, there's lots going on and there are lots of people involved. And so, we have really strong relationships and connections with our people, not just at home, but around the world, here in Aotearoa and other places. And so I think that's probably one of the key things that works is about respectful relationships that we have with our networks and our connections. I think that's a fundamental part of it. And I heard Jude say earlier on about, about knowing your strengths and what it is that you bring, what's your expertise, and kind of staying in your lane or identifying what that lane might be and working that together. Because I see this at home, is that there's a saturation of offers for assistance and help, and on a weekly basis, different institutions reaching out and wanting to engage, and so there's lots of effort goes into distilling that and working out who can we work with on different aspects. And I think that that's a key part of those respectful relationships, is understanding what it is you bring and where you can add to what we're doing. Like, we have our National Sustainable Development Agenda, Tūranga me Maitaki, and that's not the National Sustainable Development Plan, that's the National Wellbeing Plan.
And so we have this tool that's meant to help kind of guide people into how they might engage on all sorts, whether it's projects for implementation, whether it's for research, policy, a whole myriad of things. And so that's an important tool for people to engage with initially. But of course it is, so you're engaging at the policy level with those instruments, but you're also engaging with the people. And through the research permitting process, applications are coming in, and what we've seen over time is a shift away from external researchers coming to an increasing number of Cook Island researchers submitting proposals for permits, which is just this amazing change that we're seeing. And this has happened over the last 5-6 years. We're starting to see this shift in the numbers. And what we're also starting to see is a shift in what's being asked for, what people are wanting to investigate and research. And it's about, before it's very much external focus on problems and driven by kind of those deficit narratives about what's wrong with us. And now we're starting to see this change towards a very much strength-based perspective, a focus on Cook Island-based tools and thinking, theorising and methodologies. And so people starting to use that and starting to see non-Cook Islanders engaging and wanting to use these tools. So, those are kind of tangible things that we can all do to support the whole landscape or the oceanscape of what we see happening in our country. And because climate change is such an exacerbating phenomena, it will take whatever issue you have in your country and it will multiply it exponentially, to the point that it has existential implications. And so, through the research, and can I just talk about a quick example? This is related to mental health and the Climate Change Mental Health Project led by Jemima a few years back. And so in that work, we could see the connections between climate change, and this is talking to communities in one phase of this research. You could see the connections they were making to climate change, to everyday life, in all kinds of different ways. And in terms of mental health, when we heard this mentioned before, they were talking about implications around their depression, anxiety, PTSD. We see that when people have, from the effects of disasters like cyclones and floods. So we see that as well as the long-term impacts of, your lagoon becoming silted and you can't, the decline in your food supply. Octopus have disappeared, their homes have filled with sand. So you see all of these things, all of these kind of things going on. So you can see the intersection between climate change, mental health, and people's livelihoods, their well-being. So this is where, while we, but one of the key things in there was around the importance, because while we're also identifying these issues, people were also identifying what to do about it. And one of the key things that came out was the importance of developing our own models and understanding of well-being. So what is a Cook Islands model conceptualisation of well-being? Where is that in our health services? How are we incorporating these Indigenous understandings of health and well-being into our interventions in our communities? Our people are telling us. And so there's an opportunity for us to make use of those kind of understandings and engaging with these community insights to drive our responses to health and climate change.
Thanks, Hannah. To wrap up the panel, I might just ask everyone to give one key message or takeaway for our audience, policymakers and researchers.
my message is that in the Pacific region, there are large regional declarations around climate mobility, around healthy islands, around security. And in Aotearoa, we need to recognise that these are regional. These go across the whole region. So let's not ignore those, because our governments in the region are working to those. And we need to ensure that we understand them both for the country areas, but also for the region as a whole.
Maybe just a thought of things that we haven't touched is on the role of young people and following the ideas. As a lot of the work I've done before with UNFPA was really actually driven by young people and how they actually know what it needs, because this is the climate crisis is going to impact them most than anyone. So yes, just a thought there.
Just a key takeaway message as well is just on workforce development and on sustainability of projects. Something that projects needs to take into considerations, that when our projects ended, the cycle ends, there's continuity of maintenance of everything that have already been implemented, and this rests on the locals, the government, or the Ministry of Health, or whoever you're partnering with in the communities. Thank you.
Mine would be hold the space. Hold the space for whatever space you're in, hold it so that you can invite others into it to collaborate and work and, you know, just make good on the promises that we say to each other.
Thank you so much. I'm going to exercise my prerogative a little bit and not look at Colin. Does anyone have a question? Any question from the audience? All right, thank you so much, everybody.
Thank you very much, team. We've also got a little thank you pack. It's actually the leftover sausage rolls, particularly the vegetarian ones that the Tongan community didn't eat. But thank you very much, Mālō Alpito, for your sharing. Pardon me, Madame, Monsieur. We're now going to break into our breakout sessions. There are 4 streams. This is going to be room 1. Room 2 and 3 are located next door. And then the 4th room is over there in the White House. Not the one with the UFC ring. A bit far away from here. So room 1 here, room 2, 3, and then 4 is the White House. And I invite you all. It is imperative that you take part in some of these sessions. So s'il vous plaît, if you can find your way. There are some of the helpers here who can direct you. You can follow them for more information, or you can follow Jesus as well at the same time. Particularly this row here. They need you need Jesus. I said Jesus. Anyway, my fellow parishioners, we will now break room 1 here, 2, 3, and then 4 to that side. And if I could please ask you all to be back here at 3:50. 3:50 p.m., not a.m., because I do want to go home and watch Coronation Street. It is very important. All right, see you soon. Sotatale.
Can we have...
Some of the types of data we've collected are to do with health, education, employment, family structure, all kinds of things. Allows us to do is trace how conditions, for example, in infancy, predict outcomes in adolescence, how early housing deprivation becomes respiratory disease, how food insecurity in childhood can become metabolic risk in adulthood. The causal pathways, not just the correlations, become visible. Critically, the study was built on Pacific methodological principles and approaches, respectful relationships, trust and reciprocity, and Pacific ownership of knowledge. Culture was not an add-on, it was structurally embedded in how the study was designed, how data was collected, and how findings were interpreted. This is why the data is not just statistically robust, it's culturally legible. It captures realities that a standard biomedical instrument would miss entirely. And that matters enormously for translating evidence into practice. Now, before we move into a few of the specific findings, I just want to orient you to the analytical model that sits underneath all of our PIF analysis. And this diagram tries to capture that. So health outcomes for Pacific families emerge at the intersection of two domains. On one side, structural factors like housing, income, food security, and education. And on the other, cultural factors like identity, family, spirituality, and community. Pacific family well-being sits where these converge. Neither domain alone explains the outcomes. The PIF framework requires us to hold both simultaneously, and the longitudinal design allows us to trace how they interact over time across childhood, into adolescence, and now adulthood. So it's difficult to collapse 26 years of information and data into 10 minutes, but I figured, given the priorities of the Te Poutoko Centre here at University of Auckland, something like food security might be an interesting thing to talk about. So the first major finding concerns food insecurity. Now, conventional clinical narrative attributes elevated rates of obesity and type 2 diabetes among Pacific peoples to cultural food practices and individual dietary choices. But the PIF study tells a more accurate story. When families cannot afford nutritious food, when the price of fresh vegetables, lean protein and whole grains is beyond the weekly food budget, they rely on cheap, energy-dense alternatives. That's not a preference, it's a rational response to material scarcity. The causal pathway is clear. Food insecurity drives reliance on energy-dense foods, which drives obesity and metabolic dysregulation, and produce a long-term, non-communicable disease burden. Clinical advice alone, without addressing affordability and access, cannot interrupt this cycle. Addressing food insecurity is a metabolic intervention. The PIF data also allows researchers to trace food insecurity, not just cross-sectionally, but over time. So families who experience food insecurity in early childhood are more likely to show metabolic risk markers in adolescence, and the biological consequences of early food insufficiency persist. This is not simply about what a family is eating today, it's about what the cumulative experience of nutritional precarity does to developing bodies over the years. And what does this impact does this have in terms of policy implications? Well, they're substantial. Equitable access to nutritious food requires welfare policy that ensures household incomes can sustain healthy eating. It requires food assistance programs that do not stigmatize recipients. It requires thinking about the geography of food access. How many of our South Auckland communities have fewer supermarkets and more fast food outlets per capita than affluent suburbs? The built environment shapes diet. The next major domain of findings, and arguably the one with the most profound implications for how we think about Pacific health, concerns mental well-being. Specifically, the mental health trajectories of PIF children as they move through adolescence and into young adulthood. Looking at this diagram at the centre, mental well-being in adolescence and young adulthood, and surrounding it, 5 interconnected nodes: early family circumstances, housing stress, economic hardship, cultural connection, and social background. Each of these exerts measurable influence on the adolescent's psychological outcomes. This model challenges a common clinical instinct, which is to locate mental health problems primarily within the individual, as disorders of brain chemistry, thinking patterns, or personal coping capacity. The PIF data insists that we look outward from the individual to the social and material environment. The stresses that predict poor mental health outcomes in Pacific adolescents are disproportionately structural: the stress of housing instability, the cognitive and emotional load of family economic precarity, the relational disruption of overcrowded living. And yet, the data also reveals the other side of this picture, which is equally important: cultural connection. Having a strong, stable sense of Pacific identity and belonging is a significant protective factor for mental health. It's not a vague claim, it's a statistical finding. Pacific young people with stronger cultural connections, stronger family bonds, and stronger community belonging show better mental health outcomes, even when exposed to the same structural stresses as their peers. So this finding has two equally important implications. The first, we must reduce structural stresses, housing instability, food insecurity, etc., because they are genuine psychiatric risk factors. But the second, we must support and strengthen cultural connection as a protective resource, not treat it as irrelevant to clinical care. And the last one, for too long, cultural identity has been treated in clinical settings as either irrelevant background information or as an explanation for non-compliance with standard care. Our evidence rejects this framing. Cultural identity, encompassing a sense of who you are, where you come from, the values and practices of your family, your spiritual grounding, and your sense of belonging, is not a soft peripheral variable, it's a health resource. This slide illustrates the protective stack of cultural identity, family connection, spiritual grounding, and community belonging. These are not separate from each other, they are mutually reinforcing. The title on the slide deserves emphasis. Pacific cultural identity is a health resource, not a barrier to modern care. If our services are designed in ways that require Pacific families to leave their cultural selves at the door in order to access care, then we are not just being culturally insensitive, we're actively removing a protective health resource. Good care for Pacific patients integrates and honours cultural identity rather than ignoring or overriding it. So in terms of future prospects and plans for the Pacific Islands Family Study, the original PIF children are now having children of their own. This creates a genuinely intergenerational research architecture. We've done work with the grandparents of the original cohort. We have information from the parents and the original cohort members themselves, and now they're having babies as well. So this three-generation design allows researchers to ask whether the health impacts of early adversity are transmitted across generations, biologically through epigenetic mechanisms, socially through parenting patterns shaped by childhood experiences, and structurally through the persistence of poverty and housing insecurity across these family lines. These are some of the most important questions in contemporary public health, and the PIF study is uniquely positioned to answer them with Pacific data. Beyond New Zealand, the PIF cohort also functions as a future mirror for Pacific Island nations navigating rapid transitions. Things like globalised food systems, sedentary digital health lifestyles, urbanisation, and rising NCD burden. What PIF has documented in South Auckland over 25 years is likely to unfold across the broader Pacific. And this international dimension positions PIF not just as a New Zealand study, but as a Pacific regional resource, one that can inform prevention strategies, health system design, and social policy across the region. The evidence is local, but the application is actually regional. I'll carry on. Right. So I just want to close with what I believe are essential mandates that emerge from more than 2 decades of the PIF evidence. These are not just suggestions or aspirations, they are conclusions that the data compels. The first mandate is that evidence must replace assumptions. PIS study has repeatedly demonstrated that assumptions made about Pacific health, that poor outcomes reflect cultural practices or individual choices, are contradicted by longitudinal data. The evidence reveals realities that cross-sectional assumptions miss. PIF provides the evidence that we can use. The second mandate is to recognise that structural inequities are biological realities. Housing, food security, income and social policy are not peripheral to health, they are causal. Addressing this burden requires structural intervention, not just clinical management. Thirdly, culture is protective and must be integrated into care. And finally, designing interventions around families, not individuals, is likely to be more effective and useful for our Pacific families. That's it for me. Thank you.
Thank you very much, Professor Tautolo, for that wealth of information for our Pacific Island families. Now I'd like to call upon Professor Sarah Jane Payne on her talk, What is the Role of Longitudinal and Life Course Evidence in Advancing Our Health Futures? Insights from the Growing Up in New Zealand study. Welcome, Professor Payne.
Tēnā tātou katoa tuatahi, nei rā timi hatu, kia koutou, aku tuakana no te moana nui a kiwa. Just wanted to start by acknowledging my tuakana, my relations from here in Aotearoa and all across the Pacific. And like Professor Tautolo, to acknowledge te Poutoko rā kiwa for the opportunity to come and present to you all today. Not just to present what we're doing at the Growing Up in New Zealand study, but present to you data, information and evidence that comes from ainga, whānau, your people and families here in Aotearoa. So Dan's given you a wonderful introduction to the world of longitudinal studies, and the Growing Up in New Zealand study is another such study. Our study, based here at Waipapa Taumatarau, University of Auckland, started with an idea. This time the idea came from what I understand to be researchers, policymakers, but also the Crown, the New Zealand government, back in 2005. Likely because we the nation had seen what could be made possible through studies such as PIFS, the Dunedin study and the Christchurch study, and perhaps what Aotearoa would need into the future, given our changing demography, our widening and deepening ethnic diversity, and also our broadening socioeconomic realities as well. So from that idea in 2005, more than 6,000 pregnant women living in the Auckland, Waikato and Counties Manukau, DHB regions volunteered to be part of a long-term study. So that work happened in 2008 and their babies, their children were born into the study between 2009 and 2010. And like I said, those people who had the vision for a new longitudinal study, they knew what it would take to deliver evidence that was going to help support flourishing, to support child and youth wellbeing into the future. And so they did some careful thinking and some careful work with Māori, Pacific and Asian communities to try and recruit sufficient numbers, appropriate numbers of people from our different communities into this study so that we could map and track how their lives change and grow over time. And so the children, the young people in our study, they've started turning 17, so we're a few years younger than the PIF study. We have been following, like I said, their lives since their mothers were pregnant, all the way through those early weeks and months of a child's life, the preschool years, middle childhood, and now we're in adolescence. And as Professor Tautolo explained to you, really trying to understand what makes a good life for our children and young people here today. part of introducing our study and presenting ourselves to you all at this symposium, I thought I'll bring some of the information and insights that have been gathered about the Pacific cohort, about Pacific whānau and children and young people, to give you a sense of what we hold in our taonga data set, this data set about the lives of children and young people. And so as I mentioned, there was some careful work done to recruit mothers and whānau from Māori, Pacific, Asian and Pākehā communities into the study. And in the top left-hand there, you can see the proportion of women in the study who identified as Pacific at the time they were recruited. We've been following and working with those mothers since that pregnancy, and I also want to mihi and acknowledge some of my colleagues from growing up in New Zealand who are there in the second row. They work with our Pacific families right now in the field. And so those mothers have played an important role. They've been there from the beginning, they've filled out questionnaires, been interviewed, and as their children have become of an age where they can do their own questionnaires, they've become the champions of the study in their ainga and in their communities. At some points in time, we've also been able to collect information from the mothers' partners, and that helps to enrich how we understand whānau life and community life. And as I mentioned, since the children have been 8 years old, they've also been contributing their own data, their own experiences, how they see their lives as part of our data set. We have spent a lot of time trying to think about what makes a good life, and as Professor Tautolo said to you, we also recognise and pay tribute to the ways in which our identities, our cultural and ethnic identities, our gender identities, our different social identities, how they all come together to support wellbeing, and we collect that information too. Part of understanding our different cultural and ethnic identities is understanding the role of language in our lives. And so on this slide, just give you a little snapshot into how we've worked with families to understand their hopes and dreams, their intentions for their children to be bilingual and probably actually multilingual young people. And then their ability to be able to live out that vision as their children and their families grow. Other aspects of the data that we collect include questions around our educational journeys. So the role that education plays in the lives of the children and young person, both as an opportunity for wellbeing to be enhanced, but also unfortunately sometimes a site in which challenges to wellbeing can arise. So we've been thinking about education from early childhood, the different types of early childhood centres that Pacific children and young people are learning and growing in, right through to their secondary school experience. And as we're in the field this year collecting information about these almost 17-year-olds, we're thinking about their vision for education beyond school. Do they see themselves coming to places like Waipapa Taumatarau? And if not, where will they go? Where do they hope to go? And what are those transitions looking like? And how do we come in and support them with that work? We know that whānau and ainga are a very important wellbeing resource and support for our children and young people. But it's also, I think, not surprising for many of us that our children look to other people, and as parents and whānau, we look to our communities to support our young people. So when the children were 12 years old, we asked them about who they saw as being important in their lives, and you can see the role that aunts and uncles, our nannies and korors, our grandparents, relatives, siblings, teachers, friends, coaches, community and church leaders, all of these people surrounding and caring for our young people, but also people that our young people go to when they need advice and support. How did it get so big? Maybe it's a sign to go on to the next slide. I'll take it. Like the PIF study, we've also been thinking about and tracking mental health. And what I really wanted to point out in this study, because I know there's a lot of knowledge in this room around the mental health experiences of Pacific young people and families, but the special role that longitudinal studies can play in helping us deepen how we understand mental health and how we support mental well-being for young people. So in studies like ours, when we're following the same groups of family over time, we've got options. We can think about mental health at a moment at time. So here on the left, just some insights about anxiety and depression at 8 years of age, and then from those same young people when they're 12, and then when they're 15. So we can think about that change over time. But what's really important and unique about the work that Professor Tautolo and I lead is that we can think about trajectories. So we're not just looking at moments in time, we're connecting up all those moments to create what we call a life course trajectory. So on the right-hand side in the sort of multicoloured graph and the picture at the top, we're thinking about how mental well-being is shaped over time. And the factors that can erode mental well-being, such as bullying and discrimination, not just as, I would say, tragedies in the lives of our children, but opportunities for intervention. So we look at changes over time, how those trajectories move and change, and at what points we need to come in and help provide solutions. Thinking again about the usefulness or utility of longitudinal data, material hardship and cost of living is obviously a critical discussion in our communities right now, particularly so for Māori and Pacific communities. So what we're doing here, or what I'm doing here, is again trying to demonstrate what might be possible. How might we learn something different about material hardship that other sources of information can't help us understand? And so again, we can think about experiences of material hardship at moments in time between 12 and 15 years of age. We can see that material hardship has increased from 23.5% to almost 40% in our cohort. But when we think about those trajectories, how for some families and communities, material hardship as an experience, it begins before birth and it can continue and persist over time. That is what we're trying to think about on the right-hand side. And so if I focus in on those material hardship trajectories for Pacific young people, we can start to see how even within our communities, just within the Pacific community, we can see different trajectory groups. 20% experiencing persistent hardship, so that experience of hardship is always there in the backdrop. 17% experience some hardship. There may be points in the life where hardship is more difficult than in others. And of course, 15% where those hardship experiences actually increase over time and across the life. So to wrap up, because I must be on my 1 minute call, really trying to think and tie together the possibilities and potential of longitudinal data, not just as an important resource for researchers like myself and the policymakers who we work with in government, but for all of you as family members and community members, because this data is about your whānau and your communities, and we need to find ways to ensure that the right questions are being asked of the data set. So I do wonder about what the questions of the future look like. What are the most important questions for Pacific peoples now and into the future? And how we, in our research sort of studies and groups, how do we support and enable your questions to be realised? What are the capability needs? What are the workforce needs? How do we build our own analysts and statisticians, our data scientists and our researchers, so that Pacific people are asking the questions, they're leading the work and they're developing the solutions, right from the beginning all the way to the very end? Professor Tautolo also spoke about the possibilities for policy and decision-making in clinical services. And we do, as longitudinal studies, we provide a different kind of data and evidence into those solution-building spaces. And I want to touch just briefly on the notion of a social investment approach. It's a very interesting time to be thinking about longitudinal studies where we understand how early life really matters for later outcomes. And we have a government system that is trying to fund and support based on those same ideas. But I do want to ask and caution about the potential for some of that social investment way of thinking to simplify our experience, to rely on descriptive data, and to not be brave enough to tackle the real life complexity of what it means to be Māori, Pacific, Indigenous people in Aotearoa. And so finally, again, just a message that this data may be hosted and held and cared for us here at Waipapa Taumatarau, but it is actually available for your researchers, your students, your organisations to use. And so we see it not just as a taonga data set for Aotearoa, but a critical data infrastructure and resource. And we hope that after this first introduction and presentation, that there might be opportunities to work and partner and collaborate with you too. Kia ora.
Thank you. Sorry, sister, all the questions will be asked at the end, if that's all right. Sorry. Thank you very much, Professor Payne, for that very informative presentation. It's very helpful, and we really, the question that we always ask is, how do you translate this information into really helping our people, all around the socioeconomic issues around, and just build up from there. We're hoping that the younger generation will do it for us and hand over the mantle that's on the stage. Yeah, thank you very much. Now I'd like to welcome to the podium Jocelyn Raymond Tongasolo and Dr. Amio Matenga Ikihele. And their talk will be about Pacific perspectives on the use of digital health tools and AI in pregnancy, birth, and parenting. Please welcome Jocelyn and Amio. Thank you.
Whakalofalahi atu ke tautolosi, mo atu ke lifu e ke kafo kara o ka sene ngafa, te whakaoe whoki ke te Poutoko ora kiwa, ke mga ahonei, e mauri ora tātou. So Jocelyn isn't here today. So she was a student that came through and spent the summer with us at Moana Connect and undertook this project alongside myself. She's sitting her exam at this minute. And so I thought it would be a wonderful opportunity for her to be given this opportunity for her to present. But unfortunately, her exam is a priority over this presentation. So you have me. The project was an extension of my postdoc, and it was funded through Te Titoki Mataora, which is a summer studentship program through Auckland Bioengineering Institute. And as we know, in terms of those who are here working in maternal health in Aotearoa, a lot of our Pasifika women engage late in maternal care, usually in second trimester. On the other hand, we also have a digital divide amongst our Pacific communities, and there's also limited research around Pacific women that are going through maternal care. What are the experiences of digital health? Is it something they use, as well as the emerging AI? And those were essentially the things that we wanted to undertake. So this picture here, the thing doesn't work, is Jocelyn, who's sitting alongside Michael. So Michael also came through us as a summer student, and he was funded via Kids First. And those two facilitated our workshops with our mothers, our fathers, and our midwives. And they were also supported by one of my colleagues, Michaela Roberts, who supported them to facilitate on their own focus groups. And so the key objective was again, what was our Pacific parents and midwives' perspectives on the use of AI and digital health, and whether they use it to support pregnancy and parenting, and what were the barriers, enablers, and risks. And from there, the interviews were conducted between November and January, and it involved midwives, mothers, fathers, as well as our support caregivers, because it's not only our nuclear family who care for our young people, our babies, it's also our extended family. And it was all conducted over Zoom, and Michael and Jocelyn transcribe verbatim all of the interviews. Again, really good skill set, and that's where our analysis starts, from the data analysis. And apologies, there's a formatting, something gone a bit paru, but with our formatting. But anyway, the demographics. So 5 midwives, 6 mothers, 5 fathers, as well as 3 family support members were part of this kaupapa. Majority were Samoan, and we also had Tongan, Cook Island, and Fijian. And we had a young profile of people who were part of this study. So in terms of the key themes, Jocelyn and Michael were able to extract 3 key themes. What were their perspectives and acceptance of using digital tools and AI? What were some of the concerns and risks? As well as what are some of the considerations we need to think about in the future? What does this mean in terms of where the future is heading in terms of digital health and AI? So in the first instance, perspectives and acceptance. And this morning you would have heard Professor Robin Whitaker talk about the AI scribes that are commonly being used within primary healthcare and in our health service. So midwives are encouraged to use Heidi, which is the scribe that's been approved by Te Whatu Ora to be used in clinical settings. And it was really interesting to hear the midwives who talked about the administrative burden that it actually causes them. And it's because as they are transcribing, they have to go in and correct, because AI is learning all the time. It doesn't pick up on the words such as our cultural words or names, and even some of the terminology that's being used. So there is a lot of editing that is required after. For the clinicians in the room, this is actually a good thing, because your documentation is what protects you in the court of law. And so having you go back and check everything that has been transcribed from an AI is actually a good thing. But interestingly, it was an administrative burden. But I reckon it's a good quality check if you're a clinician. And from here, the midwife also said that it added time, but when I've talked to other nurse practitioners, it actually saves them time. So it just really depends on how you're using the scribe, because there are both pros and cons in how you would use it. The second part around acceptance was there were conditions in place for when people might use it. They found that information was accessible. They found it useful. However, they needed to ensure that the information they were reading came from a credible source, and it often was a New Zealand source. And when you're using Google now, there's an AI sort of summary that comes up. And so interestingly now, that's sort of the only information which people are using to determine what the answer to their question is. And then from here, they say AI is accessible, but there's an over-reliance. Again, Professor Robin talked about the clinicians relying solely on AI to give clinical reasoning. And then even the midwife here is about being reliant on digital stuff. But importantly, midwifery is all about human connection and care. They didn't want it to replace the care that they gave as a midwifery profession. There were a lot of mothers and fathers who were already using digital tools to help monitor their pregnancy, whether it was to track the gestational week that they are in, or whether it was to answer questions related to their sort of clinical concerns. And for one of them, so the top quote here was about the weeks, checking the gestational week that they are in. And they use ChatGPT, and that's often the most common AI that was being used. And then discernment around where the information was coming from. So it had to be endorsed by New Zealand doctors or midwives. And there was some acceptance around it. So again, people are already using the tool. When we're thinking about trust and privacy, people are putting in their health information into these AI tools, so there's no surprises there. That's a common theme that we're hearing internationally. And here they're putting the information in the hopes that it maintains their privacy. Concerns around midwives is data privacy, security, and consent, and making sure that AI doesn't undervalue their professional judgment as midwives. When thinking about misinformation, again, there are concerns about whatever generative AI that was being used, that it didn't give incorrect or outdated information. And here, this mum's already talking about how they're using it in terms of symptom checking and how they are using it to check whether or not, there was another quote here around those that are considered on the spectrum and putting in symptoms to then determine an outcome. So it's giving clinical reasoning, which again is a concern because we know that it doesn't necessarily give that clinical reasoning. When thinking about considerations in the future, midwifery support said that it shouldn't be an administrative burden, and there's training that's required because in healthcare, whatever workforce that you're working alongside, you have your innovators, your early adopters, and then you have your laggards. So you're going to have a whole spectrum of people who are keen to use the technology and those that are really resistant. And whenever a new technology is being implemented within an organization, you have to consider the spectrum of how quickly or not so quick people will adopt this new tool. And whilst sometimes people feel that they're being forced to use a tool without having the proper training to support them in adopting this. It needed to be free, it needed to be accessible, it needed to not be reliant on Wi-Fi, it needed to involve family. When we think about our digital tools now, it is very focused on the individual, so it's tailored to one person. But when we think about care, especially around maternal care, it is a family contextual context in which a new baby or life is being born, similar to what Professor Sarah as well as Professor Tautolo spoke about earlier. When we're thinking about a range of information sources, it needed to be something that midwives as well as parents were able to access. And again, we only spoke to 5 midwives, so if we think 5 out of the 80 midwives that we have here in Aotearoa, that's still a really good sample to think about how AI could be used within that context. And this quote here by Saini, again, all pseudonyms, family is a huge part of the journey. Whatever's being implemented, family also need to be part of whatever tool is being implemented. So in terms of recommendations, it was clear that whatever tool is being developed or endorsed by Health New Zealand, it needed to ensure that whatever data is being collected, transparency was shown about how it's being used, and AI is going to be used as a supporting tool as opposed to a replacement. It needed to be a tool around safety to reduce misinformation. Even if you're searching on Google now, there are sometimes American websites which turn up, and so often people use that as a reference point to discuss symptoms when they are liaising with their provider, clinical professional or provider. Workforce development, supporting the workforce. Again, I talked about the spectrum of those who are really going to adopt the technology versus those that will take a little bit longer to adopt. Access, making sure it's free. There's been so many tools which require cost as well as data storage. And we're thinking about keeping it human. whatever digital tools we have, it needs to enhance communication and not replace it with just a digital tool. There's a place, but our parents, our midwives, our families do not want to be reliant on a digital tool. They want to use it alongside clinical care. Now, I know I really ran through past it, but that was why do this. Malachi talked about it earlier on. It's important that whenever a new digital tool is developed, it has to be developed alongside people. I've seen many digital tools being developed with no adoption from their end users because they hadn't been involved in the whole development process. So this is just a sample of what we've heard from mothers, fathers, support people, as well as midwives, of where does AI and digital health fit in wherever it's moving now. But in saying that, perhaps there's, oh no, Kara said there's questions at the end. But I want to thank Jocelyn, Michael, and Michaela for being able to undertake this project, especially during summer where a lot of our midwives and parents just really want to have a holiday, but they managed to get the individuals to talk to them about what digital and AI health means to them. So in saying that, nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa.
Whakawelahi Mio, and we wish all the best for Jocelyn. I hope that her exams is going very well at the moment. Yeah, that's it's a minefield, this AI stuff, because especially for us clinicians, but that's very informative. Thank you very much for your talk. Now I'd like to welcome, sorry, I just need to put my glasses on now. I'd like to welcome Lata Paya on their presentation on mathematical modeling of uterine smooth muscle fiber excitation contraction dynamics. Please welcome Lata for her presentation. Yes, all questions will be at the end, please. Thank you.
Mālō lelei, everyone. My name is Lata Paya, and I'm a PhD candidate at the Auckland Bioengineering Institute. And my PhD project focuses on using mathematics to understand contractions in the uterus and how these contractions may lead to conditions such as endometriosis. So endometriosis is a condition where endometrial-like cells, the same type of cells that are shed during a period, grows outside of the uterus. And symptoms include extreme pelvic pain, heavy menstrual bleeding during menstruation, and difficulty becoming pregnant. This condition affects 1 out of 9 women of reproductive age in New Zealand and Australia. And diagnosis delay may take up to about 12 years for Māori and Pacific women and 9 years for non-Māori and Pacific women. So even though this condition is common, we still do not fully understand how and why endometriosis develops. So to explain the motivation behind my PhD project, we will go through a brief biological background. So my project focuses on the non-pregnant human uterus. And the area that we are interested in is called the uterine body, highlighted by the box. And 3 important layers make up this uterine body. Going from the outer to the inner, we have the perimetrium, the myometrium, and the endometrium. The layer that we're focusing on in this project is the myometrium layer, which is the middle layer, and it is also known as the muscular layer because it contains smooth muscle cells whose main functions are to produce contractions that are generated from electrical signals in the form of action potentials. So contractions are primarily associated with labor in pregnancy, but the non-pregnant uterus also undergoes contractions throughout the menstrual cycle. 4 phases make up the menstrual cycle: menstruation, the follicular phase, the ovulation phase, and the luteal phase. Menstruation phase is the most well-known phase of the menstrual cycle, and it also serves as the beginning of one complete cycle, which goes for an average of about 28 days before it repeats itself. So these contractions vary in strength, frequency, and direction, depending on the phase of the menstrual cycle. In menstruation, these contractions have the highest strength with low frequency, and direction goes from the top to the bottom to help expel the menstrual blood and tissue. In the follicular phase, strength is mild with low frequency, and direction goes from the bottom to the top to help assist with sperm transportation. In the ovulation phase, strength is mild with the highest frequency, and direction goes from the top to the bottom to help with egg transportation. But there has been mixed evidence in literature also showing that contractions in this phase may also go from the bottom to the top to help assist with sperm transportation. And lastly, the luteal phase, contractions are weaker with low frequency, and the direction goes from the bottom to the top to help with embryo implantation and positioning. So coming back to the menstruation phase, disruptions may occur at the time of menses, and instead of the menstrual blood and tissue flowing out, it may flow backwards. And this is known as retrograde menstruation, which is one of the leading scientific theories for the initiation of endometriosis. So that is kind of like the overall motivation behind this PhD project, is to develop mathematical models to try and help understand why contractions during menstruation may flow backwards, and how this backward flow may contribute to the initiation of endometriosis development. So the approach that I'm using to tackle this complex biology is mathematical modeling. When I say I'm using mathematical modeling, I mean I am using equations and computer simulations to understand how the uterus works in real life by building a virtual version of it. Mathematical modeling is useful to describe, analyze, and predict system dynamics. For example, it is similar to how weather forecasts work. Meteorologists do not test storms in real life. They use mathematical models to predict what might happen. So that is what I am doing, but for the uterus. So on the screen is an illustration of what my mathematical model looks like. We define each cell as individual entities called agents, and these cells have points that we call nodes, and these nodes are the interaction points between a cell and its neighboring cells. Connecting these nodes are what we call springs that stretch, shorten, and respond to change whenever these nodes move. To give a more clear visualization of what I am talking about, we will consider a 3-cell system where we fix the top and bottom nodes to remain stationary, and we apply artificial contraction to the middle cell. So this middle cell is responding to the artificial contraction by having its springs shorten, and the springs of its neighboring cells stretch in response to that contraction. And when it is time to relax, the springs of the middle cell and its neighboring cells return back to their original length. So this model shows the mechanical part of what I'm trying to achieve, to really capture how real uterine smooth muscle cells undergo contractions. I apply the biological processes using mathematics. So the biological processes behind uterine smooth muscle cells undergoing contractions are well known. It begins with a flux of calcium ions entering the cell, and these calcium ions then activate molecular processes that eventually lead to the activation of the cell's contractile mechanisms, actin and myosin, to interact and produce contractions. Translating these processes into mathematics, it was important that we capture 3 important dynamics. Firstly, the movement of the calcium ions going in and out of the cell. Secondly, how electrically charged that cell is and produces. And also, finally, the contraction generation that the cell produces. So that mathematical representation of the biological processes that uterine smooth muscle cells undergo when under contraction, we apply that to our model to the left. And this allows the cells in our model to the left to have their own mathematical definition of the excitation contraction dynamics that uterine smooth muscle cells experience when they are going under contraction. So our cells in our model can communicate with each other mechanically through the springs, but we also want them to communicate with each other electrically. So in real smooth muscle cells, there are small channels and doors that allow neighboring cells to communicate with each other, and this is called gap junctions. So we include a definition for gap junctions into our model to allow the electrical signals and contraction to spread throughout the cells. Hormones such as estrogen and progesterone can also influence uterine contractility. Estrogen is known for upregulating contractions, and progesterone is known for downregulating contractions. These hormones vary depending on the phase of the menstrual cycle, with different hormones dominating different phases, contributing to the roles of of the contractions during those phases. So for future work, I will include the roles of the hormones into my model. This is an ongoing work as I am still trying to develop the mathematical expressions for these hormones. I will use this model to investigate how dysfunctions in electrical propagation influence contraction dynamics such as strength, frequency, and direction. And I will also use the model to explore how the changes in these contraction dynamics may contribute to retrograde menstruation and how this relates back to endometriosis. So before I close off, I would like to share how I think my project can contribute to this year's theme, which is to strengthen health and solutions across Aotearoa and the Pacific. Firstly, it can transform complex biology into actionable prediction tools. It strengthens women's health research in Aotearoa and the Pacific. And lastly, it provides a safe and ethical way to understand how the uterus works and behaves in real life. I would like to thank my supervisors, Dr. Claire Miller and Professor Ellis Clark, for their continuous support and patience throughout this PhD journey. I would like to thank my research group, the Uterus Research Group at the Auckland Bioengineering Institute, and also my funding source, Aotearoa Foundation. I know that mathematics is not a very popular subject among Pacific youth, but it is a very powerful tool, especially when being applied to real-life situations. I guess the message that I was trying to get across from this presentation is that mathematicians do care about women's health. Mālō pito, thank you.
Thank you very much for that talk, man. I really enjoyed that. I really love that actin mass and calcium contraction relaxation. It's great. It's a great reminder of when we were at medical school learning about all this physiology, pathophysiology and everything. It's just great to, congratulations, and I wish you all the best for your studies. It's great to have some of our people, Mauri and Pasifika, entering into these spaces. I think it's really helpful for us. Now I would like to welcome our next speaker or speakers. We have Gerald Naipi and Associate Professor Siriana Naipi. Their talk is on a generation at risk, vaping, nicotine, and Pacific use. Please welcome Gerald and Associate Professor Siriana. Welcome.
Brilliant. That's a hard discussion to follow, but hopefully we can make it very interesting for you all. But no, thank you, Dr. Okanesi-Ngafa, for the introduction, and thank you for Te Poutoko Aroa Kiwa for having us today. We are very excited to be here. So my name is Gerald Naipi, just call me Jay. I don't know where Jay came from, but just call me Jay, please. And so I'm joined here by Associate Professor Siriana Naipi, and if you don't know, she is my wife hence the last name. And she's also my security blanket, so if anything, if we crash and burn, she'll pick up the pieces. But anyway, we are so excited to be here today, and it's so great to share this preliminary study with you. Apologies to the administration staff, we just got the sign-off on having this presented, risk management and everything like that. But today we're going to present our preliminary findings. We're not going to talk about our methods too much. The report is coming in the next couple months, and so if you want to dig into the dirty and critique our work, feel free to look at it and then give me an email and say it's terrible, but no, it won't be. Yeah, we're just going to do a preliminary high-level overview of our work, and yeah, let's get it going.
Yes, Nissan Bula Vinaka. This project in particular, we spoke to over 540 Pacific youth about their experiences and perceptions of vaping. It was co-designed. They were involved from conception to write-up. We look forward to publishing with them. We think that's an important part of lifting their voices. We asked them in the beginning, what do you want for Pacific youth and vaping in 5, 10, 15 years' time? And they were pretty clear. We would like a vape-free future. And then we asked them, okay, well, how do we make that happen? And so what they really wanted was to understand if their perception that vape stores were everywhere was true. So we said, oh, cool, let's do a geospatial analysis. And we spent some time with Pacific youth learning what that was and how to do it. And then they said, we want to know more about our experience outside of Tamaki. So we said, okay, we'll do a national survey. And some of them paired up with Jay to create that survey and send it out. And then, of course, they asked for talanoa. But really importantly, they asked us to also do kawa talanoa. And they were facilitated by Pacific Youth. And then they asked us for a social media campaign. And my researcher hat went, oh, I don't know if we want to have a social media campaign about vaping with Pacific youth. Can we make that a bit safer? So we opted for a private video diaries method.
Brilliant. So just an overview. So what we've found is that the research that we went into and the findings just reiterate to a stronger degree what we already know about Pacific youth and vaping. And so based on the ASHARE 10 survey, Pacific youth daily vaping rates are 32% higher than the national average. Our research actually reconsolidates that or strengthens that position, because what we found was that, and what Pacific youth see is that they see vape stores everywhere in their communities. There is this intense social pressure that they experience. There is an addiction that they kind of go through when they start engaging in vaping. And then there's almost no awareness of cessation support. So, you guys can come at me because, apparently in the government there is these things happening, but these are the voices of our Pacific youth, and they're saying these things. They don't have the tools and the access to information to help them through this journey of quitting vaping. And so what I want to, so these 6 numbers at the moment kind of show us what Pacific youth are dealing with at the moment. So what happens in this environment when they're exposed to a high level of vape stores, and that naturally trickles down to their social circles. They engage in vaping at such a high rate, and they start using nicotine, they start vaping at a high rate on an excessively daily basis. And then when they try and turn around after they engage with vaping and get hooked on vaping, they struggle to quit, and they struggle to find the support needed to help them through this journey. And so what we mentioned in the beginning is that Pacific Youth wanted to really consolidate their anecdotal information that they see in the community. So they go out and be like, I see vape stores everywhere, but that's an anecdotal thing. And so what we said was okay, how do we make that empirical? How do we draw that into the realm where they can say, yeah, what you can't not believe me because there's this evidence there that supports what I see on the daily. And so what we found is that high deprivation areas have 4 times higher vape stores. And as we know by the demographics within these, I don't want to say deprivation, I think that's a very terrible word. I prefer underserved areas. In these underserved areas, what we understand is that we have a high Pacific young population that are being exposed to vaping. And so what we found from our survey as well is that 45% of those 16 to 18-year-olds who vape bought their vapes directly from vape stores. And despite the fact that we have policy and legislation that is against that. And so, in a nutshell, our Pacific youth know how, where, and where to get vapes from.
I think really importantly is that while they exist in these environments where they're overexposed to vape stores, we know that they're being introduced by their friends and family members. And they all know someone who vapes. They regularly share their vapes with their friends. It's part of the process. Really importantly for us as a Pacific community is it's starting to integrate itself in our cultural practices. So one of the things that came through from the Kawa Taranoa is that they are using vapes as a chaser to the bowl. Those of you who participate in Taranoa, that's usually done with some candy. But our youth are starting to use flavoured vapes as a chaser. So it's becoming really interconnected with a cultural practice. And for us, I think that's quite concerning. It's no longer just a social practice. It's being embedded into our cultural practices too. I really want to asterisk this very carefully. So family have two purposes in this research. And one of the things that we know from this research was that Pacific youth were being exposed to vaping through their family. Some of them were finding it really difficult to quit because they would walk outside and there would be family vaping. And so our family do have a role in cementing that as a normalization process, right? But also, the part I want us to hold on to is that it was a really good protective factor too. Many chose to quit or wanted to quit or didn't start because they saw their family as a space where they wanted to do better by their family. They really wanted to make sure their siblings didn't start. They really wanted to do right by their parents. So whilst they are exposed to vaping with their family, we're also doing good things, is the takeaway there, I think.
Okay, so I'm just going to reiterate this point. So our Pacific youth, they experience vaping and vape stores. They see these vape stores in the areas that they live in. There's a social pressure that gets them into vaping. And then what happens is that when they get into vaping, they become hooked. And so these statistics are already in the beginning there. So 81% of our Pacific youth are vaping every day, and 93% of the vapers are using nicotine. And that's a crazy statistic when we consider this quote, which my daughter really wants us to read out verbatim. And so at the age of 12, I didn't even know what nicotine was. By the time I found out, it was too addicting. And so for me, that kind of reflects what is happening in our communities, whether we like it or not. And so it is quite interesting that a 12-year-old starts vaping, and they can start vaping and get hooked on vaping at 12, and they can do that for 4 years, and they're not even allowed to buy these vapes. And so what does that mean, right? Like what is happening and what is going on in the background? And so it's all this pressure that we think about, this environmental, the social pressure that they experience in the environments that they live in.
Just really quickly, one of the things we wanted to highlight was that whilst only 4% of those surveyed said that mental health was a reason for starting, in the Taranoa it became really clear that continuing to vape was tied to mental health. In particular, in one of the Kawa groups, they talked about how this was a logical response to the structural inequities that they face. They saw vaping as inevitable, as a way to deal with the structural inequities that Pacific peoples face. And the social scientist in me really, really thinks we should unpack that.
Okay, so pretty much, our kids are getting down this pathway. They're going through this uphill battle, as I like to say. They're fighting against this thing that they have no idea about and no information to help them on. And so they're fighting in this uphill battle where they go down this path, they really want to quit, but turning around and quitting is quite hard because they're hooked by this insidious thing that they don't know anything about. And I think that's what I want to reflect. Our Pacific youth are engaging in vaping, but they have no idea on what they're getting into. Sweet.
Really importantly, I guess the hopeful thing, and if you look at those stats, right, 72% want to quit, so we're good. They want out. And one of the things that became really clear about helping them quit was inspiring to aspire. They often talked about their future and how they didn't want vaping to be part of their future. They didn't want it to be part of their family, their community. And I think that's a really strong place to start from in policy. How do we create intergenerational inspire to aspire for our Pacific youth? Because they want out, and it's our role to kind of support them in that process.
Okay, so just from a recommendation standpoint, initially what we were thinking about was regulating licenses of vape stores in higher underserved areas. which we feel is like the most, has the biggest lever to pull. And I put it out to all those political people. It is an election year. You know, if you want to pick up that football, feel free to do that. We're happy to help. And the second one is education, so educating our younger population and intermediate around nicotine, and then linking that into their future aspirations. And so, like Seriana said, there is this protective factors that our families have. And so a lot of the information that we see from the surveys of people who don't vape, they say that it's health reasons, but also, you know, they have family that help them. And also those people who have stopped vaping, they say the same thing, say that family is a protective factor, despite the fact that they can also pose a risk. And then our last one is close the awareness gap. Yeah, don't come for me. I understand that there are campaigns out there, but this is what our community is saying, our Pacific youth are saying 2 minutes ago, thank you. Yeah, and they're saying that they just need more awareness of these campaigns. And so, yeah, I just kind of wanted to follow end on this quote, because I think that's another crazy quote. But yeah, I think overall our Pacific youth are experiencing this environmental pressure, the social pressure. Once they get down this journey of vaping, it's hard to turn around and go back. And you know, when you start at 12 and you're going through these things, who are you going to lean on for support? You know, it's hard to go to your parents and say, well, I started vaping when I was 12, right? But I think we really want that messaging to come to the fore, that the approach on vaping, there's urgency around it, and yeah, someone needs to approach it in an urgent way.
And I think my kind of final words on this is that 540 Pacific youth trusted us to tell their story, and we really want to push those of you in the room who have power and resourcing and potential to pick up their challenge and to create the future that they want. It's our responsibility as people who have access to power and resourcing to listen to them and to not go, oh cool, another study on how we don't do nicotine and we don't do vaping. Actually, how many times do our youth have to tell us we don't want this in our lives before we accept that challenge? Wanaka wakalevu.
Thank you very much, Jay and Seriana, for that very informative presentation. And you're absolutely right. I mean, I have a child that could grow up in a home that's no vaping or tobacco, but it's really struggling to give up. So I can totally understand. And we're really grateful for that research, and hopefully that will inform practice in the future. And yes, in South Auckland, there's so many vaping stores. And you know what the most incredible things? It's all owned by Indians, and our Pasifika people are buying it. It's amazing. But anyway, I better stop there. Our next talk is, I've been told by Eileen before I was very militant because I'm a clinician, you know, but so I try to make it less militant. So our next talk is by Megana Bandlamudi. I'm sorry if I didn't present your name correctly. And the title of your talk is around flavour regulation and youth appeal, the new New Zealand approach. Please welcome Megana to the podium. Thank you.
Kia ora, Talofa lava, and Mālō lelei, and warm greetings to everyone. My name is Megana Bandlamudi, and I am affiliated with the University of Auckland. I work in the field of public health with a research focus on non-communicable diseases. I'm here today to learn from and contribute to conversations that support the health and well-being of our Pasifika communities in Aotearoa and beyond. This presentation focuses on findings from a content analysis examining if Aotearoa vape stores were compliant with the New Zealand 2024 vape flavour regulations policy. This project was undertaken as part of a summer studentship program in collaboration with the Auckland Bioengineering Institute, allowing me the pleasure to work alongside Dr. Lucy Hardy, Cohen Radich, and Professor Jude McCool. I'd like to start off with a question, and When a young person sees a vape labelled strawberry ice cream or blue raz slush, are they thinking about the nicotine or simply something sweet or harmless? Because personally, as a young adult, I would be drawn to flavours like these because of how appealing they sound. For many young people, these products are not seen as nicotine delivery devices, but instead as something sweet, enjoyable, and seemingly harmless, which is exactly where the concern begins. Vaping is associated with adverse health effects, and emerging evidence suggests that it may increase the likelihood of subsequent tobacco smoking, alcohol use, asthma development, as well as a range of other negative health and environmental outcomes. Although vaping was introduced as a smoking cessation tool for adults, there has been an increasing uptake among young people. Globally, several jurisdictions have attempted to address vape appeal through flavour restrictions. For example, in the United States, California and Ohio have banned all flavoured vape products. In Australia, only tobacco, mint, and menthol flavours are permitted, while the Netherlands has taken a broader approach by restricting vape flavours and specifying permitted ingredients only. In the Pacific region, the Cook Islands have banned the sale and importation of imitated vape products, and Palau became the first nation to outlaw vapes in 2023. However, some nations have yet to introduce specific policies regulating vape products. Figures from the New Zealand Health Survey showed that the youth vaping has increased significantly in recent years. Daily vaping among 15 to 17-year-olds increased from 2.6% in 2019 to 13.6% in 2024. Among young adults aged 18 to 24, prevalence is even higher, reaching 23%, the highest of any age group. Together, these younger age groups now make up a substantial portion of daily vape users in Aotearoa. This study is of particular relevance to the Pasifika community, as despite strict legislation in the Pacific region, Pasifika people living in New Zealand are still disproportionately affected. Data from the Year 10 survey shows that regular vaping among Pasifika was 14.2% in 2025. Pasifika youth are around 1.5 times more likely to vape daily compared with non-Pasifika youth, highlighting a clear inequity affecting Pasifika communities. Further concerning findings come from the Asthma and Respiratory Foundation, whom found that among students who had vaped in the previous 7 days, 47% reported feeling addicted to vaping, while 48% said vaping was negatively affecting their health. In response to high rates of youth vaping, the New Zealand government introduced the New Zealand 2024 Vape Flavour Regulations Policy. This policy restricted the flavour names that retailers can use to market vape products to a list of 57 permitted words. Under these rules, flavour names can only include up to 2 approved terms, as long as you can see on the table over here. For example, a flavour like strawberry kiwi fruit would be allowed. However, names such as gummy bear or cotton candy would no longer be permitted. The aim of this policy was to reduce the appeal of vaping products to young people by preventing the use of highly attractive flavour names. This study evaluated whether the industry was actually adhering to the regulations implemented 9 months after they were enacted. So there were 3 aims of the study. First was to assess compliance of online vape retailers with flavour naming regulations. Second was to determine the proportion of total vape products that adhered to or violated the flavour naming restrictions. Third was to identify which flavour categories are most commonly marketed. We used a content analysis methods to assess online vape retailers in New Zealand. Data was extracted from across 22 popular online retailers with nearly 7,000 vape products included. So what did we find when we examined the market in detail? One key finding from the study was that the overall compliance with the regulations was low. Only 4 out of 22 retailers assessed were fully compliant with the flavour naming regulations. Across the total sample, more than a quarter of all flavoured vape products were found to breach the regulations. The vape companies appeared to adopt strategies to retain product while attempting to appear compliant. Some products used modified versions of previously restricted flavour names, such as blueberry raspberry, which has been renamed from blue ras lemonade, as you can see on the slide. Others included the abbreviation AKA, which also known as, indirectly retaining restricted names. Some examples included banana chocolate, aka monkey bar, or sweet blueberry, aka cotton candy. Using AKA preserves the association with the original restricted flavour. These findings suggest that the vape industry is actively adapting to the regulations by finding ways to preserve the appeal and recognisability of products while working around the intended restrictions. Another key finding is that many of the vape flavours remain highly appealing to young people, with over 80% of the marketed products classified as fruity or sweet. Although flavour naming is now restricted, the approved descriptor list still allows a substantial range of youth-orientated options, including 26 permitted fruity flavours and 7 sweet descriptors, which together enables up to 528 distinct sweet-leaning profiles. As a result, although product naming has been modified, the underlying sensory appeal of these products remains largely unchanged. For example, combinations such as vanilla custard, banana caramel, or berry mint are still legally available, suggesting that the regulations focused on naming alone may be insufficient to meaningfully reduce youth appeal. A third key finding is that the vape industry has responded strategically to regulatory changes by exploiting gaps that remain within the legislation. Although the Ministry of Health states that ice and other cooling descriptors are not recognised as flavours and therefore cannot be used in product naming, the term ice continues to appear in product marketing. The use of ice is particularly important as it signals a menthol-like cooling sensation that reduces the harshness of inhalation, making vaping potentially more appealing to new and younger users. Despite regulatory restrictions, retailers appear to recognise that continuing to market so-called ice products remain commercially advantageous. This suggests that the vaping industry is continuing to identify alternative ways to promote products that maintain strong youth appeal while operating around the intended restrictions of the legislation. When we consider these findings together, after reviewing nearly 7,000 products, it became clear that current policy does need strengthening. At present, the regulations primarily target product language, then other key drivers of youth appeal, such as sweet flavours themselves, colourful branding and packaging, and low prices that make vapes more accessible. In addition, the extensive list of permitted fruity and sweet descriptors allow for a considerable variation in flavour naming. This is largely due to the continued prominence of fruity terms, which enables the industry to market hundreds of youth-appealing combinations, while still remaining technically compliant with the naming rules. Further, while these regulations represent an important step, vape industry compliance remains lacking. The online retail environment complicates monitoring and enforcement, and as thousands of vape products are available online, making effective enforcement difficult and highlighting gaps in the implementation of these policies. Taken together, these factors suggest that the current approach may limit the effectiveness of the regulations in reducing youth appeal. This study highlights the opportunity for further refinement of the policy, which we suggest has made little impact in its current form. Changes could include mirroring approaches adopted in the jurisdictions such as California, where flavours have been banned, and the Netherlands, where only specified ingredients are permitted. However, such policies must be accompanied by strong enforcement measures, as limited resources currently constrain the ability to effectively monitor compliance and proactively address industry efforts to bypass regulations. Youth vaping in Aotearoa is not only a public health issue but also an equity issue disproportionately affecting Pasifika and Māori communities. Effective policy responses are needed to address both industry adaptation and challenges in policy implementation. The implementation of New Zealand's 2024 vape regulations represents an important step towards reducing the appeal of vaping. However, the findings of the study indicate that youth-appealing flavours, particularly fruity and sweet products, remain dominant in the market, alongside widespread non-compliance. This highlights the importance of active, well-resourced monitoring and enforcement of vape retailers, as well as the need for Aotearoa to move towards more meaningful and comprehensive restrictions on the formulation of sale of flavours that appeal to youth. Learning from these Aotearoa findings, this may be useful to countries in the Pasifika regions who are also looking to develop restrictions on vape products to protect youth. Me taki mate.
Thank you very much, Mayana. That's great research findings. And I think it's a very important topic. It was great. There were some people from New Zealand that came over to Niue and wanted to promote vaping so that they can stop taking cigarettes. But the government were very strong against it and they didn't accept it. So that was good on them because they didn't have the evidence at the time. So yeah, great research. Thank you very much for that. And now our final speaker for the afternoon, we're really great at keeping on time, is Dr. Tamison Taylor. And her talk, the title of her talk is Alcohol Use, Wellbeing and Intersectional Stress Among Pacific Rainbow and Young Adults in Aotearoa, New Zealand. Welcome, Tamison.
Talofa lava. I'm a Pacific health researcher working across different health fields at the University of Auckland and also for Pacific Perspectives at the moment. It's nice to see some familiar faces. Sometimes I only get to see people through Zoom, so it's nice to see people in real life. I'd like to say thank you to all the previous speakers, some really great topics. I enjoyed all of them and learnt a lot. So this study explores the role of alcohol in the lives and communities of our Pacific plus, Rainbow Plus young adults living in Aotearoa. So according to the 2023 New Zealand census, 4.3% of Pacific adults identify as Rainbow Plus. The term refers to a wide range of gender and sexuality identities, including LGBTQIA+ communities and Pacific-specific identities I've listed here across many different cultures. Yeah. Alcohol use is a major public health concern in Aotearoa, with disproportionate impacts for both Pacific communities and Rainbow Plus populations. Although Pacific adults are actually less likely to drink alcohol, hazardous drinking is substantially higher among those who do drink, particularly Pacific males and younger adults. There are no official disaggregated quantitative data on alcohol consumption among Pacific Rainbow Plus people in Aotearoa, New Zealand. And key national surveys, for example, you might know about the New Zealand Health Survey, present findings by ethnicity and by sexual or gender identity separately rather than considering these identities in combination. There are also few qualitative studies exploring Rainbow Plus young people's experiences. However, the Manalangi project was the first national study focused on the health and wellbeing needs of Pacific Rainbow Plus communities. Therefore, in building on the existing literature around the experiences and well-being of Pacific Rainbow Plus peoples, the aim of this study is to examine how Pacific Rainbow Plus young adults experience alcohol use within the intersecting context of cultural norms, heteronormativity, racialization, and minority stress. So we recruited 10 participants through peer-driven recruitment method, accessing our own community networks and using social media advertising. Talanoa interviews were conducted between November 2024 and October 2025. In terms of the participants we interviewed, the average age was 24.9. There were a variety of gender identities and ethnicities, the majority being Samoan, but also Tongan, Niuean, Fijian, and also Mauri. Most were born in Aotearoa, and most were actually quite highly educated with a tertiary qualification. Today, I'm presenting on 5 of the themes relevant to our study aims. So the slides I will be presenting will be the quotes from the participants. So you can, as I talk, you can read the quotes and get a feel for what they're saying. So if you want to come closer, because I noticed that the slides are quite small, feel free to move closer so you can enjoy reading the quotes as I speak. So participants remembered alcohol as a common part of family events like Christmas, weddings, church gatherings, Samoan to'ana'i. These memories were often positive, filled with laughter and dancing, but sometimes became uncomfortable when heavy drinking changed people's behaviours. Some participants linked alcohol to harm, including family instability, shame, and financial hardship. One participant described their parents separating, leading to an unsettled childhood and frequent moves, and this was due to one of their parents' alcohol addictions. These experiences made alcohol feel risky and shaped cautious attitudes later on in adulthood. Others had little exposure growing up, with parents who didn't drink or only drank socially, which led to more neutral or cautious views of alcohol from early on. Despite different childhood experiences, all participants began drinking in adolescence, shaped by curiosity, peers, and new freedoms. For some, drinking became linked with belonging and identity. One participant from an alcohol-free home first drank after moving overseas to go to university, where they connected with others who shared similar cultural and gender identities. They described meeting older whawhine students as being affirming and positive. Although these experiences were kept secret due to family expectations, due to the tension between identity, cultural, and religious values, drinking for many of the participants gradually became a regular habit as it became tied to social connection, this identity, and a sense of belonging. However, for a number of participants, hazardous alcohol use was also a result of coping with experiences of rejection, violence, and emotional distress within families. One described being physically punished after coming out, while another experienced ongoing abuse from family members, including extended family as well. For many, alcohol and sometimes marijuana became a way to cope, helping to numb distress and manage overwhelming emotions. At the same time, once through an initial identity exploration that participants generally described, drinking alcohol became mostly a way to connect with friends and maintain a sense of that belonging, while also coping with the pressures of early adulthood. These included the financial strains, insecure housing and employment, and uncertainty after finishing education. You see, this group, as you saw, was quite highly educated, but they'd just come out of their degrees and they had limited work experience. One participant described how employers overlooked recruiting Pacific Rainbow Plus people, which contributed to a sense of discrimination and further stress. We asked participants about the role of alcohol, advertising, and social media. Participants indicated how drinking is normalised through advertising and social media. However, Pacific Rainbow Plus identities are largely absent from alcohol advertising. Many said they didn't see themselves being represented at all. One participant noted a particular lack of Pacific lesbian visibility, reflecting this broader absence across mainstream media. Participants also pointed out the lack of strong public health messaging around alcohol, especially compared to anti-smoking or drug campaigns. In terms of accessing treatment for alcohol and mental health issues, which often went hand in hand, most participants said they would never go to a GP and wouldn't even recommend it to others. Instead, they relied on online information and trusted peers. They had concerns about being judged, and these were based often on past negative experiences that they had had. However, one participant actually trusted the health system due to working in healthcare as a healthcare assistant. They were able to advocate for themselves. And another bypassed the mainstream system by hiring a private life coach to deal with their mental health and alcohol issues. There were barriers to healthcare. These included, first of all, not actually knowing often that GPs could help with addiction or mental health issues. Cost was prohibitive, and there were cultural factors as well. For example, one participant explained that they avoided medical appointments altogether, reflecting habits from growing up in a large household where limited resources meant that others' needs came first. They talked about how maybe somebody else might need the appointment more than they did. Okay, so some key points. For many, alcohol use was linked to experiences of rejection, discrimination, and emotional distress, and became a way of coping with this and with various traumas. At the same time, alcohol played a dual role, helping people to connect socially while also relieving stress linked to particular life transitions and their intersectional identities. This is an area that has been previously underexplored. Participants also highlighted how drinking is normalised while Pacific Rainbow Plus identities remain largely invisible in advertising and health messaging. Alongside this, there are significant barriers to accessing safe and culturally affirming support. Overall, this highlights the need for broader structural change and more culturally responsive Rainbow Plus affirming health systems, although the specific improvements identified are beyond the scope of what I've presented here, but we did actually generate those recommendations. However, we've come to the end, lucky last. And I would just like to say thank you to our participants who were generous in giving us their time and their stories, and to the funders as well, and to also acknowledge the other co-authors or researchers in this study. You might know Associate Professor Patrick Thompson and Professor Vili Nossa. So, whawhatai tale lava.
Whawhatai lava Timmerson, and wow, we kept to time. So we have more than adequate time so that we can have some questions. I think we will start with Esita's question to Professor Payne, please. She was saying about the data that you presented, that you put all of us together, Tongans, Samoans, Niuean, Cook Island, but we'd like more specific data so that we can respond as a community, as a Tongan community or Samoan community or different Pacific communities to our issues that are important to us. Over to you. Is there a mic? Is there a roaming mic, or shall I?
This one, yeah.
So you. Yeah. Do you want to bring the mic over, please?
Kia ora, and thank you, and
Thank you for the question and for the chance to respond, because I appreciate the question and the challenge that you put to me, and the fact that I didn't present the breakdown of the different Pacific ethnicities in my presentation today. So I own that, and I thank you for the challenge. I think it is a challenge for research, and particularly data-based quantitative research, that we use these tools that are available to us, like a census question, to understand or collect information about ethnicity. And then we have these ways of practicing, which mean that sometimes we do condense groups down into these big, but actually very diverse and complex communities and social identities. So take the challenge as one for us as researchers, and then as policymakers and people who are involved in solution building, to remember the question and to try and find ways in which we can continue to present data for the different Pacific communities represented in our study. And the last thing I'll say about it, and again it's for researchers and particularly people who work in a space that I do, it's really important that we have sufficient numbers of Pacific people participating in our projects. Because if we continue to just have very small numbers of Samoan, Tongan, Niuean, Fijian people in our projects, we never have the power to break it down and present it back to you in the way that you're asking and demanding of us. So again, I put it back onto researchers, but also funders of research, government in our instance, to recognise the need of the community, and then to resource projects to do the hard work of recruiting and supporting and ensuring that your diverse experiences are represented in our projects. So yes, thank you for the question.
Thank you. I just want to ask a quick question. Sure. Because a significant proportion of our Pasifika people are now New Zealand born, number one. Significant proportion of them, probably I think about 40%, have now got 2 Pacific ethnicities. How do we respond to that data?
Yeah, great. Again, so in our study, when the young people were 12 years old, we presented, and I just had it up there briefly, we looked at the number of ethnicities that all of these young people are identifying, and it was 30%, about 1 in 3 children in our study identify with more than one ethnic or cultural group. So your data and what we're showing really confirms this hyper-diversity that is in our population. And again, I think if we want to represent that, if we want to get to the point when we can talk about perhaps the Tongan Samoan experience, or the Samoan Māori experience, again, we need to keep working hard to make sure our projects are big enough and diverse enough that we can get to that complex identity question.
Thank you. Thank you for that. Can I have any other questions for any of the speakers today? Please introduce yourself and then ask your question. Thank you very much.
Bula Vinaka, I'm Randalei Te Camok, and I'm really excited to be here today. It's really lovely to hear from all the amazing presentations. I think I've learned so much throughout this session. I actually have a question for Siriana and her awesome research, and also the vaping, studies that are coming through. I think they're on the rise, and I agree with you. Our young people are very clear about what they want for their futures. And I really like the design that you guys have around having the young people through the whole data collection phases and all those different types of data collection methods that you've used. I think there is something there around vaping being the lesser of the 2 evils with smoking. I think that's definitely a generational thing that unfortunately our young people are kind of having to pay the price for. And actually the other research around the smell, the smell is amazing, much better than smoking. So you can see how that impacts on young people and their sort of likelihood of picking it up. I have a question around what our young people are saying around how they might engage with the public health interventions or awareness campaigns, whether they have any ideas about, you know, what would work better for them. And I think also, given the proliferation of public health awareness campaigns everywhere, it can be quite confusing, the messaging around what you should do and what you shouldn't do and who actually the audience is. So I wondered whether young people had any insight there, and also around social media, where they brought up social media as a way, you know, for these things to look more popular, and whether that's part of the socialization of vaping that you've been talking about.
Vinaka for saying the quiet bit out loud, which is, you know, that our youth are paying the price for what we see as a smoking cessation device. So the survey presented that data, but in the Talanoa, it became really clear. It's really concerning when 70% can't name a program that's to help them quit vaping, even though I think it's 71% wanted to quit. And one of the things that became really clear in the conversations is that it needs to come from their peers. And I think in the data, they were saying that they're more willing to kind of listen to community leaders on these things. And the difficulty that we have is that we are running these campaigns, but they're not reaching them. And so we do have to think about how do we run these campaigns better so that Pacific youth see themselves and respond to it. The video method, initially they wanted it to be a social media campaign because they wanted to start a conversation amongst themselves about vaping. And they were really keen on this idea. And it was us that pulled back because we were like, well, one, the researcher in me knows that social media research is a bit dodgy, you never know who's responding. But B, it's not safe for our young people to engage. Like we had that, and this is our second vaping project. Our first vaping project, we talked to a wider part of the Pacific community, and you kind of saw parents' brains click that their kids might be vaping in their bedrooms during the talanoa. Like they're like, oh yeah, it smells nice. Oh yeah, they could do it in their room, and I would never know. And so for us, it was about keeping our young people safe in case they commented in social media. Even participating in these studies, we had to say, you know, the way we recruited had to be really careful so that our community knew that participation didn't mean they vaped. And so all of that's a really long way of saying that they have their own answers for how they would like to do this, but we have to kind of balance keeping them safe and meeting their demands. Did you have anything to add? Because you knew the data a bit more intimately.
Yeah, and just around your comments, no, vaping is not displacing smoking at the moment. So at the moment, since 2010, the reduction in smoking has actually plateaued off for Māori and Pacific. No, they don't go to the GP to get support for quit vaping. There's only a small fraction percentage, and a lot of them can't name the support, and a lot of them are leaning on their friends and their family for that support. And most of the support is around that emotional component. They need that emotional support, and they reach out to their friends and family for it. A lot of Pacific youth have shared their stories of engaging with counsellors. And so it is about that, it's about reaching youth in a way that they access support, but it's not punitive. They don't get punished for doing these things. And a lot of our research was around protecting the youth, and they have apprehension with engaging because they don't want their parents to find out. And essentially, how do we package that up into something that they will engage in? Well, we have to go back and ask them, and that's what we've done with so the way that we approach the research project is the way that you would approach any kind of program. And so, yeah, the solutions come from them.
Yeah, no, I appreciate that, because we've done some sexual health research and it's similar, where, you know, they want awareness, but also sensitivity around, you know, exposure and that sort of thing. So absolutely, you know, understand. Thank you. It's a great project.
Thank you, NJ and Siriana. Just one question from me. In your campaign, knowing that in the future, some of these young women who are currently vaping, we have no idea how much nicotine is actually in the vape. We will in the end have families in the future. Is there any proviso or as part of the campaign to also educate them that if they are planning on having a family, what the impact will be on the fetus in utero? a really important question.
Yeah, I think...
Sorry, I'm an obstetrician.
No, that's
I
a
can't
great
help
question.
it.
And 100%, I think part of the education around nicotine should be coupled with the impacts on their body in the future. And yeah, we haven't fleshed out what could potentially be, but 100%, you know, there is that potential there for it to come to the fore when you do these educational programs. And I remember when I was a kid in intermediate, they did the sexual health program. And so could we do that with, you know, nicotine? Yeah.
And that's what they asked for, right? They said, I don't want to vape because I think about my future. And so family is really important to us. So telling young Pacific women that this could have an impact on future family would probably be one way of talking to them about why this is not it's a hard balance. We don't want to shame them, but we also want them to understand the impact. And that's why we kind of framed it around inspire to aspire, that it's not actually about vaping. It's about how do you create the good future that you want. And then from that, they kind of go, actually, I don't want to vape. So it's less about don't vape and more about what future do you want and how do you get there? Because they come to it themselves, that vaping has no place in their future. And I think that's kind of that's the switch in messaging that's needed. Yeah, Vinaka for that question.
And maybe there needs to be more collaboration, I think, around also, you know, experts in those fields in the future for us, especially for us Pasifika, as we're increasing our workforce in those areas, also work collaboratively. It's because the education around that and the pathophysiology as a consequence of smoking, I think is really important. Sorry, I better stop there. But any other questions, please? I mean, we still have time. I think the time to come back here, we have about another 20 minutes, I think, or 10. Or 10 minutes, sorry.
Talofa lava, my name is Mauri lelei, and thank you to all of the presenters today. Really was truly captivated by everything that was shared today. I did have a question to Dr. Payne about the statistics that you showed around mental health for Pacific children and young people. When I saw that ages 8 and 12 had higher anxiety and depression symptoms than age 15, that was really jarring to me to see that, and I just wanted to understand a bit more around those that finding from you and how the symptoms of depression and anxiety, like what did you look at in particular for those age groups, and just to further my understanding of that stat. Thank you.
Kia ora. Thank you for the question. Were you jarred in a good way to see that the anxiety and depression rates look to have come down at 15?
I think it was more so that it was higher at the younger ages.
Yeah,
that was interesting to me.
Yeah. So I think that's a really great example of where, again, I think we would all do well picking up on the idea of collaboration, because in the literature there would be potential reasons why we might believe that anxiety and depression symptoms might be higher and lower in some groups, and why those symptoms may improve or change over time. But I think what we need to do is actually to be working with people who come from and understand the communities and the potential factors that may not currently be thought about or talked about in the literature. So if we think about some of the well-known sort of social epidemiology, the social structural factors that contribute to poor mental health, things like material hardship and poverty, discrimination and bullying, those are things that we know worsen mental health for young people. So there are opportunities for intervention. But I think if we're also wondering why mental health symptoms might improve or become more positive over time, then maybe we're thinking about the role of cultural connectedness, the strength of relationships surrounding particular groups of young people. For me, they're elements that, again, probably are known really well in spaces like this, but are absent from the academic literature. And if we don't work with the people who understand options for solutions, we'll just keep thinking about the same factors and drivers all the time. So it's a long way of saying Right now, we don't know why we're seeing the patterns that we do. We want to support and encourage and invite people to work with the data. Our team, we're responsible for looking after the whānau in the study, for collecting the data and producing some reports. But the data is actually available for any researchers, any policymakers, any community organisations who want to work with the data to come and use it. And I would love to see people, Pacific researchers and communities, come and work with the data so that we can actually answer directly your really good question about what's sitting behind that change in anxiety and depression that we can see just on the surface.
That's some research for you in the future. Please come and join, and I'm sure they're very happy for you to. Anyone else who has any questions? I do have some questions, but I'll give it to the audience to ask their questions first, please. Anyone else? Otherwise, I will ask mine to our mathematical model, Lata Paya. I'm really interested. I'm an obstetrician gynecologist. Endometriosis is actually impacting on our young Pasifika women. A lot of them don't understand the science behind it. It's great that you are, it was so wonderful to see that animation over there. That was amazing. It's really cool. If you can take that animation and use it on social media to educate our Pasifika people, and also develop culturally appropriate models would be really helpful as well. I'm just interested to know where to, from there to our clinical situation eventually, what is the real aim for that mathematical modelling?
No, that's a good question. I guess since I'm just a mathematician, I will
really
once I get all my findings and stuff like that, then I will hand it over to the engineers at our Bioengineering Institute, and hopefully they will collaborate with clinicians as well. There are some people in our research group that are trying to develop devices to detect endometriosis earlier. And I'm not sure how they're doing it, but but yeah.
Yeah, thank you. Anyone else? Oh, Jay.
I could just talk. So in your model for endometriosis, you mentioned calcium and the interaction of calcium on the actin myosin formats. How do you account for everything else that happens in the cell? Because I understand you've got to factor in the biochemical pathways, but also things like molecular pathways. Are you just isolating calcium and then the actin myosin activation, or is there like a metric or algorithm that you use to account for everything else that happens in the cell physiology?
Yeah, so I guess we're focusing on the mechanical part of this uterine smooth muscle cell contractions, which is the contraction generation. And from past mathematical models, they've known that calcium ions are just the main trigger for main trigger for leading to the activation of the contraction mechanisms. And so I am just using those mathematical models from literature that are just inputting calcium ions and then going directly to
I mean, like you said, it's like trying to predict the weather, isn't it? Whether that storm is going to go in and then go into category 1 or, degrade the category or lessen the category, I suppose. But it's really exciting. I didn't realize that, the pressure goes this way or that way or the other way. I had no idea that was happening, but it's really informative, all the science behind that. And then the theory around it, because we still don't know. What I'm really keen, though, and I know we haven't touched it here, is that more and more now we are going to start looking at herbal medicine and traditional medicine. We had our Ranscott College meeting last week. We had a Tongan in there, and she said that when there's a woman who has infertility, that she actually they do massaging to help with whatever it is, and so therefore, so I think that is something that is going to be in the future, but it'll be really interesting also, you know, doing all this mathematical modeling and then looking at that as well around, you know, if you massage or whatever our traditional medicine that was used previously that helped with infertility might help, whether it's pressure, whether it's reducing actomycin or reduction of estrogen or increase of progesterone. I have no idea, but it sounds very science now. I think we have one minute for one more question. So over to you.
The last but not the least. So thank you very much. I was captivated by Anilo's presentation on the digital health tools and AI in pregnancy. To say that of all the presentations that we have heard, thank you. It's obvious that the parents would not be the first source of information. The parents' advice would not even be sought, or the parents' information dashboard would not even be triggered. So the importance of having digital AI tools to be available so that at least while those youth say we want out, but need the information, but need the help to get the right information, that they at least they know where to get that right information, because this is one of the problems. They're online, but obviously the information they're receiving is probably not the best and the right advice. But here we are in this symposium with a lot of research data that would be helpful for them, and I would like that to be the way forward with digital health tools and AI to help our Pacific youth, because we know they're not going to the GP either. So the health system, while it is not reaching the Pacific people, again, even for our youth, they're not going there.
Okay, over to you, Mio, whether you'd like to respond, please.
Mālō, Dr. Ivy. I think it is important. The people that were invited to the focus group had pregnancies which their family were aware about, but I know that there are still a lot more where there's a lot of hidden pregnancies that we don't know, and that would be a good use case of having AI or a digital health tool which gives them accurate information. And for the participants, they still went to family as their source of information, and it's common for when you have a pregnancy that is known among families, that families still become the first source of information. Whereas if it's a pregnancy that is hidden, then that's where digital tools are often your first point of contact. Then it's the health professional. So I really think it is important. There is a place, but it shouldn't replace the clinicians. And clinicians also do rely on digital tools as well, especially because of the cognitive load. And it usually is just a tool to really check in and use as a second point if there's no one else around. And there are good use cases for people to, like recently we've been told, there was a podcast I was listening to where it can help people create questions you can ask your GP or your health professional. If you have a certain symptom, it can help you in those types of ways. But again, you need to have good command of English. You need to know how to write those prompts. You need to have the ability to access ChatGPT. So again, access becomes another problem for everybody. But in its simplest form, Google, that's the #1 search engine. It provides an AI sort of summary for people. Whatever is being searched on Google, that's often the first point before people start scrolling down into the other pages. So yeah, I don't know if that answered your question, Ivy, but yeah.
And just a quick question, Mio, around the midwives that are saying it's creating more work. Will they be assisted to how to use the tool effectively so that they don't find it as a burden, but just as helping? Because a lot of nurses and other doctors find it useful, but I can understand our midwifery. And
it goes back to how are the midwives using the tool? Because it is sort of like a transcriber, and then it does do a summary in your clinical notes, but legally as well, that's the only protection you have in a court of law if something happened to your patient. So as a quality check, midwives should take the time to go in and double check that everything that has been written in those notes has been an accurate reflection of the conversation you've had with people. I know I shared this with Dame Tawila, and she said it's sometimes difficult with a scribe because when you're writing down stuff physically, you are able to remember it even 10 years on. You remember the notes that were written, whereas if you're relying completely on a scribe, that pathway is missing. And often when you go back, then they go, oh, I don't remember that conversation. But every handwritten note, she does have some memory of what is written compared to using a scribe on its own. So again, those that rely on it can use it really well, but then others who still require that manual writing to then connect to their brain, then to have it stored in memory, that loop is missing. So I don't know what the next generation of clinicians will be like. They'll be good adopters of the technology, but then those that are still going through still, rely on that written ability to then keep it in. Yeah.
Thank you, Amir. It's quite tricky. What the AI is trying to do is mimic the human brain, but it doesn't. And so it goes through a shorter pathway. And so part of your brain that is used usually for process information that's bypassed. And so therefore you don't use it, you will lose it. And so I think that's something that we have to be very cognizant of, is that you don't use that. If we teach a lot of people not to use that part of your brain, you're going to lose it for all of us. And I think that's something that we have to be very aware of with AI. Great tool, but just be mindful of what it's going to do for us in the long term. On that note, I think we've just gone slightly over time, and I think we better stop there. But please give a hand of applause for everybody who presented today. That was amazing. Thank you so much, everyone.
One, two, three, 1, 2, 3. Pardon me, Madame, Monsieur, ladies and gentlemen. We're about to continue on with our last session of the day. So, kere kere, whamore more ala. If you can please find your seat. Once again, paging all passengers on ea te Poutoko ora akiwa. Please find your seats. We're about to take off. So now mai haere mai, Nisan Bula, welcome back. We're about to kick off very soon, so find your seat and maybe we'll give it uno le miniti, 1 more minute and then we will start. But thank you once again for being with us. What a day. Nice to see you, Mālō. Very good, very good. All right, I think that's us. Kia ora tātou, warm Pacific greetings and bonjour à tous. Ladies and gentlemen, we've now come to the final bit of our polokalama, of our porokaramu this afternoon. And without further ado, I'm delighted to invite a very, very special guest here with us. She has a very busy schedule watching Coronation Street and Shortland Street. But she gave that up to be with us this afternoon. Please join me in welcoming our next speaker, Dr. Karina Gray, who is the Director of Public Health at the New Zealand Ministry of Health. Mālō apito. I hope you're watching our show.
Always.
Nice to see you.
Talofa lava, Mālō lelei, Fakatalofa lahi atu, kia Orana, Mālō ni, Bula Vinaka, and very warm greetings to you all. Look, I know that it's a tough session. We've had a really, really long day. So just sit back and relax. I'd really like to say well done, everyone, for making it to the end of an absolutely fantastic day of Pacific insights and research. We've been so privileged to hear from a very diverse group of researchers, healthcare workers and policymakers, all of whom are so passionate about Pacific health. And how awesome is that? Thank you to all the speakers, poster presenters, and most of all the organising committee for putting this day together. As I listen to the presentations today and I look around the room at all your beautiful faces, I know the future of Pacific health is bright. And the future of Pacific health
and how we future-proof the Pacific health workforce is what I'd like to talk about today. As we've heard from other speakers, we live in a very rapidly changing world that seems to be dominated by technology and the fast-moving pace of AI. We're told that if we don't use AI, we're going to be left behind. And we're also told that AI is going to take all our jobs, doing things better and more efficiently than we could ever do. For young people thinking about future study and career options, this can be incredibly stressful. And it's not helped by headlines such as this one from The Guardian in January, which reported on a presentation given by Kristalina Georgieva, the head of the International Monetary Fund. According to Georgieva, AI will be like a tsunami hitting the labour market with young people most affected. IMF's research suggests that the future will see a big transformation in demand for skills, and it predicts that over the next few years, in advanced economies, 60% of jobs will be affected by AI. And Georgieva warns that AI will wipe out many roles traditionally taken up by younger workers, making it much harder for young people searching for jobs to find a good placement. In youthful populations like Pacific peoples, this can lead to uncertainty and disruption, with many people asking themselves, what are the skills that they need in the age of AI? The health sector, including the Pacific health sector, has not been particularly explicit about the skills and attributes that we should be developing, promoting, and cultivating in our health workforce to ensure that we can thrive in this rapidly evolving environment. But based on my experience, I believe that there are 4 specific human attributes that can't and won't be directly replaced by AI and will be important to ensure we future-proof the health system. And these characteristics include being curious, adaptable, resilient, and emotionally attuned. And very helpfully, they form the acronym CARE. And watching all the presentations today, it's really clear that these characteristics are in abundance in the Pacific health and research workforce. So the first characteristic is curious, and this is the characteristic that I'll spend the most time on because I think it's so important and often misinterpreted. We want a health workforce that is genuinely curious, that engages in critical thinking, can analyse and interpret data in different ways, and understands that there can be many different perspectives, including perspectives and lived experiences that have historically been ignored, marginalised, or disregarded. AI can be great for organising concepts into manageable frameworks, but there is a danger, and I heard people speaking about it in the last session, that if we use it too much, we start to completely outsource our thinking, and we become too reliant on AI to form judgments and potentially weaken our ability to think critically, question assumptions, and advocate for equity. Being able to understand the veracity of different data sources and distill complex concepts into a clear structure is a real skill that we need to continue developing in our health workforce. There's a lot of data in the health system, so much so that sometimes it can feel overwhelming. But what is often lacking is data that is meaningful and inspires action. So this picture on the right shows how data is completely meaningless until it is sorted, analysed, and interpreted in a way that makes sense. Data and statistics are useful, but what is it that motivates us to take action? It's the stories that people can relate to, stories of real people, families, and communities that experience challenges and enact their own solutions. We can use these stories to give us insights into not only what is happening, but why it is happening and how we should address it. This is where humans have a distinct advantage over AI. We can ensure that the right people are involved in data interpretation and storytelling. And for Pacific Health, the most appropriate people are those represented by the data, Pacific peoples, families, and communities. Data can also help us understand trends and changes over time, including what might happen in the future and the long-term impact of our current actions. This means we need to ask ourselves, who is in the population we serve? What are their health needs? What are the other factors that might be impacting population health? And what services and programs are effective? And then crucially, what does the data say about how the population and their health needs are changing over time? And what might this mean for future planning? So according to the 2023 census, there are around 450,000 Pacific peoples in New Zealand, comprising around 9% of the total population. Between 2018 and 2023, the Pacific population grew by 17%. That's around 2.5 times faster than the overall New Zealand population over the same period. And this increase was driven by two main factors: our young age structure and high fertility rates, and net migration from Pacific countries. So fertility rate is the average number of children born to a woman over her lifetime, and how this changes over time is an important driver of population growth and the age structure of our population. Globally, the total fertility rate was 2.3 children per woman in 2023, and this is much lower than in the past. In the 1950s, it was more than twice as high at 4.9. This graph here shows how New Zealand's fertility rate compared with other similar countries in 2023. So at that time, our fertility rate was 1.6 births per woman, but this year it dropped further to 1.55. So in 2023, our fertility rate was higher than Australia, which was 1.64, the US, which was 1.62, the UK, 1.56, and Canada, 1.35. Japan, China, and South Korea have very low fertility rates. Japan at 1.21 and China at 1. South Korea has the lowest fertility rate in the world, where each woman has on average 0.72 births. To put this in context, a total fertility rate of 2.1 is considered the replacement level. This is the level we need to keep the population to stay roughly the same size without migration. So the population of South Korea is currently 51 million. In about 100 years, if current fertility rates are anything to go by, experts estimate that the population could be as low as 11 million. This means that these countries depend on net migration for population growth to be able to sustain a young and productive workforce. So by contrast, if we compare New Zealand to other Pacific islands, we can see that most of our close Pacific neighbours all have fertility rates at or above the replacement threshold. Samoa has the highest, with 3.83 births per woman, followed by Tuvalu at 3.21, Tonga at 3.13, Tokelau at 2.61, Niue at 2.51, Fiji at 2.28, and the Cook Islands at just above 2. So unsurprisingly, if we break down fertility rates by ethnic group in New Zealand, Pacific and Māori women have the highest birth rates at around 2, compared to Europeans at 1.56 and Asians at 1.3. However, what this table shows is that fertility rates have dramatically decreased over the last 10 years in all ethnic groups. And although the reasons are likely to be complex, many experts point to the high costs of raising children, rising house prices, and greater economic uncertainty as important reasons for people deciding to have fewer children or deciding not to have children at all. So at the same time, New Zealand, like most other developed countries, is experiencing overall population ageing. And this graph from Professor Michael Cameron shows how the age distribution of New Zealand's population has changed over time. And the number of people aged 65 and older is shown by the lightest shade of green. So in 1996, only about 12% of New Zealand's population was aged 65 or older. In 2023, this had increased to 17%. According to Stats New Zealand, by 2028, 20% of the population will be 65 and older, and by 2050, this percentage will have increased to 25%. So 1 in 4 people in our population are going to be 65 and older. This graph here shows the number of people by broad ethnic group and age in 2023. So this total population is shown by that light blue line, Europeans by the yellow line, Asians by the navy blue line, Māori by red, and Pacific peoples in green. So the key takeaway from this graph is that if you look at the people aged over 65, the majority of people aged over 65 are European. And so what this means is that in the working age population, it's much more diverse. So we've got a larger proportion of Asian, Māori, and Pacific peoples in the working age population, which are generally supporting a European ageing population. So if you look at the current median age of the European population, it's 42, it's 34 for Asians, 27 for Māori, and 25 for Pacific peoples. Māori currently make up about 17% of the total population, but 28% of the population younger than 15. Similarly, Pacific peoples make up 9% of the total population, but 15% of all children, and these proportions are set to grow. This means that now and in the future, a growing proportion of our working age population will be Māori or Pacific, and that workforce will be supporting an increasing number of people over the age of 65. So another reason that our population is ageing, apart from our declining fertility rates, is because life expectancy is increasing, which is a great thing. However, life expectancy differs significantly and inequitably by ethnicity. And this graph, which is published by Te Whatu Ora in 2024, shows how life expectancy varies across different groups. So Asians, Europeans, and people living in the most affluent suburbs in New Zealand, that's New Zealand DEP Quintile 1, experience the highest life expectancy, whereas Māori, Pacific peoples, and people living in neighbourhoods experiencing high levels of socioeconomic deprivation, that's Quintile 5, experience the lowest life expectancy. But we know that these differences are not inevitable, but are the consequence of environments that shape our exposure to risk and our differential access to services, health-promoting opportunities, and protective factors across the life course. So we need to address these differences to ensure everyone in our future workforce, including our growing cohort of Māori and Pacific young people, are as healthy as they can be. So I'm not sure if you've seen a graph like this before, but you will have heard of the NZ DEP Index, which is a measure of the socioeconomic status of different neighbourhoods in New Zealand, and each neighbourhood is given a score from 1 to 5 based on various measures such as the level of unemployment in the neighbourhood, the number of people receiving a benefit, or with access to the internet or a car. And this graph shows the percentage of people by ethnicity in each of those quintiles. So quintile 1 is the most affluent, and that's in light blue, all the way up to quintile 5, which is in purple. And that's the kind of neighbourhoods that experience the most socioeconomic challenges. So as you can see from the graph, compared to non-Māori, non-Pacific people, Māori and Pacific peoples disproportionately live in neighbourhoods that experience challenging socioeconomic circumstances. And research has shown that people living in these neighbourhoods often don't have equitable access to good quality housing or safe spaces to walk and exercise. Conversely, they're often exposed to more environmental stresses, more pollution, excessive noise, and crime. And these environments are not conducive to good health. So this graph here is from the Geospatial Research Institute and shows how the number of vape stores significantly differs by neighbourhood socioeconomic deprivation. So it's unsurprising that the uptake of vaping over recent years has disproportionately affected communities experiencing the most socioeconomic challenges. And we see this kind of socioeconomic patterning in terms of the availability of unhealthy food outlets, alcohol, and gambling establishments. So for those of us working in health, this means we have to continue to widen our lens to look at factors that are traditionally seen as outside the health system, but that significantly impact people's health and well-being. And we need to work collaboratively with other sectors on ways to address the underlying determinants of health. So this means we have to be adaptable. We have to be flexible in our thinking and responsive to our changing environment. And in the words of Charles Darwin, you don't have to be the strongest, you don't have to be the most intelligent. To survive, you have to be the most adaptable to change. And we've seen this adaptability in populations across the Pacific as we battle with the impacts of climate change. And I acknowledge Liam and I and our esteemed panel from this morning and all the other experts in the room on climate change. So in New Zealand, climate change is affecting our health system by increasing demand for healthcare due to the impacts of heat-related illness and death, injuries due to severe weather events, changing patterns of infectious and vector-borne diseases, including dengue, which has really significantly impacted our Pacific neighbours over the last year, increases in air pollution and changes in our food supply. We're also seeing increasingly frequent severe weather events which disrupt our access and continuity of services, threaten our infrastructure and intensify our workforce pressures. During Cyclone Gabrielle in 2023, for example, flooding, landslides and bridge failures cut off entire communities in Tairāwhiti, Hawke's Bay, Northland, the Coromandel and parts of Auckland, preventing people from accessing care. And some regions remained isolated for weeks, and rural and remote areas were disproportionately affected. So these considerations are included in the Health National Adaptation Plan, which was jointly developed by the Ministry of Health and Te Whatu Ora in 2024. The plan supports the health system to adapt to climate-related risks, strengthening the system's ability to respond to climate-driven impacts. A consequence of adapting appropriately to our changing environment is that we become more resilient to shocks or setbacks. This means that we need to actively plan for uncertainty. And in the health system, this looks like risk assessment and horizon scanning, emergency preparedness and response planning, and ensuring that we have a diverse workforce that represents the population it serves. So you might have seen this table from last year. I think I used it at last year's symposium. But the table basically shows the number of Pacific people in various parts of the workforce, the percentage of that workforce that is Pacific, and the forecasted percentage of that workforce that will be Pacific in 10 years' time. So we have around 3,000 Pacific nurses, which make up about 5% of the nursing workforce, 500 doctors that make up about 3% of the medical workforce, around 100 midwives and pharmacists, which make up about 3% of the workforces, but only 83 psychologists and 49 dentists. So if you remember that Pacific peoples comprise around 9% of the total population, none of these workforces are yet to achieve population representation, and these forecasts suggest that this won't even be the case in 10 years' time. So that's why workforce initiatives such as those led by the Universities of Auckland and Otago and other institutions to increase Pacific representation are so important. It will not only lead to a more resilient Pacific workforce, but a more resilient healthcare workforce overall that can adapt and respond to the health needs of our changing population. And that brings me to my last attribute, being emotionally attuned. And this is probably the most obvious skill that AI will never beat us at. Being emotionally attuned means being people-centred, communicating well with all our key stakeholders and working collaboratively with each other, with communities and with other sectors. And an important way we can ensure our system remains resilient is by building and maintaining genuine, meaningful and enduring relationships with the diverse communities we serve across Aotearoa. To do this, we need a workforce that is representative of the population, and that's not only in terms of ethnicity, but also in terms of other characteristics such as gender, disability, and socioeconomic background. We need to recognise and build on the inherent strengths and human capital within communities, and we need to support communities with resources to address the issues that concern them most. And we need to do all this before the next crisis or emergency. During the COVID response and the recent weather events, we saw some amazing examples of community-led responses, such as community and church-based food distribution and welfare hubs and vaccination initiatives, which were driven by local community groups. So a curious, adaptable, resilient and emotionally attuned health system will learn from and build on these successes. And this is the way we can not only survive, but thrive in this rapidly changing world. Whaftaitele lava.
Dr. Karina. It's just VHS tapes of one of Pasifika games. Too soon. Mālō, but the VHS for the young people is what us old people used to watch media back in the day. And now you have USB, KFC, and 1, 2, 3. Wonderful people. We have now come to our final speaker for the day. Can I please invite back Mā Kapisinga from Le Mole Mai, Professor Sir Colin Tukitonga, for his closing remarks. Mālō, Pito.
I thought if you weren't a broadcaster in the morning, I thought you could have been a whaiwhao in your next career.
Let us pray again.
No, I'm not inviting you to do that. But actually, I think a better thing might be a comedian. Thank you, JP. Look, I won't keep you. I need to do two things. One is to say thank you to all of you who have come and stayed, and there may still be people online. So thank you for your attendance and participation. I also want to thank in particular our speakers. Dr. Eileen Tan was last minute fill-in because we had someone else who had a better offer. And so Eileen, thank you for coming across from Sydney. I thought you did a fantastic job setting the scene. We wanted today to focus on the possibility that we might actually eliminate cervical cancer, an important cancer for all women, but particularly Pacific women. And Metua, you remember the National Cervical Screening Program, all that carry on, and I'm not sure if it was all that impactful. So thank you, Eileen, for coming and safe trip home. Robin Whitaker, I learned something, and I wasn't sure whether to be scared or ecstatic about AI. My son, who's 16, says that I'm a dinosaur. I can't sort out all the gadgets, so I have to rely on him. But I did say to Robin that she's just found herself additional work, because we're going to invite her to do a session on AI in health and healthcare across the Pacific. Poutoko, one of the things we do is we work with our colleagues and friends in the Pacific on different things related to cancer. So I think, Robin, you'll be in demand for a while. And of course, the panel, Bev Lawton, Eileen again, Cara, Jude, and Audrey for that session on eliminating cervical cancer. Rowanne, thanks for doing all the work and allowing me to take all the glory on the Academy and the work we're doing there, and of course your work in the climate crisis and implications for well-being. Ituini, Denzel, and Sam, and of course facilitated by Maima on mental health. On mental health, I think it's very important that we don't simply transpose Western conventional understandings of mental health disorders in the region, and we do work better. There are amazing concurrent sessions. I said in the morning that I think we were being ambitious, having 8 Pacific speakers in a session. But amazingly, at least in our case, we finished ahead of time. So I'm sorry to the speakers. We did push you a little bit, but thank you nonetheless. And of course, Karina, thank you for all the work that you do, and again, the presentation today. So let me just finish off by announcing our Poutoko Honorary Senior Fellows, Research Fellows, who have agreed to work for us at no pay. So if you fancy being a Poutoko Fellow, let us know if you're prepared to work hard for no pay. And are we okay, team? So here we are. Recognition of some people who are still here. Meto Bates, who's come to us from Rara, currently Director of Public Health at Te Marae Ora in the Cook Islands, a respected public health leader, years and years of service across here in Aotearoa, but obviously now at home and across the region. So a clap for me too. We also have Lucy Castles. Lucy is here. Lucy is an experienced global health policy specialist and former diplomat. I thought once you're a diplomat, you're always a diplomat. You're not allowed to be naughty or do silly things like me. Expert in climate change, global health diplomacy, and Pacific focus policy development. Congratulations. Lucy, and Tevita Funaki, NZM, Chief Executive of the Whono, and doing fantastic work there, and honoured for his services to Cervical wellbeing recently. Mālō. Some other folk who are not here. Professor Donald Wilson, who is at FNU, a regular contributor to our work, and in fact a member of our governing council, Dr. Donald Wilson. Dr. C, he's Pacific. Despite the name, he's been around a long time, does wonderful work in the region, currently Deputy Director of Public Health at the Pacific Community. A great friend of ours. And Dr. Siale Akawola, for the longest time Director General of Health in Tonga, briefly Minister of Health, and still with the ministry as I understand it, and a wonderful supporter of our work. And Basil Leodoro in Vanuatu, he's a general surgeon, currently medical director of Helper, a boat that travels around to help in emergencies, but I think started life as a general surgeon. So that's the team. So if you're thinking, how do I get to be a fellow? Get in touch, be prepared to work hard for no pay. Tremendous day, everyone. Fantastic. So give yourselves all a clap. As I say, we're working on the formula for these things, but your attendance and participation and so on, I think we're on the right track. So if you see some things that weren't so great, let us know and we'll try and fix it. Thank you all.
Maururu me taki atu paka e nā atawai wolo. Mālō apito. Whakawelahi mahaki. Thank you very much, Professor Sir Colin Tukui Tonga. Beautiful people, we've come to the end of our journey. Please get ready to evacuate. But before that, I'd also just like to add, it's been wonderful to be here. Thank you very much. I'm glad all the other really good MCs were busy today, so that's why they've lowered their expectations and asked me to come back. But I've thoroughly enjoyed the sessions. I feel like I'm qualified now to be a doctor. People have studied many years, and I've just sat in here and listened, and now I'm qualified from the University of Temu, where all my credentials are from. Thank you once again for being with us. I would like to please send the apologies of Pope Leo XIV. He couldn't make it to do the closing prayer. He was very busy watching the FIFA World Cup. But we've got someone on the same par level as Pope Leo. We've got Fiungalu, Tevita Funaki, who's going to close us off. We also like the element of surprise as well. His heart rate, I will check after this because it's also still Men's Health Month or week. So, Fiungalu whamole if you can do our lotu tāpuni. Mālō apito, ofalahi atu to you all. Arrivederci. Vinaka.
Thank you, JP. I hope I get paid for this, or at least get a green basket for it. Thank you. Let us pray. E lelei mau tamai whaiwana whiona. Mau toi ununu mai he whiafkoni, tuga te whawhetai wha Mālō ke whina koe kaua whiona. He tataki e polo kalama maho inga ākoini eiki. Whawhetai eiki, ma kore ngahi whakaamu, ngahi whotūtū. Ākoini eiki, whaitau pekina bimbi a whiona. Lord, we're just grateful for the opportunity again to come together and say thank you for being with us today. We thank you for leading us, giving us wisdom in our discussions in Talanoa today. We continue to ask you, Lord, for your blessing on the wishes of today. Continue to bless it from above. Traveling mercy to take us safely to our next engagement. We ask this through your Son, Lord Jesus Christ. Amen. Mālō.
All right, I think if I take a group, if you don't mind my Facebook page photos, please come to the front. I just need to show my probation officer that I do some work for my community. So kere aloha mai. If we can have people come to the, yes, getting paid? Well, I hope so, yeah. So please, if you can come forward, our esteemed guests to have a seat here, and then everyone come around, and we're going to have a big group photo so I can put it towards my immigration application to remain here in New Zealand. So if you don't mind being in this photo, come forward. We're going to take a big group photograph of everyone that's here. Nice. 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 Yes. Oh, yes, good. Get the individual photographs. Good idea. Good. Yeah, yeah. Oh. Do not leave. Yes. So if you're available and are keen to be part of this photograph for my immigration application, can you please come forward? We're going to take a big group photograph. Aere mai, yes, aere mai, kere kere, toso.
A set off the train.
A set. So follow, please, come with me if you want to leave. My uncle Arnold. Come with me if you want to leave. Mālō.
Thank you so much. So lovely to meet you.
Mālō.
Not just hear the voice on the Facebook.
Yes, sir. I'll be AI soon. So I'm going to be artificial. Yes. Here you. Nice. Don't lean on the. Yeah, don't lean on the tapa. There is no wall behind that.
My husband at the bank, he was procurement type things, and then we had to do some research and evaluation.
Sorry.
I just got that because I thought there was my monthly stuff.
Okay, item mate.
So we managed to consult.
Yes, the mat is also available for $1.95 a day. Good. Yes. Oh, there we go. You come forward. Come on. Jump in. Yes. Yes. I think that's everyone, eh? Okay. There we go. Oh, that wasn't me. I apologize. Thank you, guys. Marlon, you still going to Ants, the team, to get your haircut there?
Oh, not for ages
Yeah.
now. Yeah, I moved out west this way.
How dare you?
I know.
You've lowered
I've
your
lowered
expectations.
My severe downgrade.
Yes, I know. Good on you.
So I haven't seen him for ages. But he's cutting it.
He does Matt Roscoe,
Yeah.
Poutoko with Fitness Plus.
Yeah.
So it's good he's found a spot in the gyms. And
Yeah. Matt Roscoe's a bit out of the way for me. But this is like,
how far west?
Newland.
Oh gosh, you'll have to fly there.
It's
that's
so
a
quite
nice
essential.
area.
It is nice, yeah. But you know, when you're from Heartsea Southside like I am, this is like foreign territory.
Look, there are times you have to make big decisions. You must leave the nest to grow and then come back.
Right.
And where are you based for work?
Sit here. Yeah.
Good on you. You still come back and forth?
Yep. So I'm in the School of Psychology. Yeah, but yeah, I would much rather be in the School of Arts.
I went last year for my second trip. Oh, I just fell in love with the place. And I live in dating a girl who was based there. She's Tongan though, but she's moved back and I'm like, good. Follow me. And Jesus, follow Jesus.
Always.
No, but it was good. Oh, good to see you. We're off out here. Yeah, that's right. I'll jump in here and then I'll come in there. Wait till we get the inputs We're very blessed.